Thank you.
Thank you, Professor Pant. I would like to please ask you to take a seat on the right side of the stage. Please. On the right side of the stage, sir, please. Sir, your thought-provoking lecture has definitely given us new insights into the molecular advancements in the diagnosis of CNS tumors. It is lovely to have you. Moving forward, to keep up with the tight schedule, I would like to request all the speakers to please mind the time limit. To help with that, we will be ringing a bell 5 minutes and 2 minutes prior to the time limit. Now, it is truly an honor to welcome our next guest on stage, the keynote speaker for the morning session, Professor Dr. Anurag Mehta, who is the Director, Department of Laboratory and Transfusion Services, Director, Research, Rajiv Gandhi Cancer Institute and Research Center, New Delhi, India. He is also the Editor-in-Chief of Journal of Current Oncology with specialization in molecular diagnostics, lymph node pathology, pulmonary pathology, and colorectal pathology. Please, sir. Ladies and gentlemen, let's welcome Professor Dr. Anurag Mehta.
Good morning, all, and thank you for your very kind introduction. I am honored. And I love to come to Kathmandu. I have many friends here, and I feel some sense of a special affiliation to this place. And today I will speak to you on next generation sequencing, meeting the expanding needs of molecular diagnosis. Can I get this slide mover, please? This is forward. This is forward. So with the emergence of precision medicine, the role of molecular diagnosis has become irrefutable and vital. There are several tools for molecular diagnosis. But the next generation sequencing stands out. And I'll explain to you, or I'll try to explain to you why. I will also try to explain to you what is next generation sequencing, the quality management and interpretation, and I will share with you the current usages in clinic by illustrating with many examples. So this is how we learned our medicine in medical college, and this is how we have been practicing medicine till now. We listen to the symptoms of the patient, we take a good history, we carry out a good physical examination, and we couple this information with imaging and labs. We make a diagnosis, and then we administer therapy. And this therapy is meant for an average patient. It benefits some, it does not benefit many, and some suffer adverse effects because of the altered pharmacogenomics, what in past we used to call as idiosyncratic reactions. Take for example, 38% of patients receiving antidepressants don't benefit from it. 50% of the patients receiving anti-arthritic drugs don't have pain relief or functional recovery. 75% of the patients receiving cytotoxic therapy do not benefit from it. And if I take this to the extreme, where in case of a ER/PR positive breast cancer, only 5% of the patients receiving chemotherapy are benefited from it. So this model is inefficient. This leaves many patients no better for treatment, and they become resentful of medical services. It often generates a lousy press, dissatisfied patients, and angry relatives. And as Dr. Pant said, you get accosted by patients' relative, and sometimes you get assaulted by them. So a change is required. And this change has started emerging in the form of precision medicine, where whatever we do in a conventional fashion, we data layer it with panomics. We can data layer it with exposomics, genomics, transcriptomics, microbiomics, epigenomics, epidemiological detail. You use this for analysis through information commons, and then we convert each patient's disease into a unique disease with unique attributes with likelihood of being treated in a unique fashion. And we have actually entered into this arena of precision medicine in last about 15 years. We are still in the very embryonic stage. We use the barest minimum of genomic data and the barest minimum of transcriptomic data, and yet we have identified very astounding results using that little bit of precision medicine. Take, for example, the case of lung carcinoma. And lung carcinoma can be divided into 17 or 18 diseases based upon the genomic and transcriptomic data. And now we'll look at this survival. When the patients are treated by genome-directed therapy, the median overall survival, which 15 years back was 8 to 10 months, in some instances can now be 7.5 years to 8 years. Imagine somebody who was to live for 7 to 8 months can now live up to 8 years by genome-directed therapy. And this is just the beginning of precision medicine. And this is how we are trying to realize the objectives of our celebrated predecessors: treat the individual, don't treat the disease. And the precision medicine will offer us that opportunity to treat the individuals rather than treat the disease. And to treat and use the precision medicines, we need some molecular data. So we need genomic data, transcriptomic data, epigenomic data, and microbiomic data. And to obtain these data, we can use many molecular techniques. We can use fluorescence in situ hybridization, and with that we can find out HER2 amplification, MET amplification. We can find the EWSR, L-cross, RET, NTRK fusion rearrangements. We can use genomic IHC, which Dr. Pant had referred to. We can find out MMR protein deficiency, BRAF V600E, the histone modified protein, ALK overexpression, etc. We can do real-time PCRs. And if we use those real-time PCRs like amplification refractory mutation system or a peptide nucleic acid clamps, we can actually reach the limit of detection of 1%. That means we can find 10 mutant alleles out with 990 wild alleles. And if we use even the more finer form of PCR, that is the droplet digital PCR or a digital PCR, we can take this limit of detection to 0.5%. That means we can find 5 mutant allele amongst 995 wild alleles. And then we can have Sanger sequencing and Pyro sequencing with much higher limit of detections of 10 or 15% and 5% respectively. But using the many molecular techniques is fraught with some challenges and with some barriers. The first is the uncertainty about the best method. Which is the best method? There are no clear guidelines. And how do you find the analytical validity of one over the other when you don't have gold standard to compare with? There are too many techniques and too many platforms. That means for each technique we will need specialized manpower, specialized equipment, and that will mean high capital cost. And if you are actually testing for more than 20 targets, then these kind of single gene assays will turn out to be costly than next generation sequencing. And these single gene assays are not tissue proficient. They are not tissue friendly. You will require too much of input DNA, or you will require too many sections. The turnaround time for initial lab, when you are doing 1 or 2 biomarker tests, then it is all right. But for the second lab, third lab, fourth lab of biomarker testing using single gene assays, the turnaround time will get longer, and there is no potential for discovery. You just continue to do what you have been taught to do. and there is no scalability. So take, for example, any case of cancer. This is the number of tissue sections that you will need. And remember now, 73% drugs in the oncology pipelines will have an associated biomarker. So the list of biomarkers that you will need to test is going to be enormous. And therefore, the current practice of doing single gene assays will not be sustainable in future. It is not tenable. And therefore, we will have to move forwards with the concept of one patient, one test. And there are 3 platforms which can be used to meet that concept of one patient, one test. The first is the mass array, which is based upon mass spectroscopy, MELD-TOF. It can find up to 240 mutations by multiplexing into 24 tubes. We can do snapshotting, that is primer extension by one base, and by doing this, you can find up to 50 mutations. And next is the next generation sequencing, where you can do DNA sequencing, RNA sequencing, methylation profiling, and various other microbiomic, methylomic studies, etc. And the best thing about using next generation sequencing is you can identify all classes of genetic alterations. It can look 360 degrees, from single nucleotide variant to fusions, to copy number gains, to gene expression profiling. Everything can be done through next generation sequencing. So what is sequencing and what is next generation sequencing? That is the question that will automatically come to your mind. So what is sequencing? Finding the structure of an unbranched polymer is called sequencing. So, you have, let's say, amino acid, lysine, cysteine, glycine. So if you find that linear structure, that's sequencing. But in colloquial parlance, when we talk of sequencing of DNA and RNA, and RNA after it has been converted into complementary DNA. So the precise order in which the nucleotides G, A, T, and C are arranged is what is called sequencing. And we do it in the regions of interest, but we can do it on whole exome and whole genome as well. But usually we identify regions of interest, that is what is called targeted sequencing. So we sequence it. We compare the query sequence with the reference genome to identify the alterations. So here you can see at the bottom is the referenced sequence, and the top one is the sequence that you have obtained by using the next generation sequencer. So at the green arrow, you can see there is one nucleotide in the subject which is different from the nucleotide in the query. So you have identified this as a single nucleotide variant. In the second image, you can see that there is about 12 or 15 nucleotides which are missing. You have aligned it, and you find that there are 15 nucleotides which is missing. This is del19, by the way, in frame deletion, 15 nucleotide loss. So you know now that this is del19 because of the in-frame 15 nucleotide loss. And then the bottom one, you can see half the sequence is aligning with the EML4 and half the sequence is aligning with the ELK, and therefore this is an EML for ELK1 fusion rearrangement. So that's what you do. And you can do this on a germline material, and you can do this on a somatic material. And when you do it on the germline means there is one mutation that is actually running, or a change that is running in the family, that is running in the bloodline, that has been passed down to the individual through the spermatozoa or ovum, and it is present in all cells of the body. And then if you find any alteration that can help you in identify the rare genetic disorder and inherited cancer predisposition syndromes. And you can also do it in the somatic tissue, that means the tumor tissue or the affected tissue, and this is useful in cancer, in neurodegenerative disorders, in autoimmune inflammatory disorders, and this sequencing can be used for diagnosis, prognosis, therapy selection, looking for additional alterations with the disease evolution. And for the era of precision medicine, sequencing is a pivotal tool, an invaluable tool. So the sequencing began in 77. This gentleman, Frederick Sanger, introduced it. This was a very clever exploitation of chemistry. I'll not go into the detail. He sequenced 24 and 17 nucleotide fragments. This process also, I think I will give it a go. But the Sanger sequencing laid down the foundation of the sequencing. And the Sanger sequencing has some limitations and has some strengths. So what are the limitations and what are the strengths of Sanger sequencing? The strength is it is very accurate and it is the gold standard till today. 77 to 23, it continues to be a gold standard. You can actually, your region of interest or your target can be as long as 1,000 base pairs. So it can actually sequence long fragments. It's cost effective up to 20 targets. If you have more than 20 targets, it's another matter. But if you're looking for 18, 19, 17 target, it is cost effective. And you can use it for fragment length analysis. I don't know whether you know about fragment length analysis or not, but you use fragment length analysis for microsatellite instability, for chimerism study, and to see exon skipping, for example, metexon 14 skipping in lung cancers or on other cancers. So you can use Sanger sequencing for these purposes, and it is rapid and it has a quick turnaround time. So you can come up with a report of a Sanger sequence in 2 days. It has limitations. So you can actually identify one target in one experiment. It has low sensitivity. It requires a tumor fraction or the altered or the disease in 15 to 20% of the cells. It requires high DNA input of nearly 100 nanogram for each target. It has a low discovery power. You will not identify newer alterations. It is not cost effective when you are looking for more than 20 targets, and it has a low scalability. So what is the solution? The solution is next generation sequencing. Here you can simultaneously sequence thousands of targets. So that's why it's called massively parallel sequencing. And you can even multiplex many samples in one experiment. So you can identify all the targets. You can sequence them together in one experiment. And not just that, you can actually take many samples from many different individuals and run it in one experiment. As a matter of fact, we routinely do around 32 BRCA in one experiment. Up to 32 BRCA mutations can be identified on a small platform using just one experiment. It's highly tissue proficient. You just need around 10 to 20 nanogram of DNA or 10 to 20 nanogram of RNA, depending upon whether you are doing a DNA sequencing or you are doing an RNA sequencing. The limit of detection is 0.1%. That means you can find one mutant allele out of with the 999 wild alleles, and you can take it down further. For example, we do it in liquid biopsy when we are using cfDNA, but when you do that, some errors may creep in. So you have to use special error reduction strategies, but you can definitely take down the limit of detection further. And the next generation sequencing, the best thing about it is it has an open design. You can do targeted sequencing. You want to sequence 6 genes, 10 genes. You want to only do those genes which are required for neuropathology work. You can do only those genes which are required for lung cancer. You can do whole exome. You can do whole genome. You can do methylome. You can do just the hotspot, those areas in the genes which actually where majority of the mutations reside. You can do the whole coding sequence with the flanking region to find out the splice site alterations. You can actually customize it the way you want it. And you can use it, as I said earlier, for all classes of genetic alterations. The single nucleotide variants, the multinucleotide variants, the insertions, the deletions, the copy number alterations, and the fusion rearrangements. And you also get the readout of fractional abundance. So I will know after running this experiment that del 19 is present in 19% fractional abundance. And after, let's say, treating for a month, I can retest and say, now the fractional abundance is 2%, and therefore the patient is responding to the drug. Much before the PET-CT will tell us whether he is responding or not responding. And you have a high discovery power. You can actually identify. And we have actually in our lab identified several things which are in the process of being reported. And you find co-occurring alterations. So take, for example, when you know KRAS and TP53 are mutated together in lung cancer, this is an individual who is most likely to respond to immunotherapy. But if this individual has an STK11 or a KEAP1 mutation, then he is not likely to respond to immunotherapy. So you can find those co-occurring mutations which may have impact on the outcome of the other mutations. And you can estimate tumor mutation burden and microsatellite instability. And tumor mutation burden, the only platform for finding tumor mutation burden is next generation sequencing. So there are two platforms available. One is Illumina. 70% of the labs worldwide have Illumina, and Iron Torrent. 30% of the labs have Iron Torrent. The Illumina owes its ancestry to Solexa, and the Iron Torrent actually hijacked all the staff of Solid 454, and therefore they are based on semiconductor. The Iron Torrent and Illumina is based upon what is known as a reverse termination. So these are the several platforms which are available. More platforms are available with a varied range from Illumina stable. Lesser number of platforms are available from Torrent. But the last one of the Torrent, the Genexus, is a wonderful platform to use, because once you have extracted the DNA, you just load the DNA and then you will get the sequencing results. So in that sense, Genexus is a wonderful machine to have in your laboratory. Now coming to the workflow, as said, I will speak to you on the process. So primarily, this sequencing is done in 4 steps. The first is the library preparation. Second is the cluster generation. Third is the sequencing, actual sequencing. And fourth is the data analysis. So in library preparation, we extract the DNA, or if we extract the RNA, we convert it into complementary DNA, and then we amplify, because we need to have some targets. We amplify the targets that we need to sequence. If we need to sequence whole exome, we can take whole exome. If we need to take, let's say, 40 genes, then from those 40 genes, we amplify the amplicons, and then we remove the primers. We bind them with the adapters. I can't use the pointer, unfortunate. Okay, I can use now. So we bind the adapters, and after binding the adapters, these are the adapters, and the adapters have 3 parts. They're used for cluster generation, barcoding. So barcoding is basically 8 nucleotides, which will make the combination of those 8 nucleotides will make it unique. So that's how you can actually multiplex samples, because all 8 samples will have different barcodes. So when the barcodes will be read, the sample will get deconvoluted and put into the bin of the individual. And then you have and then you have the reading primers, the RD1 SP or the RD2 SP. And once you have ligated the adapters, the next thing is you put them in the flow cell. The flow cell has 8 lanes. The lanes are covered with these lanes are covered with these oligos. These oligos are complementary to P5 and P7, and the oligos will bind to these fragments, or the amplicons will bind to these oligos, and then we do a PCR, which is known as a bridge PCR. I will not get into the details of that. By doing that bridge PCRs, what you do is you raise these kind of clusters, and these clusters are monoclonal. They all have been raised from one single amplicon, and they have been raised, and there are around 1,000 to 5,000 in each cluster, and they have been raised for one purpose. Their reporting signal is strong enough to be identified. That's why they have been amplified in such a way that you get the signals, reportable signals from them. And then you use a primer against the sequencing primer, and float the nucleotide with the fluorescence. As you float the nucleotide with the fluorescence, this fluorescence, and if it binds, then this fluorescence is captured by cameras. So you see here, this is how a flow cell will look. There are billions of clusters on a flow cell, and the camera will capture light from each flow cell. If it is capturing a green light, this will be assigned to thymine, T. If it is capturing a yellow light, it will be G. And likewise, you keep capturing the line after floating nucleotides in a particular way, and what you get is a sequence, which is like a TCA, GCA in this case, and this is what is called a read. So you get a read. And this read is then added with, a header and with the quality score. So each time a signal is captured, how strong is that signal, and how reliant is the machine in believing that what signal it has called or what base it has called is correct. That's what is called a quality score. And with this, the alphabetical arrangement of the nucleotide and the quality score, what we get is a fast Q file. So this linear arrangement of nucleotide, that file is called fast A file. But when the quality parameters are added to this, it is called a fast Q file. This fast Q file is then aligned, as I showed you earlier, to the human genome using several tools, because there are 3 billion nucleotides in a human genome on one strand, so 6 billion in all. So obviously you need tools to align them. So you align them using these tools, and then you clean up, and then you store this information in a file which is called a BAM file. So you make a BAM file, and then this BAM file has this kind of an information. And if you look here, what you will see, we have here five sequences which are aligned to this human reference genome. And in this 5 sequence, there are 2 sequences which instead of A are showing T. These are variants. What are these? These are variants. And this record will be kept in the VCF file. This is the record that is kept in the VCF file, variant call file. So we have a variant call file where we have all the records of these alterations, and then the pathologist, the molecular pathologist, will sit down and interpret how these variants have been called. Are they significant or are they non-significant? And the ion torrent uses the same methodology, more or less. You apply adapters, you do amplifications. And instead of using the cluster here, you actually amplify each sequence on a bead, which is called ion sphere bead. Ion sphere bead. So here on a bead you make, so you have billions of beads and millions of copies on each bead, and they are clonal. If they are not clonal, when you will do sequencing, the garbage will come out. If they are clonal, then all signals will be of the same time, and they will be reportable signals. And then you flood these ionospheres on this chip. This chip has wells, nano wells, which can be as few as 1 million and as many as 11 millions. So 11 million wells are there. The dilution is carried out in such a fashion that each well gets only one ionosphere and not more than one ionosphere. And then as you flood these well with the nucleotide DNTPs, there is a release of a proton, H-ion. And this voltage change is captured by the transistors underneath. And as they capture, they allocate the bases. And that's how we again get the FASTA file. And then we add the quality parameters, and we get the FASTQ file. So the process, of course, is not that easy. At each step we need to do lots of quality check. I'll not get into the details, but a whole horde of quality checks are required at each step. That's why this process is very laborious, very industrious. And then you get the NGS output, and the NGS output is also quality checked. It is quality checked for certain parameters which are mentioned here. So if the quality parameters are met, then we come to the variant calling. So the pathologist will sit down. This is sort of a scroll down file. So you see all the variants, and then you look at each variant. You will look at each variant, and you find out whether it is significant or not significant. Is it consequential? It is not consequential. You will also get a gene card. You will have to do lots of diving into the databases. You will have to check up who has called this before, and this is a very elaborate work, and this is a work best done by the pathologist and not by the PhDs. So that's how we carry out this work, and then we prepare a report in which we include the amino acid change, the cDNA or the change at the level of the messenger RNA. We call it strong clinical significance or potentially clinically significant. If it is a somatic tumor testing, if it is a germline testing, it is called pathogenic or likely pathogenic. And so now we come to the meat and wine of the talk. What is the clinical application of sequencing? The first is the diagnosis of cancer. Because I work in a cancer hospital, so I will talk of cancer. In the selection of therapy for effective cancer treatment, finding the cause of acquired resistance and find new actionable biomarker. You've been treating a patient, develops a progressive disease. You want to find out why has this resistance happened, and is it still actionable? Finding the patients with inherited cancers or those who are predisposed to have a cancer for purpose of prognostication. Finding rare inherited disorder for prenatal testing, pathogen detection, metagenomics, public health surveillance, HLA typing, transplant rejection, biomarker and drug discovery. And of course, we all understand that the COVID, the SARS-CoV-2 was sequenced by Chinese within 1 month, and we had the primer and testing kit within the 40 days, all thanks to next generation sequencing. So let's see some cases. So here is a 61-year-old male presented to the hospital with a space-occupying lesion with an evidence of chronic liver disease. He was being treated as an adenocarcinoma of unknown primary. He had failed 2 lines of systemic cytotoxic therapy. He chose to come to RGCI-RC at this stage. His alpha-fetoprotein was raised. He brought 1 block from outside, which was a poorly differentiated carcinoma. My colleague saw through this slide and came up with an opinion of metastatic poorly differentiated adenocarcinoma from upper GIT, pancreatic or biliary tract. We did a next generation sequencing, and what did we find? We find the IDH1, arginine at 132 leucine mutation with a variant allele fraction of 16.39%, a MET amplification, and a TP53 loss of function mutation. So now this is what we saw. So IDH1 32L is a canonical mutation for intrahepatic cholangiocarcinoma. Okay, like in the brain and in the blood, in acute myeloid leukemia. It's also seen in a fairly large number of intrahepatic cholangiocarcinoma. The MET amplification was responsible for his failure to respond to cytotoxic therapy, and TB53 was making it poorly differentiated. And the IDH1 is also actionable by a tyrosine kinase inhibitor called ivosidenib. So by doing this NGS, we could resolve the problem of his diagnosis. We could also identify a target which is actionable, and we can also explain the biology of his tumor. So this is a 45-year-old female who was diagnosed as a case of a granulosa cell tumor, but she returned 3 years later with florid pelvic abdominal disease and a metastasis. The histology was very, very aggressive. There was the mental biopsy was done, and my colleague reported it as a high-grade, poorly differentiated tumor consistent with granulosa cell tumor. The oncosurgeon called it rubbish. He says this is behaving like a high-grade serous carcinoma. There is omental caking, there is pleural effusion. What rubbish are you talking? This is basically a case of a high-grade serous carcinoma. So we said we will actually go ahead and do an NGS. And maybe we will probably find an actionable biomarker also by doing an NGS. So we went ahead and did an NGS. And the NGS returned with a mutation in FOXL2, cysteine at 134 replaced by tryptophan. So that's a browser that shows us the mutation. And if you really look at the my cancer genome, this is a mutation which is almost exclusive to granulosa cell tumor. It is not seen anywhere else. And the TP53 was mutated, which was making this tumor so aggressive. Of course, we didn't find the actionable mutation, but the diagnosis was clinched. It's a case of a granulosa cell tumor that was produced. So the pathologist can have a last laugh on oncosurgeon when they say you are talking rubbish. So NGS in diagnosis and prognosis. So this is a 61-year-old female. She had a biopsy from cervical level 3 lymph node, high-grade spindle cell tumor arranged in fascicles, exhibiting significant nuclear pleomorphism and brisk mitosis. Any guesses? With a very hemangiopericytomatous pattern. Plump cells, occasional rhabdoid cells, lots of mitosis, very ugly and aggressive. It was negative for CK, TTF1, PAX8, and P40. Doesn't fit into, like thyroid or region largely or any other. but BRAF V600E by IHC. So genomic IHC is useful, as you said. Genomic IHC, TP53 was mutated. And the NGS. And the NGS was just, left no doubt that this is anaplastic thyroid carcinoma. Had all the classical alterations, BRAF, V600E, third promoter mutation, and a TP53 alteration. Classical triad seen in anaplastic thyroid carcinoma. And then he could actually get dabrafenib and trametinib, and his cancer could become operable. So this was a woman who came with pain abdomen, no bleeding per rectum, no signs of intestinal obstruction. PET CT showed a mass in the right iliac fossa, which was attached to cecum. The endoscopy was done. A cecal biopsy was taken, which turned out to be a transient infective colitis. Right hemicolectomy was done, which showed poorly differentiated adenosquamous carcinoma. While the patient was on treatment, she developed liver metastasis. The liver metastasis showed cytokeratin P40 positive tumor with PEX8 positivity and some vague SADB2 positivity. So we were completely at loss what it is. Absolutely at loss. SADB2, PEX8, and P40 don't go together at all. But NGS was done, and this NGS revealed a P10 loss of function alteration, a frame shift insertion in PIK3R1, beta-catenin missense mutation, gain of function mutation in beta-catenin, a TP53 gain of loss of function mutation, and a widespread copy number alterations, those bar diagrams. And this genomic profile, if you go into a database which is called cBioportal, this genomic profile is absolutely dot-on fits with the endometrioid adenocarcinoma. So this woman, we told the physician in charge, had possibly an endometrioid carcinoma. He spoke to her again. In 2005 years back, she had a bleeding per vagina. She was diagnosed as a CA endometrium. It was 1B, but no local addressal was given. And this was a local recurrence, which was predominantly showing the squamous elements, and that's why it was PEX8 positive. So everything fell into a place just because we did this NGS. And then this is a 51-year-old female, came with the classical symptoms of carcinoma lung, was diagnosed as a carcinoma lung, as a LAP1 testing, EGFR, L-cross rearrangements were negative. We did an NGS. We do NGS for all cases of lung cancer. And what we found, a KIF5B rat fusion rearrangement. She was put on selpercatinib, and you can see the reduction in the size of the tumor. There was a partial response. And 1.5 years later, she is still alive and doing well. So this is a young 36-year-old male non-smoker. He had a biopsy. He had a metastatic disease. His biopsy from the lymph node revealed adenocarcinoma lung. He had gone to an outside lab for testing where L-cross and EGFR was negative. He came to us asking for a BRAF RAT fusion and MET exon 14 skipping alteration. So somehow, I don't know why, we decided to do NGS instead of do those single gene assays. We are actually sold out to the idea of doing NGS rather than doing single gene assays. So we did a NGS on him, and lo and behold, we found that actually he has an ALK rearrangement. We took one more section and did an IHC. The outside report was wrong. And if we had continued with the single gene assay, this young individual who can now possibly live for 7-8 years more would have lost his opportunity. So that's the power of comprehensive testing. You do it, you can find these kind of actionable alterations which can actually change the course of therapy altogether. 60-year-old, 63-year-old female, again lung adenocarcinoma. She, on single gene testing, was negative for EGFR, ALK, and ROS rearrangement. Chemotherapy was given, and then she developed progressive disease after 8 months. NGS was submitted. And this is what we found. You know, you hear in the book that all solid tumors should be tested for anti-RK fusion. And here she had an anti-RK fusion, which you otherwise will never find. So here is an anti-RK fusion. And she has now been put on entrectinib or larotrectinib, I don't remember. But she is doing exceedingly well. So you can see here entrectinib, and you can see here how the tumor has actually responded to entrectinib, you know. So this is the power of NGS. You can find rare alterations which you otherwise not dare to investigate for. And then you're finding the acquired resistance. So here is a case of a 66-year-old male who had an ALK-positive tumor. He was being treated with crizotinib, and he developed a progressive disease. A biopsy was taken. The biopsy was resubmitted for an NGS. And here we found an alteration called G1202R. And this G1202R is an alteration which is not responsive to all other 5 ALK tyrosine kinase inhibitor. Crizotinib, bigatinib, alectinib, entrectinib, whatever, all other 5 except lorlatinib. So this individual could be put on lorlatinib, so that, and he actually benefited from faring well. So he got benefited because we could found the cause of this acquired resistance, which is still actionable. And we can also use NGS in finding those who are predisposed to cancer. 42-year-old female who presented 10 years back at the young age of 31, 32 with a micropapillary breast carcinoma. She was effectively treated. She had no evidence of disease 8 years later. At 2020, she presented with a thigh mass, which was diagnosed as a pleomorphic undifferentiated sarcoma. Her family history of cancer was very strong, and therefore we thought we will do a NGS cancer predisposition panel. And what did we find? We find a TP53 loss of function germline mutation. She is a case of Lee-Fraumeni syndrome. You read about Lee-Fraumeni syndrome in books, but if you start doing NGS, you will see those cases. That's the power of NGS. And this is a 47-year-old male who presented with a medullary carcinoma, thyroid. His blocks were submitted for NGS. We did a hotspot panel. We found a RAT mutation on his tumor. And this RAT mutation on his tumor had a variant allele frequency of 10%, while the tumor fraction was also 10%. So I don't want to take you into those calculations, but this WAF was high for the tumor fraction and gave us a suggestion that this could be a germline alteration. And therefore, whenever you actually confront a case of medullary thyroid carcinoma, you shall always look for RAT mutations and not fusions, RAT mutations. And if the variant allele frequency is high, you are duty bound to do germline testing. And if after doing germline testing, you find that and 10 to 15% of the medullary thyroid carcinoma are inherited, familiar medullary thyroid carcinoma, or MAN2A and MAN2B. So you are duty bound to test the first degree relative for this particular mutation only. And if these mutations are 918, 634, or 883, the child, the relative must undergo immediate thyroidectomy because they produce early onset medullary thyroid carcinomas. But if the mutations are 768, 790, etc., then these are age related. You can postpone and you can allow the child to grow with the thyroid till such time you decide to do the thyroidectomy. So you can postpone. So in this case also, when we did The blood, he came out positive. So he had a germline. Son was tested. The son was negative. This variant confers a moderate risk. It has an age-related penetrance. He actually had come with an adrenal mass. So because man 2A can have a pheochromocytoma, so he was investigated for pheochromocytoma. This wasn't a pheochromocytoma. This was just some incidental. And patient has been advised to bring his siblings and encourage them to genetic counseling and undergo site-specific mutation testing. And when we were doing these hereditary breast and ovarian cancers, and we have been doing it for many, many years now, and we have a large repository of hereditary breast and ovarian cancers. And we found in the Nepalese population, 2 founder mutations. 83.2% of Nepalese population, when they have BRCA mutation, they have it in BRCA1, and they have it only the underlying lysine 739 termination and lysine 1690 termination. The first one is about 3/4, the second one is 1/4. It's something like Ashkenazi Jew. So all of you who want to test for BRCA, you can have just a PCR-based test looking for these 2 mutations, and 83% of your cases of BRCA alterations you will be able to diagnose in your laboratory. This is especially for this audience, that you don't have to run for an NGS. The NGS has helped us in identifying these 2 alterations, which is responsible for hereditary breast and ovarian cancer in 83% of Nepalese population. And I think my time is over, but sometimes you can find rare actionable mutation. This was a case of metastatic castration-resistant prostate carcinoma, and he came us to find some actionable biomarker. But instead, what we found was a homozygous mutation there, and this homozygous mutation is associated with hypercholesterolemia and hypertriglyceridemia type 3. And when we actually checked him, he was a case of hypertriglyceridemia. So you can identify rare diseases by using next generation sequence. Otherwise, this case would have never been identified as a case of a hypercholesterolemia type 3. And my last case, that will make it a dozen. So this is a case, a 61-year-old, and we did the first lap of testing for EGFR, ALK, and ROS. EGFR, ALK, and ROS were negative. But when we did the NGS, we found a EGFR mutation. Now this EGFR mutation is uncommon. It is not covered by the RT-PCR. So 41, 42 mutations that RT-PCR cover does not include this. And then we published this paper, and we found, after going through lots of literature, that it is still actionable by afatinib. So we found something actionable which would not have been found by conventional testing. So with that, I end my talk, and I just want to conclude by saying sequencing is an essential tool in the era of precision medicine. It is versatile. It can interrogate all 360-degree of alterations rather than looking for one class of alterations. It is the only tool to identify inherited diseases and cancers with no or minimal genotype-phenotype associations. The workflow is difficult, undoubtedly. The quality management is costly, requires huge efforts, undoubtedly. It is daunting. The learning trajectory is steep, undoubtedly. Yet it has to be done. It has to be done. And the pathologists, I will exhort them to eliminate their diffidence and learn, however hard it may be. It is no more an intangible science. It is a decision-making science. And if you will do that, you will not stand outside, watching from outside the patient care. You will not be an extramural agency who just did a test and then forgot about the patient. You will become the central of existence of the wheel of care of the patient. And with that, thank you so much.
Plenty of food for thought. Thank you, Professor, for your enlightening presentation. As young doctors, we can only hope to match your passion towards our field in the future. Now, we have come to the discussion part of this session. In this room full of passionate professionals, I'm sure everyone is having a great time, as well as a great deal of queries. With this, we will now be taking questions from the audience, and I would like to request the audience, as well as the speakers, to keep the questions prompt and the answers brief. So, any questions? Please, there must be some curious cats in the room. Well, delivering a presentation with such clarity and leaving no queries is a talent on its own, and Professor Pant and Professor Mehta seem to be experts. So, if there are no questions, I would like to move on to the next part. We are extremely thankful for our speakers today, and so I would like to ask Dr. Priyanka and Dr. Sadiksha to help Professor Dr. Geeta Sayami, consultant pathologist at HAMS Hospital, Grantee International Hospital, and former head and professor of Tribhuvan University Teaching Hospital, an eminent figure and immense contributor in the field, to please express our gratitude with a token of appreciation to our guests. Please, ma'am. Professor Dr. Geeta Sayami. It seems like Professor Geeta is unavailable right now. Instead, I would like to invite Associate... sorry, ma'am. Professor Dr. Geeta, please. I would like to invite Professor Dr. Rajesh Pant on stage to receive a token of appreciation. Next, can I please invite Professor Dr. Anurag Mehta on stage for a token of appreciation. Thank you so much, ma'am. Thank you so much, sir. I would now like to ask all the residents and pathologists with poster presentation to please proceed towards their respective stalls. It is not every day that we get to stand amongst the pioneers in the field of pathology, but before we continue with the rest of the program, I would like to invite you all to please proceed towards the garden for a short tea break. Thank you. A gift for all the participants, so please visit the stall during the tea break.
worth choosing in clinical labs. BioSage 240 Plus is one of the fastest small-size analyzer with 240 tests per hour for biochemistry and 200 tests per hour for electrolyte testing. The sample and reagent area are combined in a single disc. It contains up to 90 sample and 90 reagent positions. Both polytype primary tubes and micro-container cups are compatible. The sample and reagent disc provides constant cooling at 2 to 10 degrees centigrade. Continuous loading function for sample and reagent is also available during measurement. The detachable design is convenient for sample and reagent storage. The sample and reagent needle coated with Teflon is washed automatically after each pipetting to avoid cross-contamination. Other functions, including liquid level detection, clot detection, and cross-proof are also available.
That's right, I said a 3D fence.
1,400 round per minute high-speed mixer coated with Teflon is used to fully mix sample and reagent and is washed with preheated water before and after mixing.
But that's only about
Totally 80 reusable optical plastic reaction cuvettes are used for reaction and measurement.
Landing anxiety.
Minimum reaction volume can be lowered to 100 microliters, which is cost-effective for customers. BioSage 240 Plus adopts post-spectroscopic optical system and a long-life halogen lamp, which greatly improves the detection accuracy in reducing consumable cost. 16 wavelengths ranging from 340 nanometers to 800 nanometers meet the needs of different assay configurations. 80 reaction cuvettes can be automatically cleaned by a station with 4-step washing procedure. The maximum water consumption of BioSage 240 Plus is ranging from 2 to 3 liters per hour, which greatly minimizes water usage. One BioSage reagent kit includes 30 ml R1 and 10 ml R2. Smart Design reagent kit makes the benefits of loading R1 and R2 at one time. Each reagent kit has a unique barcode. Barcode recognition function is available for both sample and reagent. A simple and user-friendly software provides excellent user experience. STAT mode and automatic dilution function are supported. The needle and cuvette can be washed by acid-based cleaning solution Thought.
Before I invite our next speakers, I would like to heartily welcome the chairperson for this quarter, Dr. Sanjeev Kumar Gupta, Professor of Laboratory, AIMS. Could you please take your seat on the left? Yes. He is the Professor of Laboratory, AIMS, and Associate Editor of Indian Journal of Hematology and Blood Transfusion, and the co-chair, once again, Dr. Anurag Mehta. I would also like to request both the chairs to introduce our speakers for this quarter, Professor Dr. Sumit Gujral, Dr. Gaurav Chatterjee, and Professor Dr. Ram Chandra Adhikari. As we seem to be running behind schedule, I would also like to request our speakers to keep their sessions brief and be aware of the time limit.
Good morning, everyone. We thank the organizing team for inviting us to be here as a part of this conference. So for the next session, it is my privilege to invite Professor Sumit Gujral, who is a professor of pathology at Tata Memorial Center, Mumbai, with a special interest in oncopathology and hematopathology. He needs no introduction, but just as a small introduction, he has been a teacher par excellence and mentor for most of the pathologists in India, and I'm sure many in this room also. And he runs a very successful online postgraduate teaching program also. So if you have not joined, you must attend the classes that he has been organizing for past many years. And over to you, sir. He has been an author in the latest WHO classification of hematolymphoid neoplasms also. So he'll be talking about what's new in the 5th WHO classification of hematolymphoid neoplasms. Over to you, sir.
Thank you, Sanjeev and sir. Thank you very much, the association here, to invite me and for all the love. It's been my first visit to Kathmandu and I'm really enjoying it. So I have my slides. Hi. This is pointer. Yeah, good one. Yeah, thank you. So my talk is on what is new in WHO. Why I'm talking on this topic is because I'm lucky to be part of this Blue Book editorial team. So I've worked with around 19 more editors for this book. So I would be sharing with you a little bit experiences of mine, this 2-year journey, and salient points on what is new in this WHO classification. So we were almost 20 to 25 expert editors and more than 400 authors from all across the world. If you see this map, it shows you the map of editors. Editors are from different parts, all these parts. Like this from India, also China, Australia, one from Africa too. And these are the authors. So authors have even more distribution. So this is a list of expert members. I happen to be somewhere here. Now, why do you have classifications? Why do you have WHO classifications? And what is the use of having such a classification? Can they be used worldwide or they can be used only in the developed world? So if you look at the older classifications, even the newer one, latest ones, most of the the way they define leukemias, lymphomas, or even brain tumors, 80% of the world cannot follow it. Even now, the new classification which you will see, most of us cannot follow it. But there are some changes in this new classification which are very encouraging for the developing world. So that's how maybe I have been selected from India, because they never had any representation from Asia. So they took few people from India for male genitourinary Santosh Menon, and for lung chapters Dipali from AIMS. So there are 3 of us who have been editors in the WHO book this time, mainly because they wanted representation from the developing world. So we had, amongst the editorial team, we had a lot of Zoom meetings on deciding on the chapters and deciding on who will write the chapter, and then who will be the co-authors. So one responsible author, co-author. So it was a task deciding on the responsible authors and the co-authors. I, being an editor from India, I got a chance to select co-authors from India, responsible authors from India. So I'm lucky that, we are lucky that we could get 15 authors from India, from Vellore, from Tata Hospital Bombay, from TMC Kolkata, CMC Vellore, AIMS Delhi, PGI Chandigarh. So I tried to include almost all institutes, the institute which have the training programs. Maybe we have left behind some good ones, but we're still lucky to have 14 authors in the new WHO book from India. Now, if you look at the overview of this classification, it is actually even the older ones are very similar. There are very subtle changes. So if it follows a lineage-based framework, starts from benign to malignant, and there are triad of attributes. Now this is for all leukemias, all lymphomas. First is lineage, you have to give a lineage. Second is dominant clinical attribute. Is it an acute, chronic, or any cytopenias? Then biological attributes. Any gene fusions, rearrangements, or mutations. And clinical, even the history, the site, age. So these 3 put together, we classify tumors. And another interesting thing in this classification is hierarchical classification. Means first job is to know it's a lymphoma, it's a B-cell lymphoma. So we need CD20, maybe CD3, 20, and MIB1. Then we need to say it's a large B-cell lymphoma, obviously morphology plus the same 3-4 antibodies. Then DLBCL NOS. Now DLBCL NOS, you need more workup. Not many centers can do it. And then DLBCL, if you do the mutations, basically same thing. So if mutations, not many centers in India are doing. Like, you don't do MYC or BCL2 translocations. We don't do it. Not many centers do it. So if you're not doing it, maybe you can stop here, a large B-cell lymphoma. So I will briefly talk about lymphoid, myeloid, both. Lymphoid B, T, and K, plasma cells, and then myeloid. I have 40 minutes, but I'll try to finish in 30 minutes because we are already running short of time. So I will stop at maybe when I'm left with 10 minutes. Because it's a very standard thing you'll read in the books anyways. And there are no major differences in the new WHO book. I think I'll skip this. The major changes in the large B-cell lymphomas. This is the commonest lymphoma. Now there are 2 entities very clearly defined. One is large B-cell lymphoma. Second is high-grade B-cell lymphoma. Now high-grade B-cell lymphoma is not large cell. It is more blastic or intermediate size, but TDT negative. Something like Burkitt-like or high-grade NOS, which to call Burkitt-like lymphomas. So these are the lymphomas which do not look like DLBCLs, and they are not even Burkitt's. And they have morphology of intermediate size blastoid. So once you have this DLBCL, one type, second type is high-grade B-cell lymphoma, and both these types you need to do MYC and BCL2 rearrangements. You need to do both. So if you have DLBCL with MYC BCL2, then the diagnosis becomes this. If you have high-grade B-cell lymphoma with these 2 abnormalities, then your diagnosis becomes this. Otherwise, it is high-grade B-cell lymphoma NOS or DLBCL NOS. So to call a diagnosis of DLBCL NOS, you have to do MYC and BCL2 both. Otherwise, you can't use the word NOS. you stop at DLBCL. There are new entities in green color. So if you look at this circle, we have almost 17, 18 types of large B-cell lymphomas. And they are basically on site on some viruses, like in medias channel, intravascular, cutaneous, fibrin-associated, ALK positive. And the WHO recommends that you diagnose DLBCL. If you can further divide into GCB and ABC type, it is good. If you cannot divide, it is not mandatory. So your clinicians cannot force you to do CD10 BCL6 MUM1, which we were forced 2 or 3 years back, because there is not much use to do that. And best is to do genomics, and we don't do genomics. And these are not the best surrogate markers either. So there's no need to do cell of origin. If you can do it, it's good. If you cannot do it, don't do it. So this is very clear in the WHO. Then the role of NGS now means we have seen that there are publications to this effect. There are some types of DLBCL with some very specific subtypes like MCD, and there are 1 or 2 publications which have a very good prognosis. 100% patients survive, live more than 4 years, 3-4 years. But there are only 1 or 2 studies, so WHO has not included NGS right now. So NGS is not part of DLBCL. So it's only basically 3-4 strains, 320 and MIB1 are mandatory. It's not written actually, but it's kind of mandatory. You need not do the cell of origin. And NGS is not required as of now. It's not mandatory. If you're doing it, good. So if you look at aggressive B-cell lymphomas, I had shown you large B-cell. Now these are the aggressive. These are the aggressive ones, high-grade B-cell, DLBCL, and Burkitt's. And then these 2 I've already mentioned. And there's a new entity called as high-grade B-cell lymphoma with 11q aberrations. Now this is a chapter on its own, a new chapter now. So this is differential of Burkitt lymphoma. If you have a case which looks like Burkitt, but doesn't fit into Burkitt's, maybe because of some pleomorphism or there is a BCL2 is positive. So it doesn't look 100% fits into Burkitt's. It's a good idea to do this test, provided you have. So if you look now, 3 markers, FISH are important, BCL2, MYC, and 11q. There are few more, but these 3 for the aggressive B-cell lymphomas. So this I have already discussed, hierarchical structure, mature B-cell lymphoma we have to decide, then large B-cell, then DLBCL, if you can do FISH. Now, briefly for postgraduates, this is kind of written in WHO, and it's not the recommendation from WHO. We have made a table, how do you approach a high-grade lymphoma, B-cell or DLBCL? You first try and do 10 and MUM1 and BCL6. If 10 is positive, then you go further and do FISH. If 10 is negative, you can stop there. You may stop, if you're a rich lab, you do FISH in all cases. But if you are like a lab which is contemplating, shall I do FISH can I do FISH in lesser number of cases? We are not that rich. So maybe when 10 is negative, you need not do MYC. But if 10 is positive, you just do 1 MIC rearrangements. You don't have to do BCL2. But if MIC is positive, MIC break part FISH is positive, then you need to do BCL2 also. So MIC is the most important, followed by BCL2. BCL6 has taken a back seat. So it's not that important in the WHO. ICC, which is another classification, has still kept BCL6. So now, in Burkitt's lymphoma, we diagnose based on morphology and markers, but now historically there are different types. But recently now in WHO, Burkitt's has been divided into 2 types. One is EBV positive, second is EBV negative. Prognostic-wise, there is no difference. The same, but molecularly they are totally different diseases. So WHO mandates, it's a mandate to not recommend, it is mandatory to divide Burkitt's into these 2 types. We do not do in Tata Hospital. So we do not follow it. We don't do it because we are tertiary, we have money, we have reagent, but still we do not do. But WHO says do EBER-ish in all Burkitt's. You can't diagnose, now leave Burkitt's at only morphology and 4 or 5 strains. And obviously you have to do MIC rearrangements. Now, another chapter which has come in this new WHO book is mimics. So this is an interesting chapter, which is mimics in B-cell lymphoma, mimics of T-cell lymphoma. For mimics of B-cell lymphomas are few, Castleman's, IgG4 related, PTGCs, infectious mononucleosis, reactive lymphoid hyperplasia of female genital tract, Kikuchi's or SLE disease. Now, going to the blastic, now B-cell ALL, if you look at, I'll quickly go through this now. B-cell ALL is defined into so many types, 11 which are well defined, 11. Based on, hyperdiploidy, hypodiploidy, IMP21, BCR-ABL, BCR-ABL-like. So there are 11 markers. For each marker, there's a chapter now. And there are other defined, there are 7 markers. And then NOS, means these are only proposed ones. And there's something called as NFC. And NFC is not further classifiable, which we discussed yesterday also. I'll briefly tell you what is NFC. Now, if you look at this table, like this is a poorly drawn histogram. All leukemias are here. If you are a best center, you will do all workup and you will do maybe NGS also. And after doing flow, molecular, NGS, cytogenetics, PCR, all tests, you put your leukemia into which type. There are 18 types. Then if nothing comes here, and there are 4 or 5 proposed, actually not proposed, entities, it becomes NOS, because you have worked up and it doesn't fit anywhere. There are no major abnormalities seen. Now this entity, which is not further classifiable, this is for the developing countries like India and Nepal maybe, that we are doing only flow cytometry and immunohistochemistry. We cannot do FISH, we cannot do molecular. So here the WHO recommends you do at least immunophenotyping. So if you do immunophenotyping in lymphomas and leukemias, you can use the word NFC. So call it B-cell ALL NFC. Means you've not done these markers. You've not done RUNX1. You've not done IMP21. But then there is a marker called BCR-ABL1, which is kind of mandatory in B-cell ALL because there is a targeted therapy. So BCR-ABL should be done by FISH maybe. So this entity has come. In case you are not able to do a complete workup, you could leave it as a B-cell ALL and NFC or T-cell ALL NFC. Why all this? Because we know that ALLs are different types. They are good, they are bad, and they are very bad. Like this one, TCF3HLF, we have around 6-7 cases in our lab. Gaurav can tell me. And these patients do not live more than 6 months or 1 year, these children. So this is now a new chapter in the WHO. So based on good and the bad ones, we have defined chapters. Now this is a new entity in WHO, splenic B-cell lymphoma with prominent nucleoli. Now this entity has come and we have removed 2 entities. One is PLL, de novo pro-lymphocytic leukemia is removed now. You won't diagnose PLL anymore. You can diagnose PLL if it's a known case of CLL. Similarly, hairy cell leukemia variant, you don't diagnose anymore. Hairy cell leukemia variant has no similarity with hairy cell leukemia. It is high counts, there's no BRAF, there's no flow matching, there's no morphology matching, nothing. It was called hairy cell leukemia variant for some 1 or 2 reasons, but doesn't fit. So hairy cell leukemia variant, most cases, PLL, most cases go to this entity, which is called as splenic B-cell lymphoma with prominent nucleoli. I think I'll skip. So if you look at this, which are the entities in the new WHO which have been redefined? B-cell PLL excluded, hairy cell leukemia has been redefined. And these are the entities which have major changes. Large B-cell lymphoma, follicular, I'll show you a few other ones. Like this is like CLL, classical. We used to call it PLL. Now I can't call it de novo PLL, unless until it's a known case of CLL. Otherwise, I would just leave it as a B-cell lymphoma with prominent nucleoli. So hairy cell leukemia variants and the PLL of this kind of morphology comes into this category. Now, follicular lymphoma, they have made it more simpler now, simplified. Grade 1, 2, and 3A, you don't have to think too much to divide. If you can divide into 2 and 3A, good. If you cannot divide, just call it classic follicular lymphoma. The important is follicular lymphoma grade 3B. The new name of follicular lymphoma grade 3B is like DLBCL. It is follicular LBCL, follicular large B-cell lymphoma. So there's again a table for follicular lymphoma, means it will come in the WHO. I'm not going to spend time on this. This is interesting chapter now. Lymphoid proliferations and lymphomas associated with immune deficiencies and dysregulation. Actually, these lymphomas and proliferations are in the old WHO book also, but they are kept in different chapters like HIVs, primary immunodeficiencies, PTLDs, drugs related. So now what WHO has done, they have removed these parts from all these chapters and made one chapter, and the label of the chapter is immune deficiency or dysregulation related lymphoid proliferations. And here WHO suggests 3-part nomenclature. What is 3-part? You take histology, you look at the viruses, 2 viruses, EBV and Kaposi sarcoma, and third is what is the immune deficiency. Based on these 3, we give a label, and then broadly we come up with 5 diseases. One is benign hyperplasias. Second is also kind of benign, polymorphic LPDs. Third is also benign, which is EBV positive mucocutaneous ulcers, which mimic Hodgkin's lymphoma in all cutaneous sites. And fifth is inborn error of immunity, which was initially called as PIDs. And only one category of lymphomas. So these are the categories which are benign, or they might become malignant later on. We do not know, but at present form they will be benign. But these are the lymphomas. So these are the entities excluded. I have told you already this. In Hodgkin's lymphoma, there are 2 chapters. Classical has been written by Anita Borges, and NLPHL has been written by Sylvia Hartman. And there's a beautiful definition. If you have to read the chapter when you get the book, Hodgkin's lymphoma, she's written it very well. People did not know who is Anita. Many of these hematopathologists didn't know. They are mostly from Europe and America. Anita is very well known. I'm sure many of the youngsters who do not know Anita, she's one of the leading flame of pathologists in India and beyond India. An excellent person and a pathologist. If you get a chance to work with her, means I am lucky to have her, and Dr. Anurag will agree with me. We're lucky to know her. And she has written this chapter, and when she wrote the chapter, people are just going gaga over her. There are co-authors with her, around 12 co-authors. Every co-author has almost 50 to 150 publications in Hodgkin's. And Anita has none, actually. But she has seen so many cases, and the understanding of the disease and writing. So NLPHL done by Sylvia Hartman, and this patterns done by Yashoda Natkunam. And Yashoda has given these cartoons along with HNE and CD20. It will come in the book now. When you're writing a book on Hodgkin's chapter, there is a chapter on T-cell rich B-cell lymphoma, there is a chapter on EBV-related proliferations, there is a chapter on gray zone lymphoma. They all mimic Hodgkin's. So authors are different in each chapter, so it was important to have harmonization between each chapter. So if all these chapters, 5-6 chapters which were mimicking Hodgkin's, they used to, all the authors and primary and responsible authors sat through together for a few meetings so as to have harmonization between each chapter. Plasma cells, some new terms have come, TEMPI, ISOP. And if you go to T cells, again we have mimics of T cell lymphomas. Here again, Kikuchis, they're also Kikuchis, but there we call it SLE. Means SLE and Kikuchis are very similar looking, and Kikuchis and SLE can look like B-cell lymphoma, can look like T-cell lymphoma. Indolent T lymphoblastic proliferations, very rare. We have not diagnosed any case in Tata Hospital. Maybe we are missing. Then ALPS. ALPS is autoimmune lymphoproliferative syndromes. Now this is only one autoimmune. There are many autoimmune syndromes. ALPS is well known, more common. Now PTCL has been defined into 2 parts. One is PTCL TBX21, second is PTCL GATA3. Now this is a little more aggressive. So you can do 3-4 markers in the T cell panel to define TBX21 and GATA3, but it is not mandatory. But if you have money and if your clinician is aggressive, he wants to know, is it a good PTCL, is it a bad one or a less bad one? You could do these markers, and then you could give in your report. Similarly, there are some entities, newly entities introduced and some entities deleted. Now this entity has been deleted, NK lymphoblastic leukemia. Why it has been deleted? Because many of these cases, they look like blastoid plasmacytic dendritic cell neoplasm, or few of them could be T cell ALL expressing 56, few of them could be AML with 56, and few of could be acute and differential leukemia 56 positive. So this entity is gone. Now AITL, old AITL, the new name in WHO is nodal T follicular helper cell lymphoma. It is 3 types: AITL morphology, follicular morphology, or NOS. There are mutations defined, but you need not do. If you can do genomics, good. Now, ALK negative ALCL, it has been divided into two types. The good one is DUSP22 and the bad one is TP63. Again, not mandatory. Stroma divide, some new terms have come. Already there, existing terms, but in this chapter, they made a chapter of this with some new terms. Now, this is another interesting chapter which has come, genetic predisposition syndromes. So here, you have to take the history of the family. Like in the previous case, Dr. Anurag had shown one case. You check the mother, you check the siblings. Similarly here, we have cases of leukemia, a family affected. Then you do germline studies. Now this is yesterday. We started our day with the lymphoma symposium, and Gaurav was teaching. And then we were lucky to be offered coffee by our colleagues at lunchtime. Then we thought let's be religious for family purposes. We went to temples, and second temple, Buddha temple, Stupa. And in the evening we went to where did we go, Gaurav? We don't have casinos in India. Maybe they are in Goa. But never been. But we were brought up as child listening to stories of casinos of Kathmandu. So it was a dream to go there, and thanks to our friend, she took us to a casino, and what an experience. And all those friends who are from outside Kathmandu, please visit one of the casinos. But I think it is not for the Nepalese. It's only for the outsiders. So you can borrow my card or sir's card. So now I go to myeloid. I have 10 minutes left. So I'll finish myeloid in 10 minutes. So this term has been now identified. Clonal hematopoiesis, a chapter is coming on it. CHIP, CCUS, these are now well-defined terms. Now, if you ask me what is new in myeloproliferative neoplasm, three things. In CML, accelerated phase is gone. In CEL, diagnostic criteria are updated. You can read that. In JMML, again, it goes under MPN. Unchecked activation. There are some good ones and the bad ones. So there are different changes in these three entities, which will be in more details in the book. In MDS, very little changes, but now the new name is myelodysplastic neoplasm in place of syndrome. You can use syndrome because people are used to syndrome. So WHO says you use both terms, but this is preferred term. And then how do you define it? Defining genetic types, 5q deletion, SF3B1, and TP53. These are the three common genetic markers you have to do in MDS. Otherwise, then you go to the morphology. Once you're ruled out, then you go to the morphology, and then you define based on blast count or cellularity. CMML also, there are some minor changes. Atypical CML is renamed now as MDS MPN with neutrophilia. MDS MPN with ring sideroblast has got a new name. We call it now MDS MPN with SF3B1 mutations and thrombocytosis. They have ring sideroblast. So if you have a case of megaloblastic anemia in elderly and anemia is persistent despite of all other tests, it's a good idea to do this mutation. Now in AML, like in ALL, it's three types, defining, very classically defined, then defined by morphology, this is differentiation, and other defined. So these are the 13 types of based on molecular markers. We all know these, the two of them are new. BCR-ABL1 is now defined, SEPA is defined. Now these are, once you have done all these markers, then you could call anything from here, AML without maturation, or AML myelomonocytic leukemia. But to call anything as acute monocytic leukemia, you have to do KMT2A and everything to call it negative, then you call it acute monocytic leukemia. Because acute monocytic leukemia is classically associated with KMT2A rearrangements, then you call a diagnosis as AML with KMT2A. You don't use the word monocytic there. So as we told in the beginning, we have fusions, rearrangements, and mutations. These are the common ones. These will be given in the book when you read the book, which is coming maybe by end of June. Just to show you the example, AML with KMT2A, you have ALLs also with KMT2A. Now this is AML with KMT2A, they have multiple partners. How many? 80 fusion partners. So now there are some good ones, there are some bad ones. There are some with pediatric age group, there are some with adult age group. So this you can do, 80 partners you can't do on FISH or PCR. You need to do, again, NGS, because you can do so many mutations, rearrangements. Now this is the morphology of, classical morphology of monocytic leukemia, which are NSE positive. You need to do KMT2A. And these are the classical AML-M2 with maturation on morphology. Once your all markers are negative, then you defined by differentiation or by morphology. You call it AML with maturation, MPO positive. Yeah, then we have a new entity now, AML myelodysplasia related. Again, morphology is not that important. These are very more important. Morphology is important, but not the definite. Cytogenetic are very important. Also, now these new genes, 8 genes mutations. So now it's not easy for all of us to do all this. This gets very expensive. Now this slide just to show you that there's a marker called as BCL11B rearrangement. It can be seen in so many types, T cell, B cell, mixed phenotypic, ambiguous in AMLs. So it means there are markers which can be seen on all types. So we are basically, maybe in the next classification will be even more to learn. With every classification you learn and you change a bit. Now myeloid lymphoid neoplasms with eosinophilia. So if you ever have a case of eosinophilia, rule out common causes, parasitic, fungal, allergy, drugs, then you go to these rearrangements, common enough. Initially we used to study 3 or 4. Now there are even more. So the WHO recommends workup for eosinophilia, and because there are some of these have targeted therapies. Now acute leukemia of mixed or ambiguous lineage, again defined into 2 parts based on genetic abnormalities, based on immunophenotypically. Now the blast count. Now this is a slide I think it took from Gaurav. If you look at the blast count, you have to have 20% blasts to call it AML, but if you have these abnormalities, you don't need blasts, even 1% blast, even no blast. But patient will come to you with sickness, he will have cytopenias, he will have some abnormality in the counts. So you do a bone marrow and you find 3%, 5%, 8% blast, but you find CBFB, MYH11. So it is AML, even if the blasts are not 20%. But these 2 markers, BCR-ABL1 and SEPA, need more than 20% blast. And these entities also need more than 20% blast. And obviously, those leukemias are defined by morphology, you need 20% blast. So just to conclude, most important, in resource-setting countries, 80% of the world, maybe 80 or maybe 90% of the world needs trained hematopathologists, trained oncopathologists, trained GI pathologists. So we have to have training programs. If you start training programs, you improve yourself, teachers improve, and students improve, and the next generation starts doing more tests, and the funds also come gradually. So we need, that's the most important to me, trained hematopathologists, which will give you a good quality H&D section, because without a good interpretation of H&D, genomics won't help. Flow won't help. Flow cytometry without understanding leukemias will not help. So it's good to start trained pathologists, super specialists. We have started in India. We have many centers doing it. And Nepal also, I'm sure, is starting. Dharan has started one. I hope more centers start, more oncopath or hematopath or dermatopath kind of fellowships. This helps us improve. The seniors, the old people, they also improve with the youngsters when you teach them. So rest, I think I'll skip. I've already mentioned this. Yeah, each chapter in this book, each chapter in new WHO has essential criteria and desirable. Essential means you need to do at least this much. At least you have to do PAX5, 30, 20 to diagnose Hodgkin's. Desirable will tell you 15 markers. But if you read the whole text of Hodgkin's, it may be 50 markers. So 50 markers, nobody can do it. So research-based setting. But at least 3 markers, like I told you, 30, 20, and PAX5. These are mandatory in WHO. So each chapter has essential and desirable. So we should be desirable. Like we should look forward to do at least desirable. We should move beyond essential. Yeah, again, this I mentioned. I think I will skip here. These are a few of our contributions. This term was suggested by me, and I'm happy it's coming at least in ALL chapter. There are 2 publications that have already come out. One for myeloid, one for lymphoid. They are free, available. So I thank my team and the WHO team. And this is my group, which has helped me to be a part of the editorial team, though I was having mostly coffee and going to the casinos. But you have to have good friends with you, like Dr. Nurag Mehta and Dr. Rajiv from AIMS, and my colleagues in Tata Hospital. Thank you very much.
Thank you so much, sir, for this lucid talk about the new changes in the upcoming WHO classification, and making it very simple to understand and saving us some time also. Thank you.
Thank you.
Now I request Dr. Anurag sir to introduce the next speaker for the session.
So that was wonderful, Sumit. You explained the nuances so well. And our next talk is on cancer genomics in hematolymphoid malignancies. And this will be explained to us by Dr. Gaurav Chatterjee. He's an associate professor, hematopathologist at Tata Memorial Center, Mumbai. He has 19 publications in journals and 2 book chapters to his name. And his specialization is in cytogenetics and hematopathology. So welcome, Gaurav. Dice is yours.
Thank you, sir. I think there was I don't do cytogenetics, so it's all molecular genetics and flow cytometry. Thank you for the introduction, sir. So, we're going to talk on cancer genomics in hematolymphoid neoplasm. I'm really thankful to Dr. Anurag Mehta, who did a great primer on the topic of NGS a few moments earlier. So my job is really easy. I'm probably going to focus more on the examples and maybe just a little bit of reiteration of what he said to just hammer home the point. So that's going to be the main thing. And this is the point I think I'm trying to, enforce from yesterday on you, that a pathologist's job right now is not only on diagnosis. Multiple level you are going to diagnose, we're going to impact therapy. So the talk is again structured in this way. First, we're going to discuss some examples of genomics in diagnosis, classification and prognosis of hematolymphoid malignancy, and it will be followed by some examples, and if we get the time, to monitoring and theranostics. So let's start with the case. This is a 32-year-old lady found to have a 2-month history of a low-grade fever. Pancytopenia was there. We did a bone marrow aspiration. We discussed morphology yesterday. So this looks like blast. They look like blast to me. Some amount of cytoplasm is there. Very monomorphic. MPO was negative. So we went ahead. We did flow cytometry, which is the first thing you do for lineage assignment in cases of AML. We did flow. If you can make it out, there was some, the blaster here in red. They are positive for some myeloid markers like 33, 11B, 15, 117, maybe it's dim positive. 4 and 56, some monocytic markers were positive, like 64 as well. Other lineage markers like cytoplasmic CD340 and B markers were negative. So what is the diagnosis at this point of time? If any of the postgraduates can say. Sorry? AML, of course, no, because some myeloid markers were positive, but some monocytic, maybe you can say it's an AML with monocytic differentiation, okay. So we did FISH, and FISH didn't show anything, any abnormality. So what next? Are you going to do anything else, or you are going to diagnose the case as AML, NFC, like Dr. Gujral says, and we move on, or we do anything else? In an ideal world, what do you want to do in this case now? We discussed yesterday, so we are going to do NGS, we're going to do sequencing. So, for that, we need to learn some techniques. I will probably skip through this slide real fast, but this is a good slide. This slide is courtesy of Professor Nikhil Patkar in our lab. I really like this slide. So, why do you really want to learn techniques of molecular biology? Because, the laboratory developed assay, this is very important for a country like us and country like Nepal, that they save a lot of money. If you take a company setting, if you take a company instrument, if you take a company analysis software, they're going to be costly for you. So once you learn these techniques, you can actually develop assays, home-brewed assays in your lab, which are going to save you a lot of money. You can build a trained technician workforce, which is going to then help you to build capacity and go on further. You will know exactly what you are doing. You can ask a right specific question in a right context. And of course, you can publish some cool stuff. So here you can see some examples of techniques in molecular biology which have been, which are really maybe some of them are path-breaking, like this one first developed exome sequencing. This is a technique to do non-invasive testing from peripheral blood, which is now becoming very, very important in maternal things. This is a technique that developed CRISPR-Cas9. One technique that we have developed in our lab, not as important as these, but very important for us, which is a cost-effective NGS technique to detect fusion. So this is the way you can develop techniques in your lab once you know these techniques. And science ultimately is a hypothesis and context, but you need technique to prove your context, prove your hypothesis. So that is really a compelling reason why you should, like Professor Mehta said in the morning, that you should be, there is no choice but to learn now. So you have to invest in this and learn these techniques if you can. Okay, let's skip this because we have already discussed. So this is a question I would ask the postgraduate. I was asked to put some question in this. So what is the recommended container for molecular testing? Anyone want to take a guess? What do you, in which container you send usually when you send for molecular testing? EDTA, that's correct. So EDTA is the correct answer. Very good. We can maybe give her a chocolate, whoever said that. Yeah. And Girishma told me to put some question. Thank you. Girishma, a chocolate for her. Okay, so again, probably I will skip. So this is, in brief, it was discussed in the morning, the Human Genome Project, which was first initially launched by Bill Clinton, who was the president of USA at that point of time. And it came in the cover of Nature, cover of Science, and now we are talking, there are multiple iterations that has happened. Now we are talking telomere to telomere sequencing. This was published last year only. So now we have a full telomere to telomere human genome sequencing sequenced with us. Two of the discoveries are very critical for all type of sequencing that we do. One of them was discussed in detail in the morning by Professor Mehta, which is the Sanger sequencing developed by Frederick Sanger, awarded Nobel Prize in chemistry in 1980. And the other, of course, is PCR, which was for which Kyle Mullis got the Nobel Prize in 1993. We'll skip this. This has been already discussed. You know, this is just one slide I want to show you that what is really the chemistry of most of the sequencing that we do. Again, Professor Mehta said that 70% of all sequencing that is done in the world is using Illumina. So the chemistry that Illumina uses is what is called as cyclical reversible transmination. So what it means is, you know, some of this nucleotide binds to this chain. And in Sanger, what happens is that will stop the chain elongation. And so you have multiple chains at multiple random points, the chain elongation has stopped. And then you take this, you decipher this sequencing using various methods. But what makes Illumina a multi-billion-dollar company is that they have made a way to make this reversible. So something binds here, and then it goes away again. So this chain elongation continues. So in this way, the DNTP binds, you take an image, and then it is reversible. So it will go away, and the chain elongation will continue. So this is one of the basic methods with which is the basic chemistry of all Illumina instruments that you see. So these are in our lab. This is a MySeq. This is a NextSeq 1000 that we have, that we use in our lab currently. We want to get another NextSeq, but let's see. So this is all this, like Dr. Mehta said about ion torrent. This is Illumina. So both of these are short read sequencing. So now we have some methods of long read sequencing as well, in which the DNA fragment of one read that you sequence are quite long. So that gives you a lot of more information. So PacBio or nanopore sequencing is one of those methodologies. So one real, at the core of it, what sets next generation sequencing apart from Sanger sequencing is that you are able to read data from individual DNA molecule. So instead of, so for example here, if you consider these two alleles, let's say this allele has a mutation, this one has not. And now this will be amplified into this will be amplified into this, and you can say, okay, these reads have a variant, these reads do not have a variant. So this is really a revolutionary thing that had happened in the initial days of next generation sequencing that has helped us to, understand this DNA molecule in so much details. Again, this has been discussed in the morning, so I'm not going to talk too much. Just I'm going to talk a little bit about template creation, because this is the basis of short read sequencing. So how do you create template which sits at the core of any library preparation method, which is the first step of 9GS. So in any short read sequencer, I was talking about short read sequencing. So what it means is you can at a go only sequence a small part of the DNA, which typically lengths of around 200 to 400 base pair. So you first have to chop your DNA into small bits. That is the first step in this template creation. Whereas for long read sequencer, you don't need that. These fragments can be really big for one read. And when you have chopped them into sufficient length for either short read or long read, then you bind them with adapter, and then they are maybe ready for sequencing. This is the very basic of it. And then the second important step is target enrichment. So, like again, Professor Mehta said that, of full genome we know very, very little. We have just scratched the surface right now. But right now, to really do full genome will be very, very difficult. It is only in a research context that these things are done. So for a clinical purpose, you need to target areas. For clinical purpose, we will only do those parts of genome which are well known for its association, well known for its clinical relevance. So a very important step is target enrichment for any NGS in our clinical lab. So for that, there are two methods that are mostly used. One is you can use a capture bait, which is known as a capture-based sequencing, or you can use an amplification-based method where you use PCR to amplify the part of your target. So this is one of the techniques we used in our lab, which is known as single molecular inversion probe or an inversion probe which we use to capture parts of the genome that we wanted to sequence. So we said that it's an AML, we want to only sequence NPM1. You do not want the all part of the genome. So that way you can enrich your library for specific targets that you have pre-decided. So next, coming to bioinformatics. So this is just the sequencing part of it. But what happens when the data comes out? What do you do with it? So this is how the raw data looks. It is like a meaningless sequence, not meaningless, but if you look at it on the surface, it is a very hard to find meaning sequences of A, C, G, and Ts and random order. So how do you make sense of it? How do you make a report like this from this? This is a much more legible report for us, where you can see that what are the genes that are muted. So how do you really reach from this to this? So for that, there is a long pipeline process. Again, I will not go into detail. Dr. Mehta has already told about it. So there are a lot of, suffice it to know that there are a lot of informatics steps that are involved, and it is a very, very, my suggestion to all of you would be, if you get a chance to learn some of this bioinformatics, this is really going to be even more useful as we go along and produce more and more genomic data. So there are multiple workflows that you can choose. You can go for whole genome and whole exome with their own pros and cons. But currently in the clinical lab, we either do a targeted DNA sequencing or a target RNA sequencing because of the cost effectiveness and because of the evidence-based clinical association with known disease. So now we'll talk a little bit about AML because that's the case we started with, right? Let's go back to our case. What happens in AML? How these techniques help in the diagnosis and prognostication of AML. So the first cancer genome that was sequenced was an AML patient, and that patient had an IDH1 mutation. We know that AML mutations belong to any of these groups. For this, we have to thank the initial discovery studies, right? So initially, there was discovery projects were initiated, including the TGCA project, where they sequenced cancers, broad spectrum technique, and they identified what are the main parts of genome that are mutated in a particular cancer. So now that allows us to develop a targeted panel, which only targets this part of the genomes. So this is the current panel in our lab. We use a 227 gene panel that can, that have the more important genes in different types of leukemia, as well as some inherited bone marrow failure syndrome, as well as some non-acute myeloid neoplasm like MDS and MPN. So this is our own data. We have sequenced 309, this is a little bit old, but till that point of time, we have sequenced 395 patients of adult AML. We found out what are the more common mutations in our setup. But importantly, nearly 90% of our patients did show one mutation. So if you apply a case of NGS, if you apply NGS, you can classify, you can prognosticate, or you can at least find a mutation in nearly 90% of the AML patients. This is going to be, let's keep this. So now we come back to our patient. Remember, this is the case of AML with monocytic differentiation. He did not have any cytogenetic abnormality. This is the NGS report. There are 5 mutations, as you can see, some RAS pathway mutations and BCOR and U2AF1. Any resident can now tell me that what is the diagnosis now. Your options are here. Another chocolate awaits, I think. Can anyone tell me what this diagnosis is? Okay, so the diagnosis, of course, is an AML with myelodysplasia related. The reason why I'm showing this case is because in this case, we didn't show any morphological dyspoisis, right? We did not see anything on cytogenetics either. But in NGS, there are a couple of mutations here, BCOR and U2AF1. So Dr. Gujral has said that in WHO now, we have gene mutations that are classifiers, that are really labelers for the case as AML with myelodysplasia related. There was a paper in, I'm forgetting the group, but in Blood in 2015, where they showed that these mutations are very specific for secondary AMLs. And if you use this criteria, you can actually detect a significant number of AML with myelodysplasia related, which are going to be missed otherwise if you just use morphology and cytogenetics. And why this diagnosis is important? Because these patients usually do very poorly. And there even might be a therapeutic indication because we now know that the azaven based of therapy instead of 3+7 might be used in certain percentage of these cases. So this diagnosis is really, really critical. And now if you go into genomic heterogeneity, a very busy slide, you can just understand that there are a host of genomic abnormality that can be seen in AML. Some of them have been included into the WHO classification. Our case will belong here, acute myeloid leukemia, myelodyspoisis related. So that was how a NGS can help in diagnosing a case. You know, this is not, we are not talking about prognostication or anything. This is diagnosing based on the biologic attributes. Now, if we go a little bit in detail, this is our cohort of NPM1 mutated AML, which was the most common AML in our setup, which is again, this is commensurate to worldwide literature. So in our setup, there was 110 NPM mutated patients. So what we did, we wanted to know whether all these NPM mutated AML are the same or not. So we saw that NPM1 mutated AMLs also express other mutations. So for example, 50% of them has a DNMT3A, not 50% of them, they frequently have DNMT3A mutations, and among those DNMT3A mutations, 50% do have a hotspot DNMT3A, which is known as R882. So when we looked at the overall, looked at the prognostic outcomes, so we saw that only the R82, not any other DNMT3A, were associated with poorer overall survival, poorer relapse-free survival as well. Similarly, the presence of IDH2 mutation indicated a good prognosis for this NPM mutated AML group. So now we have diagnosed this case as NPM mutated AML as per as WHO, but can we go further using NGS? Answer is yes, of course we can. So using all this, we build a machine learning based algorithm where we said that these mutational features, including FLT3-ITD, DNMT3R82, IDH2, they can actually substratify NPM mutated AML as well, and they have a significantly different prognosis based on this mutational level. So we talk about clinical context, right? So patient have what kind of clinical features. Based on that, you are going to diagnose. That is a very important thing. We talk about morphologic context, like what are the morphologic cells and everything. Now you have to know not only one mutation, the overall molecular context. So it is an NPM mutated AML, but what is the other molecular context? So based on everything, the prognosis will depend. So we have talked about diagnosis, we have talked about subclassification and prognostication. Let's keep this thing. This is just our approach. I've already discussed what we do basically. Okay, so let's go to another case. This is a hypothetical scenario. This I think we have discussed yesterday in the workshop, so whoever had attended the workshop, this will be kind of a repeat. So if you have a patient with persistent cytopenia, the diagnosis, and there is no dysbiosis, no cytogenetic abnormality, and then the diagnosis will be a cytopenia of undetermined significance. So can we do anything else in this? And this is a very common situation, to be honest, because we have cytopenia patients who may not reach an oncology hospital, but a hematologist is often faced with this kind of conundrum that a long-term cytopenia cannot be explained with anything else. Cytogenetics is normal, bone marrow do not show dysbiosis. Do we say they are normal, or what you can do? So if you identify a mutation, they are automatically labeled as clonal cytopenia of undetermined significance, or CICUS. Is there an importance of this? Of course there is. So this is the data from Malcovetti group, the French group in Blood, that was published in 2017, where they followed up 683 patients of cytopenia, and the patient that had a CICUS defined as any mutation, they had a significantly, you want to say anything, Jilson? No. They had a significantly higher chances of transformation to MDS and AML. So therefore, in this context, this mutation identification is really, really important. That tells you that which of these patients are more likely to transform into AML. Yeah, maybe we'll skip this. So we can go even earlier than that. So what if there is no cytopenia at all? So we now know that there is a condition known as CHIP, or clonal hematopoiesis of indeterminate significance, which happens normally in human body. Like if you take more than 40-year-old human, almost 10 to 40% of them will have a mutation in a myeloid associated gene, which is known as CHIP. The evolutionary purpose of this is that as we age along, what happens is that the repertoire of our hematopoietic stem cell pool reduces. So our body cannot keep pace with the need of producing more and more hematopoietic cell. So they might acquire a mutation in a gene that gives them a proliferation advantage. So let's say TET2. So then TET2 gives them a proliferation advantage, and that thing proliferates. So that is the evolutionary purpose. But what happens is they can progress to myeloid neoplasm. So these are some of the common mutations that you can see in CHIP. The diagnosis criteria is that allelic frequency should be at least more than 2%. So this is again just to show you that CHIP-associated mutations, they do have a higher chance of progression to MDS and AML, even in normal human being. And also they have a higher chance of association with non-hematologic deaths, such as the CVS mortality. Actually, they were identified this way. It was a population-based study where they wanted to look at what are the things that predispose an individual for a CVS associated death, ischemic death. And one of the factors were this CHIP mutation. So they are associated with other abnormality as well. In fact, now there are some theory that it might indicate your mutational aging of your body, which is a component of your biologic aging. But these things are still in research. But this is a very important concept that you need to be aware of. So this is just a conceptual model. A clonal hematopoiesis can then progress to a clonal cytopenia, and then can progress to a myelodysplastic syndrome or a secondary AML. So that is why it is important to know them at least, and then re-stratify them accordingly. So with this, we'll go to case 3. If there's any question, you can stop me anytime. Like if you want to discuss anything about CHIP, we can take them now. This is a 62-year-old female presented with cytopenia, basically. Again, a case we have discussed yesterday. quite hypercellular marrow. There was some features of dysbiosis as well. Blast was there, but not approaching 20%. So there was around 12% blast. There was some dysbiosis. The diagnosis on bone marrow was given was an MDS with increased blast 2 in the context of cytopenia as well as dysbiosis and increased blast. But when we did NGS, what did we find? We found a lot of structural abnormalities. So this is an NGS-based copy number alteration that you are seeing. Here, this is the median number of coverage of each chromosome. So based on this, we can say what chromosome is deleted and what chromosome is amplified. So there is 5q is deleted, 7q is deleted. But even more importantly, 17p is deleted. So this is a location where TP53 gene resides. And this is, again, just to show you that part of 17p was deleted in this case. And when we went to target sequencing, we found another mutation as well in TP53, so which was with an allelic frequency of 52%. So what is the importance of this diagnosis in this patient? This is a patient of MDS, right? So the importance is we know that this is known as MDS with biallelic TP53, where you have 2 hits of TP53 mutation. One was mutation in our sequence mutation, the other was deletion in our case. And we know that they are different to monoallelic TP53. This is a very large data set coming from Eli Papamanu's lab in Memorial Sloan. So what they did is they showed that the monoallelic TP53 and the biallelic TP53s, they had a significantly different biology. So if you see that the proportion of cases with complex karyotype was much higher in biallelic TP53, the proportion of cases that had other mutations were much lower. So it indicates that monoallelic TP53 by itself is not a disease-causing event. Only when it becomes biallelic, it is an important biologic event. So that is okay, that is for biology, but does it translate into a clinically meaningful thing for us? Yes, it does. So if you see the, their overall survival, so not the monoallelic, only the biallelic TP53, they were associated with a significantly poorer overall survival, a significantly higher chance of transformation to AML. So therefore, this now becomes a definite entity defined by NGS, where you can find out biallelic TP53. And this has, as Professor Gujral has showed, this has now translated into WHO classification as well, where they have recognized this entity known as MDS with biallelic TP53, as well as SF3B1. So genomic mutations are important for subclassifying MDS as well. So we saw an example of AML, we saw an example of, I will skip this, MDS. What about lymphomas? In lymphomas also, it happens, like if you see diffuse large B-cell lymphoma, we now know that there are data from at least 3 centers that have come up, and total number of patients will be close to 2,000. So 2,000 patients have been sequenced, but they have found that this DLBCLs can be classified into one of these groups, and some of them bear biologic similarity to a precursor condition, like the N1 group is like a CLL thing. Then these MCD group, they mimic some other low-grade lymphomas. So that way you can classify them. And like Dr. Gujral was saying in the morning, how do they translate into clinical implications? So, one of the reason why the ABC and GCB subtyping of DLBCL was here since 2000, since 1999, I think, when Ash Alizade's paper came. So till now, why it is not in clinical practice? If Dr. Gujral said that we do not need to do it. It is desirable but not essential, even in WHO 5 in 2022. The reason is no clinical trial till date has showed that classifying them in this way can improve survival. So if you see this Phoenix trial, where they added ibrutinib to either ABC or GCB subgroup, but they did not translate into superior survival. But when you look at this is retrospective, not prospective trial, but look at some subgroups of DLBL, look at what ibrutinib is doing. Ibrutinib addition at 3 years event-free survival is 100%, 100% in DLBL. So that is an unheard of figure in DLBL, but of course this needs to be proved in a prospective setting. But it gives a lot of hope that molecular classification beyond ABC, GCB may be the way forward to subclassify and prognosticate DLBCL. This is just a report of our lab. I'll skip this. So that was some examples how NGS helps us in not only diagnosis, classification, and prognostication in areas of hematolymphoid neoplasm. We discussed some case of AML, some of MDS, and some DLBL. So let's see, can it be helped in monitoring? So what is the concept of measurable residual disease? So this concept basically is that when before treatment, there are the most of the marrow or most of the other part of the body where the tumor resides is going to be full of blast, full of the leukemic cells, so it is very easy to identify them. But as you direct therapy, we see that only some of these cells remain. So if you can pick them up at this point of time by techniques more sensitive than morphology, this is known as measurable residual disease. So let's go to a case. This is a 52-year-old male who was diagnosed with AML. Again, FISH karyotype was negative. Again, on mutation analysis, this is an AML with myelodysplasia related because BCOR STAC2 mutation was there. But if a question is now asked, what will be the appropriate strategy to identify MRD in this patient? So one of the strategies is in NPM1 mutated AML is a qPCR, which you can use. For AML that have fusions like 821, you can use again a PCR-based method. But for this kind of mutations, you cannot use PCR because they don't have a known hotspot either. So either you can make a patient-specific probe, but then again, how many probes are you going to make for each patient, right? So for these cases, the answer is a next-generation sequencing that can be used to not only diagnose and classify, but also monitor these patients. So this is some of our data. I'll fast this. This data was produced as part of the Wellcome Trust grant received to Dr. Patkar in our lab. So we basically what we did is we followed these patients. We did NGS MRD at post-induction and post-consolidation time points. We did flow MRD as well, and we saw that sure enough, NGS MRD at post-induction as well as post-consolidation time points did stratify the patients into superior and inferior overall as well as relapse-free survival. And when we combine this with flow cytometry, what we saw is that what is really the best is negative by both of the methods. They do really well, these AMLs. But if they are positive for either of the technique or by both of the techniques, their prognosis was much inferior than being negative. So it seems that NGS MRDs could be the future standard of care in patients of AML, and much more, efforts are going on to really unknow which is the most important technique in this context, which is the most useful technique in this context. Another way to do similar thing in DLBL, we can do by cell-free DNA. We can actually even diagnose those cancers early, and we can definitely monitor. There are a host of another application of cell-free DNA I'm not going into because we don't have that time. This is the data in DLBL from the Stanford lab, where they have shown that presence of circulating cell-free DNA after 1 or 2 cycle of therapy, they can prognosticate these patients into really significantly different survival. So again, monitoring using molecular techniques that's happening in this context. And finally, let's discuss an example how they can directly implicate in therapy selection. How are they going to? Can this be done? So you cannot discuss this without discussing CML, of course, because this has really become the poster boy of all translational medicine, and for good reason as well. If you see this, this curve, before imatinib introduction, the overall survival of CML used to be 10-year overall survival in the range of 50-60%, which is now, look at the 5-year survival, it's beyond 90%. So imatinib has really improved significantly the survival of CML patients, and this has really become a poster boy of all translational medicine. But let's go ahead with the case. This is a 12-year-old male, a fever for 1 week. We had some, this is the count, blast, negative for MPO, B markers, 10, 19 positive, 17, 22 positive, no problem whatsoever, BLL. So what do we do in this? We discussed yesterday, so the bare minimum that we should be doing is ploidy and BCR-ABL. Dr. Gujral said BCR-ABL must be done because they identified a therapeutic opportunity. So we did that, they were negative for everything else. So can we do anything else? So this is the typical, investigation strategy in a case of BLL, but is there a way to go forward? Is there a need to go forward? The answer is yes, because there are a significant number of BLL cases that will be negative for all of these, and there may be some of these cases that are potentially actionable, so-called B others. So how do you identify these B others? So the way to do it is using targeted RNA sequencing. This is again a technique developed in our lab. We like to call it NARSIMA, where we can identify, any fusion partner of a known gene. So, for example, if you are using KMT2A as a one primer, the other primer is a universal one. So it will identify 100 fusions of KMT2A gene, whatever fusion is there. So we just need to know one partner of it. This works on the principle of anchored multiplex PCR. So we did in this case, what we found out is a NUP214 ABL1 fusion. Now this next question, and this category now is defined in WHO as BCR-ABL like BLL. So next question, whoever answers gets the biggest chocolate of the day. Can anyone answer this question? Don't you agree that this is a very weird way of classifying a disease, BCR-ABL like BLL? Why would you say so? Means you could have said this is the BLL with NUP214 ABL1. Why BCR-ABL like BLL? These are your options. What do you think? And the reason why I am enforcing on this is very fundamental. This is as long as we go on and produce more and more DNA, RNA, epigenetic data, this kind of concepts are going to come. For example, now we even have a double hit like lymphoma in the space of large B-cell lymphoma. So what is the principle of this like? So the answer lies in the basic, if you go back to the biology, central dogma of biology, you know that DNA becomes mRNA and then it becomes protein, right? So a philosophical question is, what really is the most important? What change is really the most important? What really determines your clinical behavior? Is it DNA mutations, or is it what happens in gene expression level? Because if you think of it, when you do not have a somatic mutation, all cell of your body have the exactly similar sequence. So how does a nose cell, for example, is completely different from a cell of a skin? So the answer is that their gene expression is completely different. So gene expression might be a very important step. That also might be a component of clinical behavior determination. So these neoplasms, they do not have BCR-ABL. That is, at DNA level, they are different to BCR-ABL. But at RNA level, their gene expression is exactly similar to BCR-ABL. So that is why they are known as BCR-ABL-like BLL, because their gene expression profile at a transcriptomic level is exactly similar to BCR-ABL positive BLL. And why this diagnosis is important? They have a poorer prognosis. This diagnosis is really complicated. It requires complex laboratory analysis. If you see, this is the St. Jude data of close to 2,000 children, and this is the clustering according to gene expression. Look where the pH-like is. So this is pH, which is in pink, and this brown is pH-like. So they tightly clustered together with pH-positive BLL, and that is the reason why they are labeled as pH-like BLL. So, okay, I'll skip this probably. What suffice it to know that they do have poorer prognosis, but why this diagnosis is so important is these kinase rearrangements are actionable. So if you see, a host of this group, they do respond to dasatinib or TKI, and some of them might even respond to a JAK2 inhibitor. So for example, in our case, this was our case, NUP214-ABL1, if you remember. So at post-election time point, the patient had a significant disease of 10.5%. But at this point of time, the patient was given a TKI, and look what has happened. This patient now has gone into a durable remission, and then this patient could have been taken to transplant as well. So this is the importance of identifying this disease, where NGS have directly impacted therapy in this context, not only diagnosis, but what therapy should be given. So in the end, I will just talk a little bit about what I think could be the future. So there are many techniques, more are coming. For example, the CRISPR-Cas, we all know, Emmanuel Charpentier and Jennifer Doudna was awarded the Nobel Prize last year for this. And the application of this is now coming on in cancer diagnostics as well as cancer therapeutics. This is very important actually. Look at how the cost of genomic sequencing is going down. So this is Moore's law, which says that as you go along, maybe the cost will be half. But this has even beaten the Moore's law. Look how the sequencing cost is going down. So now we have a NovaSeq X from Illumina, which claims at $200 per genome. Ultima Genomics is even claiming $100 per genome. So in the future, a broad spectrum test like whole exome or whole genome might really be the direction where we are going. And like Professor Mehta said, we might finally be knowing a comprehensive view rather than just scratching the surface. So this is the data again from the Papamonu's lab, where they've shown a clinically it is possible to do whole genome sequencing with a 9-day TAT, and you can give more information on this. Some other techniques that are coming up is single cell and spatial genomics. We don't have time to discuss, but these are also a future technique. Those might be used. So finally, to end, I hope combining yesterday and today, you have finally got the point that a hematopathology role is really today's date central in hematology, where we can diagnose, we can re-stratify, we can prognosticate, we can identify targets, we can monitor. And therefore, intelligent use of molecular technology is really becoming inevitable. It's important to know this test. If it is possible, try to develop some informatics skills as well, which are going to give you more cheaper and more democratic broad spectrum molecular test. And finally, maybe we will be going to an era of molecular targeted therapeutics. So with this, I will end my session today. This is again our lab, a very big lab. Many pictures have already been shared with you by Dr. Gujral. So this is Dr. Nikhil Patkar, who some of the data that I showed were completely part of his project. Dr. Prashant Tembare is there. This is our senior technician who has now left, who has now retired, and Mr. Ashok, and this is Mr. Sitaram. This is Professor Subramaniam, who is the voice in our lab. Dr. Gujral is missing in this, but he often comes, and then we take another photo. So we'll take any question at this point of time. Or maybe we take question after this, no? After the full session.
Yeah, we have a combined session for the question answers. Thank you, Dr. Gaurav, for giving us an overview about the role of genomics in the hematolymphoid neoplasms. And the message is that we have to move beyond the morphology and immunophenotyping for the complete workup of patient. And genomic technique, especially NGS, can help us in diagnosis, therapeutics, as well as in the prognosis of patient. So with this, we move to the last talk of this session by Dr. Ramchandra Adhikari, who is a professor in the Department of Pathology, Maharajganj Medical Campus and Tribhuvan University Teaching Hospital, senior consultant pathologist in the HAMS Hospital, senior consultant pathologist in DI Skin Hospital and Referral Center, ex-Vice President, Association of Clinical Pathologists of Nepal. He has multiple publications in national as well as international journals with a special interest in dermatopathology. So Dr. Adhikari is going to talk about cutaneous lymphomas, case-based discussion. Dr. Adhikari, please.
Good afternoon, everyone. Thank you, both chairpersons. Ladies and gentlemen. So, can I have this? Okay. After this molecular discussion, NGS, I am coming to a simple HNE slides. Okay. So, today I am going to discuss purely cases that I have seen, I have reported, and the problems I have encountered during reporting. I am going to share my experience with you, and I expect that probably junior pathologists and residents will be benefited from this. And some of you have already seen these cases, similar cases I mean, and those who have not seen will see in near future if you practice the pathology. So today I have included 6 cases of cutaneous lymphoma and 4 mimickers of cutaneous lymphoma. So from fluid, from bone marrow, we are coming to a solid tissue now. So before starting, I would like to thank Professor Kemp, who is regularly doing immunohistochemical staining and molecular studies of my cases. And I am thankful to Dr. Mahesh Shah and Dr. Smita Joshi, who have provided me clinical details of the patients. And finally, I would like to thank my lovely residents, Ankita Simkhada and Rituraj Baral, who took the photos of the microscopic slides and collected the clinical cases as well for me. And these are the books I usually refer when I think of the cutaneous lymphoma. I do not diagnose cutaneous lymphoma unless and until I see a clinical picture. Okay, my diagnosis is based on clinical findings as well as morphological findings. So this is the historical book, first book written in cutaneous lymphoma globally. So how frequently we see lymphoma? There are couple of case reports. I personally diagnose less than 5 cases of cutaneous lymphoma per year. And this is also one historical article published in यसले काम गर्दैन नि हाम्रो अलि अलग देऊ त बाबु okay. So this is published in 1998 in Journal of Nepal Medical Association, and this was the first article published when I searched on PubMed and Google. Okay, this one of the author is my Professor Harigovinda Shrestha. He is unfortunately not here today. And this is the 4th edition classification, 5 is coming. But I prefer this one because this shows the behavior. Some mycosis fungoides CD30 positive, and these are these lymphomas have indolent clinical behavior, while others have little bit more aggressive. And this is newer 5th edition coming, probably almost same, nothing much added. This primary cutaneous peripheral T-cell lymphoma, NOS, was added. It was not in the previous edition. And I was expecting this one. It came out, but I was expecting one more. Primary cutaneous DLBCL NOS. I was expecting, because sometimes I used to see these cases. There are good number of case reports, and some of the books mention also. I was expecting primary cutaneous DLBCL NOS in this 5th, but it's not there. This is long list of lymphoma mimickers. I'm not going. This is case 1. Okay. So this is 70-year-old lady. She has some plaque-like lesions. You see here. Some maybe patch, some plaques. Trunk, arm, legs since 4 years. Indolent clinical behavior. Indolent clinical behavior. So these are the clinical diagnoses provided to me. Psoriasis looks like parapsoriasis, MF, maybe leprosy also. So QAH was negative, AFB stain negative. Incisional biopsy was done and reported as some dermatitis, spongitic dermatitis. And patient got some treatment but no improvement. And repeat biopsy was done, and this is what I got. This is what I got. This is okay. Probably you are more close to the HNE slides than the molecular, I think. Okay. So you see, this is epidermis. I can see high. Some band-like lymphocytic infiltrate. I can see it here, and some maybe collagen here. This is some lymphocytes going to the epidermis. Some hallowed areas also you can see, and some little bit of collagen and band-like. This is beautiful derriere nest. Beautiful derriere nest. Probably these are the atypical lymphocytes making a nest within the epidermis, derriere's nest. And around somewhere you see a hallowed type of, bacillar type of this epidermotropic cells, and this is derriere. This is another picture showing again hallowed lymphocytes in the epidermis. This is dormal component, lots of atypical lymphoid cells. So with this, see, this is all what I have. And you see, these are the clinical diagnoses. I do not agree with most of them, and I agree with MF. Okay, I have reported this as a cutaneous epidermotropic atypical lymphoid infiltrate, favors mycosis fungoides. Favors. So I have not finally given any diagnosis, just it favors mycosis fungoides. Some atypical cells I see, which are atypical lymphoid cells, which are epidermotropic. And based on morphology, it can be a lymphomatous papulosis type B and D, and primary cutaneous aggressive epidermotropic CD8 positive cytotoxic T cell lymphoma. But these both entities are incompatible with clinical pictures. I have shown you. Incompatible. They are not the diagnosis. Only morphology is compatible, but clinical not compatible. That's why I see the clinical picture before diagnosing cutaneous lymphoma. And I have sent the paraffin block for ISC. So CD3 is positive in most of the cells, CD4 positive, CD8 negative. First diagnosis is now done. So with this clinical picture, these morphological pictures, this ISC diagnosis, mycosis fungoides, plaque stage. And this is where this disease stands in WHO classification. She got some treatment, and after treatment, these plaques disappeared. There are hyperpigmented areas, you can see it here. Later on, almost disappeared. She is responding to the treatment. And after 6 months, she developed a classical Hodgkin lymphoma of right inguinal lymph node, which was Epstein-Barr virus positive. And she was referred to the medical oncologist. Okay, before starting the another case, if you have any questions, we can discuss right now. Otherwise, if I move to the case 2, we'll together forget the case 1. Okay? Lymph node, inguinal lymph node. 6 months later of the diagnosis of MF.
Because patient is on methotrexate.
Yeah, maybe methotrexate. EBV positive, yeah. So this theoretical part I am not going to discuss because probably there is less time. This is just a picture. See how pairs like MF. This is, you remember, sun protected area. MF occurs in sun protected area in the beginning, not sun exposed area. This is patch. Okay, this is plaque stage. This is tumor stage. Okay, so morphologically patch stage sometimes may be very subtle. You see few hallowed cells, very difficult to make a diagnosis. Okay, you need a ISC, some. Okay, little bit of lymphocytes you can see even in the dermis patch. It is plaque. You see a full blown. You see a derriere nest. You see a band like collagen. Everything you see in patch stage. Tumor stage, epidermotropism may be lost. So this is the ISC, and if you do some molecular stage, there is monoclonality of TCR genes. So prognosis is indolent. Now case 2. Any questions regarding case 1? Okay, case 2 then. This is 55-year-old female. You see, she has lesion everywhere. There is hair loss also little bit. I can see 4 months history. This is another picture you see here. Abdomen here. This is extremities. These are the diagnoses. Clinical diagnosis. Allergic contact dermatitis, psoriasis, MF. And 2 biopsies were taken. I received only 1, but this is report of the biopsy sent somewhere else. Spongitic dermatitis. I love this term. Others also love, I think. So this is everything what I received. Punch biopsy. Little bit artifactious because of the technical maybe error. You see 2 hair follicles, I see some collagen in between, some lymphocytes, that's all. Nothing much here. Some edema, spongiosis or spongiosis maybe this one, little bit. Maybe mucin, I am not sure.Maybe mucin, I have to do Alcin blue for that. And some little bit of fibrosis lymphocytes here. Some lymphocyte going into the hair follicle as well. This looks spongiosis. That's why the diagnosis of spongiatic dermatitis was made. You see here, some lymphocytes going into the, and I sourced, are there any epidermotropic lymphocytes? I found only few. I say there is no epidermotropic, it's correct. Only 2 cells. I don't know whether they are typical or not, I'm not sure. But there are few. And I did Alcin blue stain, which is beautifully positive, you see. This is not follicular spongiosis, this is follicular mucinosis. Now I'm sure this is follicular mucinosis, you see. Mucin everywhere. Around the hair follicle as well, increased mucin. See, these are the clinical diagnosis. Here my opinion is folliculotropic. Maybe minimal epidermotropic, you may write, you may not write. A typical lymphoid infiltrate with follicular mucinosis. Strongly suspicious for folliculotropic mycosis fungoides. Strongly suspicious, I am not sure. But for me, follicular mucinosis is synonymous to the folliculotropic EMF, at least for me. This is, I have taken from Cerrone. He says this mucin deposition is almost invariably found in head and neck area. Almost invariably. And I have reported only 2 cases of folliculotropic EMF till date, and in both of them, there is follicular mucinosis. That's why this is synonymous for me. And there are so many other cases I have of follicular mucinosis, only few I have copied here, but there are so many. So I have sent the block for ISC, and you see, almost all cells are CD3 positive. They are folliculotropic everywhere you see, outside the follicle, inside the follicle, everywhere you can see. Most of the cells are CD4 positive. And these lymphocytes are CD8 negative. And a few cells are CD30 positive. So with this, diagnosis is clear. CD3 positive, CD4 positive, CD8 negative, diagnosis is made. You see, diagnosis is folliculotropic mycosis fungoides. And I requested to do some molecular, with which I am not familiar with this technology. I am not doing this, I don't know it. But they have written some monoclonality here. Monoclonality that favored the diagnosis. And patient visited some hemato-oncologist, admitted in TH, got bone marrow also, which is free of tumor. And currently, she is getting some radiation therapy. I don't treat the patient, I am not aware of this treatment modality. And I called the patient few days back. She told me that she is getting better, and I requested to send her a photograph of the lesion, but she didn't. You see, there is where this disease stands. Now this is just opposite, head and neck region. Folliculotropic, mostly head and neck region. Sun exposed area, not sun protected area, remember. Mycosis fungoides is sun protected area, while this variant is sun exposed area, head and neck mainly. So these are some papular, some plaque, some only hairless, some pictures I have taken from the books. This is how it looks like. Some mucinosis again, folliculotropic lymphocytes plus mucin, as in my case. This is immunophenotype. Okay, that's all. Any questions regarding case 2? If not, I am going to case 3. This is very young boy, 11-year-old. Some papular lesions. I have probably, this is papule with central necrosis. I say necrotic papule. Not a patch, not a plaque, not a nodule. It is a necrotic papule. Okay, remember, this is important. So these are the clinical diagnoses I received in the form. You see, deep mycosis, mycobacterial infection, lymphoma, and LCH. This is the lesion. So this is everything what I received. Subcutis looks pretty okay, no infiltrate. Almost full thickness dermis is involved by these blue cells, lymphoid-like cells. You see, but closer view, you can see a little bit of epidermis here. Some red collagen I see, otherwise everything is occupied by a lymphoid cells. See this, I can see some spongios in the epidermis, some eosinophils, some neutrophils are going into the epidermis. I can see some eosinophils here, some large cells, some large cells. This is dermis, good number of eosinophils. I want to show, there are lots of eosinophils, you see, everywhere eosinophil, and in between large, some histiocyte-like cells, I say, or lymphoid, large lymphoid cells, any name can be given. Okay, this, some groups I see, maybe some multinucleation somewhere, some group, lots of eosinophils here in between. Some look like a histiocyte, some look like a large lymphoid cells. You see, beautiful, these eosinophils look very beautiful. Persistence, there is no fungus, Zn is negative, Giemsa is negative for, and these are the clinical differential diagnosis again. And infective procedure is less likely. But I have reported this, cutaneous atypical lymphohistiocytic infiltrate with frequent eosinophils. That is my conclusion. Okay, I have not given in, I thought of LCH, number one LCH, in my opinion, this is LCH. And I can't rule out the possibility of lymphoma. Okay, so I requested patient for the follow-up report, for amendment report, then I have sent the block. CD1A I have requested because I thought of LCH, and I have requested to do a CD1A and SN. It looks like some Langerhans cells are positive in the epidermis, but this dermal infiltrate is negative. SN is also negative. Oh, then I am lost, you see, I am a little bit frustrated also, because I thought of LCH. Now I have only one diagnosis left, lymphoma only. Maybe cutaneous lymphoma, I say. Only one diagnosis left, and I requested to go further. CD3, most of the lymphoid infiltrates are beautifully positive for CD3. CD7 is also positive, CD4 positive, but less number of cells. CD8 negative, 20 positive, 20 negative, sorry. CD30 positive, 50% around cells, CD30 positive, ALK negative, and now I am little bit confident to label this disease as a CD30 positive lymphoproliferative disorder. Okay, WHO, this mentions only two diseases. Because cutaneous is little bit, cutaneous lymphoma is little bit different from the nodal lymphoma. Only two diseases. Lymphomatous papulosis and primary cutaneous anaplastic large cell lymphoma. Both can spontaneously regress without any treatment. And probably some cases of MF also CD30 positive, some cases. So these three differential diagnoses. Now, if it is MF, clinical findings incompatible. With necrotic papule, we never make a diagnosis of MF. Incompatible clinical findings. That's why I see the clinical picture before diagnosing. Age 11 years old. Unlikely this is. CD30 expression, strong expression here, which is not common in MF, but may be seen, not common. CD7 expression not seen in MF. That's why I don't think of MF. It is not MF. Primary cutaneous anaplastic large cell lymphoma presents with a nodule, not a papule, not a plaque. Clinical picture again incompatible. I should not make this diagnosis when clinical picture is not compatible. And in primary cutaneous anaplastic large cell lymphoma, 100% cells are CD30 positive, 100%. Book says more than 75%, but in practice it is 100%, which is not in this case. Though I am left with only one diagnosis. So with this clinical picture, young boy, necrotic papule, this HNE, this ISC, diagnosis is lymphomatous papulosis type A. Type A. That's why there are lots of eosinophils. So this is where this disease stands, lymphomatous papulosis. This disease can clinically present as a papule, and it can resemble any form of the cutaneous lymphoma. That's why the term lymphomatous papulosis. It can resemble any form of cutaneous lymphoma. Okay, that's why the type you see. A, B, C, D, E, F, G, H, I, so many types. Okay, ours one is type A, DD is arthropod bite reaction, and type B resembles with MF, type C anaplastic large node, type D aggressive epidermis CD8 positive cytotoxic T cell lymphoma, type E NK T cell lymphoma, external NK T cell lymphoma. So it resembles any form of the lymphomas. Any form of the lymphomas. Sometimes maybe difficult, we need to follow up the patient. Because the hallmark for the diagnosis of lymphomatous papulosis is the spontaneous resolution. No treatment is required. So this is again, I have taken from Cerrone, Lorenzo Cerrone, and typing of the lymphomatous papulosis do not have any prognostic or diagnostic implication and should not be included in the report. Typing is not required. The hallmark of the prerequisite for the diagnosis is the spontaneous resolution of the disease, which is observed within a few weeks or months without any treatment. So you have to follow up the patient for a definite diagnosis. So I don't have a follow-up data of this patient. Some clinical pictures from the book, type A, type B, type C, type D, type E, type F. This picture is important. You see, that you can see a epidermotropic lymphocytes here. Epidermotropic. These morphological findings can be seen in MF as well as lymphomatous papulosis. But clinically they differ. If you see a papule like this, it is lymphomatous papulosis. If you see patch like this, it is a MF. Clinical presentation is important. Morphological may be same. Case, I'm going to next case if there are no questions. Okay, case 4, this is old, 81-year-old male. You see everywhere looks like a lymphoma or metastasis everywhere. Nodules, multiple of variable size, almost all over the body. There are some more photographs, swelling of the legs and hands. So this is probably not important. Clinical diagnosis. Number 1 is lymphoma here. Number 1 is lymphoma, you see. Maybe tuberculosis, leprosis, disseminated cutaneous metastasis. I say this is last one. Clinically, if I see the patients, this is more likely diagnosed. This biopsy was taken from the thigh. This one. And this is what I received. This is what I received. You see, little thin epidermis, you can see it here. And entire dermis shows some diffuse to vague nodular infiltrate. And that has involved the subcutis as well. Full thickness epidermis, dermis and the subcutis. Okay, in this magnification, I don't see the epidermotropism. You see, this is more closer. No much epidermotropism, no hallowed cells here. Everything in the dermis and subcutis. This is little bit closer view. Most of them look large. These are large lymphoid cells, almost monotonous. You see, in the subcutis, they have involved the subcutis as well. I have reported as a lymphoma. Okay, large cell lymphoma, nothing else, because I have no doubt that it is a lymphoma. Further typing is required. I have sent the block for ISC. CD2 is positive in 100% cell. CD3 is negative. CD3 is negative, which is a good T cell marker. CD4 is also positive. CD8 negative and CD30 positive in 100% cell. 100% cell. So again, there are some more. ALK negative and Ki67 in 90%. Okay, again the CD30 positive T cell lymphoproliferative disorder. And again, same differential diagnosis previous. And you see, lymphomatous papulosis incompatible. Clinically incompatible, I mean. And 100% CD30 positivity is unusual for MF, for lymphomatous papulosis also. So with this clinical projection, this morphology, this ISC diagnosis is clear. Primary cutaneous anaplastic large cell lymphoma diagnosis is clear there. This is where this disease stands in WHO classification. These are some pictures from the book, microscopic pictures. This is also indolent disease, okay, indolent behavior. Okay, I am going to the next case if no questions. Case 5, you see, this is 33-year-old male, 33. And some cutaneous lesion I can see here. Mostly nodule, maybe some plaque. And I see some lymph node also here. Lymph node. Here also one lymph node. There is a scar of previous biopsy. Lymph node. And patients has this skin lesion since 2 weeks, but he has a lymph node since 1 month. Lymph node enlarged before the skin lesion appeared. Enlarged lymph node since 1 month and 2 weeks after 2 weeks only, 2 weeks history only for this skin lesions. These are some plaque-like lesions also here. And anteriorly also you see some lesions, some nodular lesions. So these were the biopsies reports. Patient had it. So one is lymph node biopsy. Lymph node biopsy is conclusion is C description, C micro description conclusion. Okay. Another is skin biopsy, diagnosis malignant hematolymphoid neoplasm. Malignant hematolymphoid neoplasm. Two reports from the same places. Okay, and when patients came to us, punch biopsy was taken. Clinically, diagnosis of hematolymphoid malignancy was written because it was reported before. And this is everything what I received. Punch biopsy I received, and everything blue from top to bottom. Everything blue. Full of this very busy dermis with full of lymphoid cells. Everything full, you see. This is closer view, most of them look large. Most of them look large. This is large lymphoid cells. I reported it as the large cell non-Hodgkin lymphoma, and usually I requested patient for amendment report after ISC. And this is the ISC. CD8 negative, CD3 also negative, some interspersed lymphocytes are positive, neoplastic cells are negative, and CD4 almost all cells are CD4 positive. CD3 is negative. This is CD30 again, CD30 beautifully positive. I am coming to CD30 again. ALK is also, once CD30 is positive, I request to do ALK also, in all cases, in skin. ALK is strongly positive. EMA, some cells are positive, membranous positivity, some cells are positive. So with this, Ki67 almost 40-50%, and this is the conclusion of the immunophenotyping, and diagnosis is cutaneous involvement of an anaplastic large cell lymphoma, ALK positive. Okay, there is nothing like primary anaplastic large cell lymphoma ALK positive in the skin. It does not exist, WHO does not recognize it. Once it is, because this patient has a lymph node also, enlarged lymph node before the skin lesion. That's why node is primary site. Lymph node is a primary site, and that has involved the skin. This is where this disease stands. Secondary, this one, secondary, not primary, secondary. And I don't have a follow-up data of this patient as well. This is some theoretical aspect. Okay, now next case, case 6. Okay, 43-year male, this one, SIV positive, SIV positive. And some nodules here. This photograph was sent to us by patient on WhatsApp. That's why quality is not very good. But you can see a nodule in any case. There is some ulcer which was covered by a gauze piece, and when you see, when it is open, it looks like this. But I don't know what is this. Is it neoplastic or non-neoplastic? I don't know, because biopsy was taken from the nodule, not from the ulcer. Okay, and there is no peripheral lymphadenopathy as per version of the treating physician. Okay, and I asked for CT chest or abdomen to see a lymphadenopathy, but it was not available. And later on, he developed some lesion on forehead also. Later on, okay, initially only in the leg. After 1 month, it developed some lesion in the forehead also. And incisional biopsy of right leg nodule was done. This is what I received. This is what I received. You see, I see a epidermis here and no infiltrate just beneath the epidermis. You see, there is normal collagen in the superficial dermis. And below this, there is diffuse to vague nodular infiltrate. This is another pictures. I can clearly see grain zone here, not involving the epidermis. There are no epidermotrophic lymphocytes here, only the dermis. This is another picture again showing this grain zone of collagen. This is closer view, looks monotonous. Most of the cells look larger. This is large cells, most of them. Okay, periacrine infiltrate, perifollicular infiltrate, destruction of the erector pili muscles by lymphoid infiltrate. And with this, I made a diagnosis of, again, same non-Hodgkin lymphoma large cells, okay, which is probably not very useful for the clinicians. I did a CD45. It's beautifully positive, membranous positive, maybe little bit of cytoplasmic. I did CD20 also, which is also beautifully positive, CD20. CD3, some interspersed lymphocyte positive, but tumor cells are negative. MOM1, almost 100% cells are MOM1 positive. CD138, I am not sure whether positive or negative, maybe patchy, little bit. BCL2 positive focally in some areas. Ki67 nearly 100%, nearly 100%. ALK negative. This is the summary of the BCL2 focally positive, 20 positive, 45 positive, Ki67 nearly 100%. So these are the differential diagnoses. When I see a large cell lymphoma in the skin, these are the differential diagnoses. And all of them are T cell, only this one is B cell. All of them are T cell. Our case is a B cell, which is cutaneous B cell lymphoma is not common. Okay, 15 to 20% overall. CTCL, cutaneous T cell lymphoma, constitute 80 to 85% of all cutaneous lymphomas. This looks like a B cell. I am left with only one here. And I thought of number one is primary cutaneous diffuse large B cell lymphoma, leg type. This is the only one DLBCL exists in WHO. In skin, I mean, not nodal, skin, I mean. And primary cutaneous diffuse large cell B cell lymphoma, I know it can be, but WHO does not recognize. There is nothing like this in WHO. But many books, there are so many articles, that's why I was expecting this to be included in 5th edition. Professor Gujral Purul can explain why this entity is not included. He can explain you well. I don't know. He's one of the author. He can explain it. Because I personally was expecting this will be included like primary cutaneous peripheral T-cell lymphoma NS was included in 5th. I was expecting that both of these, but it is not. And if lymph nodes are also enlarged, maybe secondary. But in this case, no lymph node enlargement. Okay? And to differentiate number one and number two, these books, Lorenzo Cerrone writes BCL2 is the criteria. Okay? If BCL2 is negative, it is primary cutaneous DLBCL NOS. If BCL2 is positive, it is leg type. Primary cutaneous DLBCL leg type. That's why with these findings, these clinical pictures, this morphology, this ISC, I have made a diagnosis of primary cutaneous diffuse large B-cell lymphoma leg type. Okay, mostly in the legs. 85% occurs in the legs, and later on can involve other areas as well. So patient was sent to the cancer hospital for treatment, and I don't have a follow-up data. So cutaneous most common lymphomas in HIV positive as per book is primary effusion, plasmablastic, Burkitt, and important things to know, in skin, B-cell lymphomas are more common than T-cell lymphoma in HIV positive. Okay, usually T-cell is much more common, 80 to 85%. But if HIV positive, immunocompromised, then cutaneous B-cell lymphoma is more common than cutaneous T-cell lymphoma. So this is mostly in the 85% in the legs. There are some from the books. If you have any questions, you can raise right now before forgetting this. Okay, then I am going to next case. This is 6-year-old young boy. Yes, it's not a papule, some maybe papule, but looks like a rash rather than a papule, for me at least. You see, multiple erythematous rash, maybe some papules since 2 months. Progressive from legs to ascending, from legs to arms, ascending. Mild itching, silvery hair since birth, development is normal. There's some more photographs, you see. Rash-like of things, almost all over the body. This is a long list of differential diagnoses, you see. GNOT, crusty, Hansen, LCS, lymphoma, everything. TB, sarcoidosis, everything. Long list. Okay, and they have taken a punch biopsy and they have put everything on my head so that I can give a final diagnosis, they can manage the patient. So this is everything I received. This is a bisected punch biopsy, bisected and processed to 2 halves. Okay, you see epidermis here, some infiltrate I see, blue cells, I have some closer photographs, little bit dilated plug, some lymphocytes. Here I see, you see basal cell layer is lost, like quinoid. Okay, interface inflammation, interface activity, you see, interface activity, lost basal layer. Okay, here you see even spinous cells were also lost. Spinous cells were lost. Some look a little bit elongated. I don't know whether they are epithelioid cells or not. I am not convinced at least. You see some lymphohistiocytic infiltrate, some cells look like epithelioid cells. This is another picture here. You see, spinous cells were lost, not only basal, spinous cells. There is evidence of some pigment incontinence, means evidence of basal cell injury, and lymphohistiocytic infiltrate. This is, you see, almost epidermis is perforated almost here by infiltrate. And the periadnexal also, there is around the eccrine ducts, in the subcutis also. So adipose panniculus, lobules of the panniculus also infiltrated by these lymphoid cells. So you see, I could not make any definite diagnosis. I reported is this lichenoid interface dermatitis with lymphohistiocytic infiltrate. I can't rule out gyanotic crusty syndrome. Morphology is very compatible with this. I can't rule out tuberculid also because there are vague granulomas. I can't rule out lymphoma also where they are epidermotropic. They have destroyed some of the spinous cells, basal cells of the epidermis. But I ruled out sarcoidosis, ruled out mastocytosis, ruled out LCH, ruled out Jansen's disease. But still, this report is not useful. It's not useful for dermatologist. And as usual, I have sent the again block. I did some stents which is not useful. And this is the report. I received CD3 positive and CD8 positive. All other markers, mycobacteria also ISC done, negative. All other markers 56 negative, 30 negative. Only CD3 and CD8 positive. CD4 also negative. Only 2 markers positive. You see. And with this, what should I do? Only CD8 positive. And CD3 positive, I say they are T cells and they are cytotoxic. That's much I can say. Their cytotoxic T cells are there. And I have a long list of differential diagnosis, you see, which is again not useful. No one wants multiple diagnosis. Everyone wants only one diagnosis. See, I say cytotoxic variant of the mycospongiosis. It can be 4 negative, 8 positive can be, but clinical picture is not compatible. It is not IMF. Very young person. Type D lymphomatous population is also incompatible clinically. Primary cutaneous acral CD8 positive lymphoma, which is usually seen in the earlobe, solid single lesion. It is all over the body. Again, not compatible. Primary cutaneous CD8 positive aggressive cytotoxic T cell lymphoma, it is also clinically not compatible because they present as a necrotic plaque. Necrotic plaque. Okay, this is an aggressive tumor. Number 4 is an aggressive tumor. Okay, it's not compatible. E is also not compatible. And fifth one, this disease is not recognized by WHO. Again, but there are good number of articles. Some of the books also mention this disease. Cutaneous CD8 positive lymphoproliferation associated with congenital immunodeficiency syndrome. It is one possibility, but we have to work upon this immunodeficiency syndrome. And PCR was done. PCR also says some monoclonality. I understand whether it is monoclonal or not. That's all in this report. And CD8 positive only 2 disease which is not compatible in this patient. And we are not sure about the diagnosis. That's why we have not treated the patient. We don't know the diagnosis, how can we treat? So no, treatment was given, only follow-up. Because we don't know the diagnosis simply. I could not help the dermatologist. At the time of biopsy, this was the lesion. After 3 months, this lesion disappeared. Disappeared lesions. Patient is not getting any treatment, you see. This is again at the time of biopsy, 3 months later. Some hypopigmented area, healing lesions you can see. This is at the time of biopsy, 3 months later. You see, these lesions disappeared. So what is the diagnosis now? Treatment is not required, patient is getting better. So my diagnosis in this case is gyanotic crusty syndrome, which resolves spontaneously. It resolves. But do we see this tuberculosis less likely? Tuberculosis also can have a spontaneous remission, but it takes more than 12 months, not within 3 months. Unlikely. This is also unlikely, and this third one I can't rule out. But I checked in the literature whether CD8 positive cells can be seen in gyanotic crusty or not. Yes, they can be seen. There are good number of articles published. Can we see monoclonality in zeanotic rusty? Yes, it is not pathognomonic of lymphoma. It can be seen. So with this, I have, with these clinical pictures beginning and after 3 months, these morphological pictures, I have made a diagnosis of zeanotic rusty syndrome. With follow-up only, not with the ISC or monoclonal studies, molecular studies, with follow-up. But still, zeanotic rusty syndrome usually does not recur. It is caused by virus, or if patient gets infected, another virus can recur. If patient gets some vaccinations, nowadays COVID vaccine can recur. Usually does not. Usually does not. But I told the dermatologist, you have to follow the patient closely. If it recurs, we have to work up on congenital immunodeficiency syndrome. I can't rule out this one. Because though this disease is not recognized by WHO. So this is some causes, some viruses, spontaneous remission 2 to 8 weeks. This is some clinical pictures from the book. Histopathology is very typical. Like in white, spongiotic, vascular, everything here. Bacular change, everything we saw. Morphology is compatible with zeanotic rusty. This is all. Do you have any questions regarding this case? Oh, I have to rush, or can I go slowly? If I have to rush, I will. 3 cases. Okay. So this is, I'll try to finish as soon as I can. There are 55-year female. She has some lesions, erythematous nodules, arm, leg, and she went many hospitals. You see, some reported as a granuloma, some leprosy, some treatment ATT, no response. This is, you see, looks like a nodule. Looks like a nodule. It is, for me, it is a lymphoma. Clinically, for me, it is a lymphoma. So provisional diagnosis given to me are lymphoma, sarcoidosis, tuberculosis, leprosy, some, this is non-contributory. This is what I received. This is what I received. Epidermis and BG dermis with lots of lymphoid cells, everywhere lots of lymphoid cells. Some look like a histiocyte, some epithelioid look, some lymphoid, some large lymphoid cells. Again, some little bit elongated, histiocyte-like, some large lymphoid-like. So this is the picture. I have reported it, this. Okay, it may be useful for you also. Dense diffuse dermal lymphohistiocytic infiltrate with vague granulomas. That's the report. I have signed out. Okay, and I have kept some differential diagnosis, maybe tuberculosis, maybe lymphoma. Again, useless report. Again, useless. Dermatologists do not like this report. Okay, PAST and not contributory, Jill Nelson not, and ISC CD3 and 4, small number of cells are positive, does not mean any, does not have any significance. Few cells CD8 positive, small number CD30 positive. Can be a atypical mycobacterial infection, can be a lymphoma again, can be a lymphoma both. So molecular was done and no monoclonality. You see, this is one finding that is helpful. So I then reported it is a granulomatous infiltrate, maybe a mycobacterial infection, maybe. Still I am not sure. And dermatologist started ATT and added clofazimine. I don't know why clofazimine was added, but he gave ATT plus clofazimine. And after 5 months of treatment, these nodules disappeared. Some only hyperpigmented area. After 8 months, almost disappeared. Probably we are in right track. Probably we are in right track. Case 9, almost at the end. This is 75 oral female. Some erythematous area I see here. I don't see actually, but dermatologists say there are some lesions. They have diagnosed as eczema and tinea. Eczema, 2 differential diagnoses. Okay, this is everything what I received. You see, very subtle findings. You see, epidermis, some lymphocyte here. That's all. That's all, nothing much. You see some lymphocytes here. Lymphocytes. Again, some lymphocytes. This pattern is not very pleasant for me. It is interstitial type of pattern. It is dissecting the collagen. I'm not happy. You see, it has gone to the subcutis also. Infiltrating pattern. That's that make me that some disease should be there. Huh? It's not a simple lymphocyte. Something you see some maybe atypical lymphocytes. I say atypical lymphocytes. PAST negative. So I told these clinical diagnoses are incorrect. Both are incorrect. I am not happy with this clinical diagnosis. And this picture I have taken from the Cerrone interstitial MF. And my picture very resembles with this one, my findings. So I have made a diagnosis of small round blue cell tumor, maybe interstitial MF, interstitial mycospongitis, or maybe something like SLL, CLL. Dr. Gujral probably can highlight this in better way. SLL, CLL type that has involved the skin, maybe, I am not sure. And maybe metastatic carcinoma. So I have reported this as a small round blue cell tumor and sent the paraffin block for T cell, B cell marker. CD3 looks negative. Looks negative. 20 also negative. Then I have requested to do a cytokeratin. Cytokeratin is epidermis beautifully positive, and all these small cells are cytokeratin positive. And patient had a history of infiltrating globular carcinoma 6 years back. This is metastatic globular carcinoma from the breast. So I am not going to on this. Last case, this is mimics lymphoma, but not a lymphoma, mimickers of lymphoma. You see, this is pea-sized nodule on the bridge of the nose, and later on it became larger. This you see how it some crossed erythematous nose. Same picture. So again, long list of differential diagnosis. Skin. This is everything I received. This is everything I punch biopsy. Okay, some artifacts. Again, dermis is very busy, infiltrated by all blue cells, lymphoid cells. You see, very busy dermis, all lymphoid cells. You see, some look like a epithelioid cell, some again lymphohistiocytic, I mean. Some look like a granuloma, some look like a large lymphoid cells, again, some look like a granuloma. Some fungal spores in the stratum corneum. So I thought of to report this case in this way, but I have not done this. Dense dermal lymphohistiocytic infiltrate with vague granuloma. And I have 3 differential diagnoses in my mind. I have not reported as this. One is leishmaniasis, another is marginal zone B-cell lymphoma cutaneous, primary cutaneous CD4 positive, small, medium-sized pleomorphic T-cell lymphoid, because this is solitary lesion, head and neck region. That's the, I have kept this one. Okay, I saw one micro, maybe leishmania. I saw some dot sort of things, small dots, you see. And I put, while I see some parasites, maybe Amasticus of leishmania, maybe. I did a pass session to rule out maybe histoplasm also. And with this, I made a diagnosis of cutaneous lymphoma. Patient got some amphotericin, and after 3 months of treatment, after 6 months of treatment. So I'm at the end. Some take-home messages, I'm ending it. Subtle clinical lesions shall not be ignored, like in this case. Okay? Roll-up ancillary technique is vital when microscopic features are subtle in this case. Cytokeratin became a very useful staining here. Correlation with clinical picture is must in cutaneous lymphoma, is must. Yes, similar morphology finding are seen in different diseases. In non-lymphoma also you see similar finding. You see, this is lymphomatous papulosis or mycospongitis, looks similar. But clinically they are different. You can easily make a difference on clinical ground. Few cases remain undiagnosed even after with ancillary technique. This case we could not make a diagnosis, but with clinical follow-up we could make a diagnosis. This is the picture, microscopic. And inflammatory and infectious processes in this case. This was treated ATT plus clofazimine, looked like a lymphoma clinically and histologically also. So, lymphoma and inflammatory process, they are similar clinically as well as histologically. Similar. You need ISC plus you need a monoclonality assessment. This is the picture you see, looks like a lymphoma. Rare disease do exist, but we have to think of it. If you don't think, we can't make a diagnosis. This is the example. Follicular mucinosis is a good clue for the follicular trophic EMF. Don't forget it. Because for me, it is synonymous, for me at least. B-cell cutaneous lymphoma is more common than T-cell cutaneous lymphoma in HIV positive. And this is the example. So at the end, I have some clinical clues for you. If you suspect lymphoma in microscopic slide, please see the clinical picture of the patients. If you see something like a patch in sun protected area, think of mycospongitis. If you see some papular small nodular lesions like this, think of lymphomatous papulosis. If you see solitary plaque lesion on the head and neck region, think of primary cutaneous CD4 positive small medium T-cell lymphoproliferative disorder. If you see alopecia, some loss of hair follicular based lesion, think of follicular based folliculotropic mycospongites. If rapid onset, fast progression of multiple necrotic plaque like this, then think of the primary cutaneous CD8 positive aggressive epidermoid cytotoxic T-cell lymphoma. Rapid onset and fast progression of tumors on leg, think of primary cutaneous diffuse large B-cell lymphoma, leg type. This is the only one DLBCL exists in the skin. Thank you very much. Huh? Hey, okay, thank you.
Thank you,
Shall
Dr.
I remove this one?
Thank you, Dr. Ramchandra. That was excellent. You just showed us that good morphology with some basic IHC, good observation, a clinical observation can still do wonders in a pathology lab. And to do that, you really don't need lots of molecular evidences. So I think, despite paucity of time, these are the three luminaries here, and they have probably provoked some questions in the mind of the audience. We will take a few questions. Yeah, please, go ahead.
So commendable presentation. I really liked it. I mean, especially when you said that we should not report on any suspicious lymphoma cases or inflammatory dermatosis which has got a lymphoma in the differential diagnosis without looking at the clinical picture. Kudos to you, Ramchandra. I really loved it. I liked it very much.
Can I ask some question to Dr. Gujral? If you have large cell morphology, diffuse proliferation of atypical lymphocytes, and in ISC all the CD10 is negative, BCL6 is negative, and even MUM1 is negative. So in those cases, what do you do further?
So you have done 20, is a B-cell lymphoma?
Yeah, 20 is positive, but all these CD10 is negative, MUM1 is negative, and BCL6 is negative.
Means if 20 is strongly positive and if it's a large cell lymphoma, I'll just call it, I'll surely do MIB1 to make sure it means, obviously your morphology says it's a large B-cell lymphoma, but sometimes I take help of MIB1 also. I like it to be more than 30-40% at least. I would leave it as a diffuse large B-cell lymphoma.
Is there an entity like triple negative diffuse large B-cell lymphoma?
No, WHO doesn't define that. There are some publications to that effect. We do not call it triple negative. As I said, cell of origin is not a mandatory criteria anymore. Now, if you can do it, BCL6, MUM1, if 10 is negative, your BCL6 is negative, MUM1 is also negative, you said. We have seen very few cases of that, maybe, but I do not know, means.
I had one case.
Yeah, means I also can think of one odd case.
KIV 67 was quite high.
Yeah, means 138 and other, MUM1 is negative, huh? And CD30 or something else, and other markers have done CD5, CD30.
CD30 negative, yeah.
Only
CD20
I don't have an answer for your question, but I think I would leave it as a diffuse large B-cell lymphoma.
Okay, thank you.
Because
so you're progressing along the Haynes equation. CD10 is negative. We do BCL6. BCL6 is negative.
MUM1 is also negative.
I think we can stop there itself and say that it is a non-JCB. Why shall we even go to do the MUM1? No, you do. That's all right. But the algorithm says you start with CD10. CD10 is negative. You do BCL6. BCL6 is positive or negative. Then you do MUM1. And if MUM1 is positive, that will trump BCL6 positivity. But if BCL6 is already negative, it's a non-JCB. I mean, that's the way I do it. I also do them together, but in my mind, I break them up into 3 steps.
But I in my reporting, I do not use GCB and ABC. I don't do it, actually. Myself, I don't do it. My clinicians do not ask for it also.
Maybe, if you are a MIC positive and if you have a GCB, you will probably insist on doing a double hit workup.
That's
if it
right.
is a non-GCB, you may probably avoid doing a double hit workup. So with that context in my mind, I generally do it.
I do it, but I don't report it. I do CD10. Sorry?
So,
ALK? No. ALK is not. Even CD30 doesn't come in my first panel. It doesn't come. Means if you are in a rich country, you could do all these markers first go, 30 and 5. They could be prognostic markers. But in our practice, I don't put these 30 and 5 in first go. Not even cyclin D1. There's a rare variant of pleomorphic mantle cell. We don't put cyclin D1 also.
So I generally, what was your question? You said L. So if because they are plasmacytoid and we do LCA and CD20, and these are discordant, you are not getting them, then amongst the list of the plasmacytoid, then I will include doing L. CD30 I do every case, because if salvage chemotherapy is required at some point of a time, then brentuximab vedotin can become a very useful drug. And I think the NCCN guidelines recommend that all cases of DLBCL should upfront be tested for CD30. And though it is not in the WHO classification, but I have seen many cases of CD30 positive de novo DLBCL. They are very anaplastic. They grow in the sinuses like anaplastic large cell lymphoma. And quite a lot of them are EVV positive. And those which are EVV positive have a terrible prognosis. So I think CD30, I will probably differ with great humility, with the great man here, that CD30 should be done in all cases of
It should be done. But CD30 is a marker which prognostic markers indicate. 5 also. CD5 and 30 are good markers to be done, but I don't do it in my first go. And I do not do in my DLBCLs. In my hospital, I totally agree with Dr. Anurag. He says, if you want to work up well, if you want to do a comprehensive panel, you should do 30, without a doubt. He works in Rajiv Gandhi, he can do it. But I myself do not do it, and I do not recommend to most of the hospitals, because I want at least 3 or 4 antibodies to be done. So if you want to do a complete panel, surely 30 should be done. And for your question, when you ask ALK positive, I do not know if you had in mind ALK positive DLBCL. ALK positive DLBCLs are generally 20 negative. So ALK I will not do for that matter.
So I just want to add, in my mind, I always know that I have to do CD5 upfront. I've seen cases of blastoid mantle cell, which, we just caught at the very fag end because we didn't do the CD5. So in my mind, I always think that CD5 should be done upfront. And one myeloid marker should also be done upfront, because sometime a myeloid sarcoma in a lymph node, you will keep groping for 1 week and then do an MPO and check it, and then say it's a myeloid sarcoma. But often I forgot, when I'm sitting and ordering the IHC, I often forget to get a CD5 and MPO done. But as a good practitioner of a pathologist, if you are seeing something which has a morphology of a large cell lymphoma, a myeloperoxidase and a CD5 shall be done.
But why should you do myeloperoxidase?
Because I've seen myeloid sarcoma, which I have diagnosed after 7 days of roaming around, trying
20
everything.
Positive?
No, they were not 20 positive, but still, I did for T cell, and then I came back and
so
found that they were myeloid sarcoma.
So Dr. Mehta, if I understood you correctly, you would recommend for all large cell lymphomas MPO up front?
At least in the back of your mind, you should know that you have to do this. As soon as the CD20 comes negative, you shall do it. CD79, I have seen aberrant positivity in many myeloid sarcoma.
Myeloid sarcomas in morphology also are not the closest differential of DLBL.
So they're very highly proliferative, they're large cell, they have a prominent nucleoli, and when you miss them, you miss them.
Sure.
I saw one case of Gujral sir, I saw one case of a paraspinal mass in a child. I think this was around 8-9 years back. So I think that it was child around 14 years, 12-14 years old. And it was a small round cell tumor, and I was about to order a battery of immunotests and probably deplete his financial condition also, when a peripheral blood film revealed all rods. Yeah. And it was easy. So I just wanted to share it.
I agree with
sometimes peripheral blood film can do wonders in cases where myeloid sarcoma is suspected.
Yes, I totally agree.
So if there are no more questions, we thank all the speakers and we thank the organizing team for inviting us. With the help of my co-chair, we would close this session and hand over the session to the organizers. Thank you.
Thank you, sir. Well, that was a very enthralling discussion, or say the very least, satisfying. Once again, thank you so much, esteemed speakers. Now, I would like to invite Dr. Sumit Kumar Gujral and Professor Dr. Anurag Mehta on stage to please lend a hand in showing love to our guest with a token of appreciation. Now, I'll also like to invite Dr. Sanjeev Kumar Gupta to hand over a token of appreciation to Dr. Gaurav Chatterjee. Similarly, please, Professor Dr. Mehta, could you give out token of appreciation to Professor Dr. Ramchandra Adhikari? Now, may I please invite on stage Professor Dr. Rajesh Pant to present our token of appreciations to our esteemed chairpersons, Dr. Sanjeev Kumar Gupta and Professor Dr. Anurag Mehta. I'm sure all of us are looking forward to more of the illuminating discussions and lectures we have lined up today. But before we dive headfirst into the rest of the session, I would like to invite everyone for lunch. We will reconvene at 2:15 p.m. to continue with the rest of the evening. We hope you enjoy the wonderful lunch. And before you leave, I'm pleased to inform you all you will be receiving gifts from Om Surgical, and please make sure that you collect a single gift from your seat. And similarly, Om Surgical has also arranged for a QR code scan in their stall with a very interesting surprise for any 2 lucky participants.
prognosis. Then Boekman said there's a type 2, which is a little different. It was mostly a serous or a clear cell in morphology. It was high grade. It arose in a background of atrophy. It was not estrogen dependent. It was seen in a different profile of women. These were a little thin and they were postmenopausal, and they were more aggressive. And during this time, they also noticed that there were certain genetic mutations which were typical of type 1, and certain genetic mutations were type 2. So idea about genetics was also coming in 1983. So let us now skip 30 years. There was the TCGA, the Cancer Genome Atlas study, which was published in Nature in 2013. And it gave us the molecular classification of endometrial carcinoma, where endometrial carcinomas were classified into 4 non-overlapping groups. Now, whatever the heterogeneity was there in type 1, type 2, it was a bit overlapping. It was heterogeneous. 30 years later, there was a clear-cut idea that endometrial carcinomas are 4 non-overlapping groups, and these were the groups. They were the Pol E ultra-mutated, which, as by the name as you can know, ultra-mutated, many, many mutations, more than 100, in a gene encoding the exonuclease domain of the DNA polymerase epsilon. Then there was this MMR deficient group, which was concerned with the MMR deficiency in tumors. These were also hypermutated. It had many mutations, but less than the Pol E. The third distinct group was the P53 mutated group, which had mutations in the gene oncogene TP53. And the last one is a diagnosis of exclusion. If it's not Pol E, it's not MMR, it's not P53, automatically it is no specific molecular profile. So 1983, heterogeneous confusion. 2013, 4 distinct molecular groups. Now, where are we today? Let's look at that. Then we found in this time between 2013 and now, 23, so 10 years now, where are we now? When more studies started being done, they found that this is how there is a relationship between the traditional histological classification and the molecular classification. Each traditional histological diagnosis is connected or represented to a molecular subgroup. If you see the thicker lines, they show a stronger association, and a thinner line shows a weaker association. From this table, you can see that the no specific molecular group, they are mostly the grade 1, grade 2 endometroid carcinomas. And the P53 group is mostly the serous carcinomas. Look at grade 3 endometroid right in the center, and look at clear cell over here. If you actually study them molecularly, they could be anything. An EEC grade 3 or endometroid grade 3 could be an MMRD, could be a POLI, could be NSMP, could be anything. So could be a clear cell. Okay? So the heterogeneity, what we see in morphology and even with immunohistochemistry, gets cleared up on molecular diagnosis. Right. So this is the 2014 classification, which is based on histology and IHC. This is what we report every day. You report it, I report it. Endometroid carcinoma, serous carcinoma, clear cell carcinoma, neuroendocrine tumors, mixed carcinoma, undiff, D-diff carcinomas. How is this diagnosis made? On morphology, most importantly. And we should never forget morphology. What's the second thing that we do to aid in this distinction between endometroid, serous, clear cell? We use IHC. And you all know which markers are available, and we'll discuss them shortly. Now, this problem of doing endometroid, serous, clear cell, and this distinction has a lot of subjectivity. There are problems. Now, when molecular comes in, it removes that subjectivity, makes it more accurate. You can prognosticate these tumors. You can have a personalized treatment for these tumors, and the patient has an overall survival. So what I mean to say is with the histological and IHC diagnosis, there can be errors. And those errors can be very dangerous because it can have serious clinical implications, which I'm going to discuss shortly. Now, WHO 2020, in all its wisdom, the book became, by the way, it's become a little more blue, it's become a little more thicker, And because it's incorporated a lot of moleculars, it recognized the molecular alterations in endometrial carcinoma. And that's the greatness of WHO 2020, and that's why I'm here today to discuss these points with you. But let's not forget, WHO has an international approach. I have my next colleague who will be speaking is from the WHO. WHO is an international approach. It still says if you want to classify endometrial carcinoma, the most important thing is, what's the most important thing in diagnosis? Morphology. Of course, aided by immunohistochemistry, which all of you now are aware of, because we cannot have molecular in every corner of the world. So the cornerstone is morphology aided by immunohistochemistry and desirable if you have molecular diagnosis, and when to apply them judiciously. Okay. Now, the 4 molecular subtypes of endometrial carcinoma, good news, they have surrogates of IHC. The good news is you want to diagnose P53 abnormal molecular endometrial carcinoma, it has an IHC, the P53 IHC. You want to diagnose the hypermutated MMRD, you have MMR IHC, MSH2, MSH6, PMS1, MLH2, you have the MMR IHC. But Pol E doesn't have the IHC. So let's make it simple. You want to diagnose molecular carcinoma in your laboratory, or you want to outsource it to a referral center, say in Nepal. Maybe one center can be doing the Pol E, you can do the IHC. So the molecular classification can be done by IHC, and in addition you require a Pol E mutation. So that makes things simple. But as I said, for Pol E, there is no IHC surrogate. All right. Now, you want to apply IHC. It has to be done with an algorithm, and I shall discuss it with you in a bit. Now, Pol E is ultra-mutated, many mutations. MMR is hyper-mutated, many mutations. You can have a P53 abnormality in a Pol E or in an MMRD as a part of a secondary mutation, as a passenger mutation. The main problem is Pol E, the main mutation is Pol E, but the subsequent mutation is maybe a P53. The main mutation could be in the MMRD, but the subsequent mutations could be in P53. So if you do, excuse me, sorry, yeah. If you do a Pol E first, you can pick up the Pol E initially. So if you do a Pol E first, this is your Pol E, do it first. You can pick up whether it's Pol E wild. If it's Pol E wild, then do the MMR. If it's MMR proficient, then do the P53. Now, if your Pol E is pathogenic, voila, it's a Pol E mutated endometrial carcinoma. If your MMR is defective, it's MMR deficient. If your P53 is abnormal after doing Pol E, after ruling out Pol E and MMR, it's a P53 mutated endometrial carcinoma. So there has to be a logic, there has to be a sequence of doing IHC and mutations. Now, why do you want to identify Pol E first? Why do you want to do Pol E first? You want to do Pol E first because of this. Pol E has the best prognosis. It's excellent prognosis. You want to know it's Pol E? Very good. I don't want to do anything further to a limit. Up to stage 2, if it's Pol E, fantastic. You don't need any treatment further. Then you want to pick up your MMRD because it's got an intermediate prognosis. Then, of course, you'll do your P53 and pick up your worst prognosis. And if it's nothing, you're left with no specific molecular profile, which is also got an intermediate prognosis. All right. So, 2 important prognostic factors in endometrial carcinoma. If you ask me right now, what are they? The surgeon. But this was for a surgical talk, so I put him first. But no, I'm here at a pathology talk. I want to switch it. It's the pathologist. If you want to do any good for a patient with endometrial carcinoma, you are important, and then I hope there are no surgeons here, then the surgeon's important, okay? So, but you are very important, and then I'll tell you why. In an endometrial biopsy, you make a diagnosis of histological type and tumor grade. Once this diagnosis of tumor type and tumor grade is done, the surgeon will decide the extent of surgery. If it is a low-grade endometrioid carcinoma, grade 1, grade 2, he may just do a TAH and a sentinel and leave it. Okay? If you call it serous, which is a high grade, he will take out the lymph nodes, do an omentectomy. So you decide which surgery the surgeon is going to do. In the resection specimen, you confirm the tumor type, tumor grade, and you stage the tumor. How do you stage the tumor? You tell them depth of myometrial invasion, cervical involvement, parametrial involvement, adnexal involvement, lymph node involvement. You give a stage. See how important you are. And if you have the IHCs, as I said, MMR and P53, and if you have Pol E, you give them that information, and with that information, provided everything only by the word P, the pathologist, then risk stratification is done. Then the clinicians will decide, this person is going to get radiation, this person is going to get chemo, this person is not going to get anything. But who made that call? You made that call. You decide for the patient. They just give the therapy. So please don't underestimate the powers that you have. When you speak, it's almost like God has spoken for the patient, okay? All right. These are the ESCO-ESTRO-ESCP guidelines for the management of patients with endometrial carcinoma. This is the staging. Stage 1A, tumor limited to the endometrium or less than half, 1B more than half. Stage 2, cervix, 3A, adnexa, 3B, vagina, 3C if it involves the lymph nodes, 4A if it involves the bowel and the bladder, and 4B when it's got metastasis, okay? Now look at the prognostic groups, low, intermediate, high. These are the prognostic groups based on what? The stage that you provide, LVSI that you say, the type of the cancer that you decide, and if you have molecular, the moleculars that you did. So that will decide the fate of the patient, low grade, intermediate grade, high intermediate, and high. And once the risk stratification is given, risk on one side, treatment on the other side. They will give the treatment. So everything rests on you. Now I'm quickly going to go through 6 long cases and 4 short cases. I may hurry, and that's only because I want to finish everything. And we will try to cover everything through cases. So first one, 55-year-old female postmenopausal bleeding, endometrial curettage. What you can see here is an increased gland to stromal ratio. The glands are more than the stroma. The glands are more than the stroma. And if you notice, there is uniform cytology. They're not very different. They're all oval and they are perpendicular to the base. So let's look at this. This could be a precursor lesion, right? This could be an endometrial hyperplasia without atypia. Let's look for some atypia for an endometrial atypical hyperplasia. You look closer, the glands are more tortuous, but look over here. They resemble the normal endometrium, correct? They are tortuous, cystically dilated, but look at the nucleus. They're not very atypical. They've not become rounded. They don't have prominent nucleoli. Again, compare it with the background endometrium. They look pretty normal. Again, over here, they look like the normal endometrium. Over here, the atypia is not marked. So this is endometrial hyperplasia without atypia, increased gland to stromal ratio, tubular branching, cystically dilated gland, and a uniform distribution of nuclear features. In other area of this biopsy, it's getting more compact. Okay, there is some architectural crowding. Now compare it with the background endometrium, there is atypia. So atypical hyperplasia is when there is a crowded gland architecture plus epithelial cytology is atypical. Now, case 1, I can now say there is a background of atypical hyperplasia. You all agree with me? Okay. Other areas of the biopsy gets more complicated. The glands become back to back. They are becoming tortuous. There is no stroma in between the glands. In one area, you can even see that there is some solid areas, there's some papillae, but still they are endometrioid. If you compare endometrioid, looking like normal endometrium, more or less, it's looking like that, so it is endometrioid. Look over here, again, they are oval glands. It's become complex, it's becoming solid, but they are retaining their endometrioid morphology. So this biopsy has areas of endometrioid carcinoma, which is a malignant epithelial neoplasm showing glandular papillary solid architecture, looking like endometrioid cells, looking like endometrioid. Therefore the name endometrioid carcinoma. Now, how will you distinguish endometrioid carcinoma from atypical hyperplasia? The presence of glandular crowding with endometrial stromal exclusion, no stroma, and significant cribriforming, confluent glandular, labyrinthine, papillary architecture distinguishes low-grade endometrioid carcinoma from atypical hyperplasia. So this is how it looks, back to back, no stroma in the middle, okay? Now, can you confidently say that this is now an endometrial carcinoma arising in a background of atypical hyperplasia? You can say that? Okay, great. Something missing. Grade. I didn't grade it. If you don't grade it, you can't prognosticate it. So grading. Endometrioid carcinoma is graded traditionally by the FIGO method, grade 1, grade 2, grade 3. They should exhibit, if it's grade 1, less than 5% solid growth. If it's the solid growth is 6 to 50%, glandular growth is 6 to 50, it is grade 2. And if there is more than 50% solid growth, it is grade 3. Now, what is this solid growth? It should be solid, non-glandular and non-squamous. You can't count squamous modules or squamous differentiation as a solid area. So this is a grade 1 endometrioid carcinoma, and you can see some squamous modules in the center. Remember, modular metaplasia should not be counted as a solid area. You can see the variety. Grade 1, a lot of glands. Grade 2, which has some solid areas. And grade 3, there are hardly any. Some lumen formation, it's mostly a solid endometrioid carcinoma. Now, ISGIP, that is the International Society of Gynecological Pathologists, says that microacinar growth is to be counted as grade 3. Okay? There's a slight variation. ISGIP says microacinar growth pattern is called solid growth despite the presence of small acinar spaces. Now, this confusion, suppose 6 to 50, it's a little difficult, yeah, 5 to 6%, suppose I say 5 and someone says 6% solid growth. Should we fight with each other? We shouldn't. Because grade 1, grade 2 are low grade and grade 3 is high grade. So when should you scratch your head? Between grade 1, grade 2 together, and grade 3 is separate. So grade 1, grade 2 are low grade, grade 3 is high grade. You should worry between grade 2 and grade 3 and not worry between grade 1 and grade 2, okay? So my case, which I was showing you, had 70% gland formation and 30% of the solid areas. So it is grade quickly. I'll overshoot my time otherwise. It's grade 2. So it was ER strong positive. It was P16 not block-like positive. I'll tell you about not being block-like. P53 was wild type. So this is a endometrioid carcinoma, FIGO grade 2, low grade in a background of atypical hyperplasia. Let's work it up further. Now the biopsy is reported. MRI was done to assess the depth. It was PT1A, means less than half of the myometrium. The patient, now low grade, less than half. The information given to the surgeon only did TH, BSO and sentinel lymph node biopsy. So you are determining the extent of surgery. Final histology was endometrioid carcinoma, FIGO grade 2, low grade. The P53 was not mutated. It was a wild type on the biopsy already done. The MMR was done on the resection specimen. It was proficient. It was not deficient. LVSI was not there. So it was staged as PT1A N0SN. Now, if you look at this table will keep coming after every case. If you look, I've put the tick on, this was a stage 1A low grade. There's no need to do a poly on this because anyways poly is also low grade, isn't it? We didn't want to waste money. We are all we have resource constraints, all of us. There's no need to do a poly in this. Anyway, it will be low grade even if the poly becomes mutated. So on the basis of this, it is a low grade and we didn't do a poly. It's a low risk. Now what's the information you give to the medical oncologist and the radiation oncologist? This information. No adjuvant treatment plan. Patient saved a lot of trouble because of all the trouble that you took. Okay? So, the low-grade endometrioid carcinomas include only two, endometrioid FIGO 1 and FIGO 2. All the rest, endometrioid FIGO 3, serous clear cell, etc. are high-grade and they are to be treated separately. We'll talk about them soon. All right. Which grade is this? Quickly. Grade 3, excellent. It's got only solid areas in this picture. So, key is, if you want to call it grade 3, it should look a little endometrioid at least. Oval or round cells lined by columnar or cuboidal cells, low-grade oval or round nuclei, pseudostratified, some squamous metaplasia. You should see some endometrial hyperplasia in the background. It is generally solid, but there should be some gland formation. If you see some squamoid metaplasia, great, you're kind of sure it's a grade 3 endometrioid. And the nuclei should not be terribly high grade, otherwise the differential will be a serous carcinoma. So this is a typical grade 3 endometrioid, where you can see here a grade gland formation, and these nuclei are somewhat similar to this. So this is a grade 3 endometrioid carcinoma, and it is endometrioid because the nucleus is similar to the normal background endometrium, though it's a little more atypical. So grade 3 endometrioid is not that simple. It's heterogeneous. If you subjected it to molecular testing, 40% are mismatch repair, 18% are P53 mutated, 12% are poly mutated, and 30% are no specific molecular. So it is a diverse group on morphology, but it is here a distinct group on molecular. Now again, as I said, grade 3 endometrioid should be subjected to further molecular testing because poly will have an excellent prognosis. MMRD and NSMP have intermediate prognosis, and P53 have the worst prognosis. All right, so high-grade endometrial carcinomas, what we just covered, was FIGO grade 3. Now I'm going to rush. Now, endometrioid carcinomas, the prognosis depends on the stage, the myometrial invasion, the endocervical stromal involvement, adnexal lymph node involvement, and also on the presence of LVSI. And sometimes in an endometrial carcinoma of the uterus, you can also get an endometrioid carcinoma in the ovary. Now, whether it is synchronous or it's a MET depends on certain histological features. They are considered synchronous if both the tumors are low grade, if the tumor in the endometrium has less than 50% invasion, if there is no involvement at any other site, and in the absence of extensive LVSI at any location. I'm going to rush to case 2 because I have many cases to cover. This was a 71-year-old with cervix biopsy. This is the cervix biopsy. Remember, it's from the cervix. So the important thing is to distinguish whether this is arising from the cervix or this is an endometrioid carcinoma. This looks pretty endometrioid on morphology. Looking like an endometrioid carcinoma, and indeed it is. It is positive for Paxate, Vimentin, ER, and PR, negative for P40 and P16. It lacks the block positivity. By lacking block positivity, we mean it's not uniformly positive. P16 is a surrogate for HPV. So endometrioid carcinomas do not show block positivity for P16, okay? And P53 was of the wild type. But the cervix biopsy was diagnosed as involved by endometrioid carcinoma, FIGO 1/2, it doesn't matter, both are low grade. If you can see over here, P16, not every cell is strong positive. It's not block-like. Some cells are positive. This is not a positive P16. This is actually a negative P16. ER is strong positive, PR is strong positive. Okay. This is another case of a cervical adenocarcinoma. This is not this case. I just kept it for reference. Look, this is looking like an endometrioid carcinoma. But this is the block-like P16 positivity. The HPV-ish was positive. They are ER and PR negative. So this can be, you need to distinguish endometrioid carcinoma from endocervical because its treatment is different, okay? And you can do it on the basis of IHC as we just discussed. Now, further workup. So, chalo, cervix involved by endometrioid carcinoma of the uterus. So, on MRI, the tumor was found in the fundus in the cervix. So, the stage is T2, okay? The patient underwent a different kind of surgery, a radical hysterectomy where the vaginal cuff was taken out by information given by you. You said that this is endometrioid carcinoma. The radiologist said that this is involving the cervix. So, the surgery changed. From a simple TAH, it became a radical hysterectomy with vaginal cuff. Pelvic lymph nodes came out, paraiotic came out, or mental biopsy was done. There was this peculiar kind of invasion I will show you, MELF type of invasion. There was extensive LVSI. The MMR was proficient. The P53 was wild. It was a PT2N2 MI. MI means micromets. And therefore, okay, these are the pictures where, look at the tumor over here. It's invading. It had a peculiar invasion pattern called the microcystic elongated fragmented pattern of myometrial invasion. And this is being studied, and there was a lot of conflicting data that this is prognostic, but the recent data has suggested that, and this was of course the cervix over here, which was involved by the tumor, and this tumor also had lymph node mets. So if I put this into a risk category now, it's a stage 3 because it's involving the lymph nodes. And of course, there is no need to do a pole E. I'll tell you why. Pole E up to stage 2 is low risk. Even if you do a pole E comes positive, this is anyways high stage. This will require adjuvant therapy. So again, we don't do things blindly. The minute we see that this is a high risk, stage 3, there's no need to do a pole E in this one. So this patient was high risk, and therefore pole E mutation analysis was not done, and the patient was given adjuvant chemotherapy and radiotherapy. Case 3, 65-year-old female endometrial aspiration biopsy. This is a polyp, and this part of the polyp looks very busy. This is the normal endometrial polyp, and there is a dirty carcinoma arising from the polyp. Very pleomorphic, not looking like endometrioid. It's got a lot of pleomorphism, prominent nucleoli. If you can see, very, very ugly tumor. Brisk mitosis, we can see it over here, some hobnailing. Does it look like the normal endometrioid tumor? It doesn't. P16 block positive. Is this from the cervix? By any chance, we just spoke about it? This is not from the cervix. I'll tell you why. P53 is of the mutated type. I'll show you how. Because it's showing null staining. There is no staining in the tumor, whereas there is staining in the background. This is a null pattern of P53 mutation. WT1 was negative, ER was positive. So this is an endometrial serous carcinoma where P16 is positive by the tumor suppressor pathway and not by the HPV pathway. Please remember, this is not an endocervical adenocarcinoma. It's a P53 mutated serous carcinoma. It's a very, very high-grade tumor. So the second important high-grade endometrial carcinoma is a serous carcinoma. They are associated with P53 mutations. They show a diffuse pattern of P16 like cervical, but that's not by the HPV pathway, it's by the tumor suppressor pathway. Interesting thing is that 1/3 of the cases, or 30%, show HER2 amplification, and therefore, just like the breast, you can give them trastuzumab in the recurrent and advanced stages. Now, all serous endometrial carcinomas are P53 abnormal or high copy number cases. Okay. So how do you interpret P53? This is an excellent paper which you may refer. P53 overexpression is by diffuse strong staining. Complete absence is also a mutated pattern where you see no staining in comparison to your background or your internal control. Sometimes you see a cytoplasmic staining, a diffuse cytoplasmic staining. This is also P53 mutated, and sometimes, very rare cases, the tumor is looking serous, but it's showing a wild pattern. That can happen in cases of truncated mutations. But the most common one will be a strong diffuse staining called the overexpression pattern. All right. So this is your wild pattern of P53 where some nuclei are stained, some are not stained. This is your overexpressed pattern where more than 75% of your nuclei are strongly stained. This is the null pattern which my case had where the tumor is negative but your internal control has worked, and this is the mutated cytoplasmic type. Please refer to the paper for further guidance. Now, endometrial serous carcinomas, they are very, very aggressive tumors. They're going to metastatize, so it's very important to correctly diagnose them, and we can do them even by morphology and aided by immunohistochemistry. All right. So further workup, on MRI, this was invading more than half. Because the surgeon knew this is serous on curating, he did a TH, BSO, pelvic, para-aortic omentectomy. P16 block positive, P53 mutated, MMR proficient, pole E wild. Why did I do a pole E here? I did a pole E here because pole E can sometimes harbor P53 as a second mutation. If it is PT1B pole E, it's got an excellent prognosis. Patient doesn't need further chemo. But this pole E was wild. HER2 was negative. The final diagnosis, endometrial serous carcinoma, P53 abnormal serous carcinoma, LVSI negative, stage 1B. It comes under high risk, and therefore the patient was given adjuvant therapy. Case 4, postmenopausal bleeding, endometrial curettage. Diagnosis, anybody? Clear cell carcinoma, very good. Look at the clear cells. They look ugly, but not as ugly as serous. uglier than endometrioid, less ugly than serous. They are pretty ugly, okay? So they are pretty but ugly. So they don't look endometrioid. They have this hobnails of this horse rider's shoes. They are hobnailing. The nuclei are projecting out. They have a lot of hyaline material in their papillae. And look at the clear cytoplasm and the hobnailing. If you look at the pleomorphism, there's moderate pleomorphism. There's no brisk mitosis. They look different from endometrioid, a little more uglier and a little more prettier than a serous carcinoma. They look pretty actually. They are napsin A positive, ERPR negative, P16 not block-like, P53 is wild. This is the third type of high-grade endometrioid carcinoma. Sometimes endometrioid can show a clear cell, but look at this. This is true clear cell. This is endometrioid with clear cell. IHC can help you. This is a serous which can show hobnailing, but this is a dirty serous. This is a pretty clear cell. Again, IHC can help you. These clear cells are HNF1 beta positive, napsin A positive, AMACA positive, P53 wild, P16 is not block-like, and ER is weak or negative, and PR is negative. So, if you wanted to diagnose your tumors on histology and IHC, this is your slide. FIGO 1 and 2 are ERPR positive. They lack strong diffuse positivity for P16. P53 is wild. FIGO grade 3 endometrioid are ERPR positive. They again lack P16 block positivity. P53 can be mutated in FIGO grade 3. Serous is ERPR positive negative. P16 strong block, not by the HPV pathway. And P53 always mutated, either the overexpression type or the null type or the cytoplasmic type. And clear cell is ERPR negative, lacks P16, P53 wild. And napsin, AMACA and HNF1 beta are strong positive. Now, clear cell, as I told you in the beginning, is heterogeneous. If you subjected it to molecular profiling, it could be any of these tumors. And how do you determine the prognosis? It depends on the molecular subtype. P53 abnormal has a worse prognosis. MMR and poly has a great prognosis. And most of these tumors are treated with adjuvant radiotherapy and chemotherapy. So our patient was T1B, P53 wild, MMR proficient, poly wild, clear cell carcinomas, PT1B, LVSI negative. Again, this comes under the high risk, and adjuvant therapy was planned. Case 5, 71-year-old female, postmenopausal bleeding. This one underwent TAH, pelvic lymph node dissection at an outside center, and came with that specimen to our hospital with a diagnosis of endometrioid grade 2. This was the tumor. Look at this. It's got these glands, tall pseudostratified cells. Again, gland formation and tall pseudostratified cells, little pinkish, lots of peritumoral, intratumoral lymphocytes. We did a PMS2 and an MLH1, it was lost. MSH2 and MSH6 was retained. ER was strong positive, P16 lack of block positivity, P53 was wild, poly was wild, MMR was deficient. Final diagnosis, MMR deficient endometrioid carcinoma, FIGO 2. It's actually an integrated diagnosis of molecular and morphology. LVSI negative, PT1B N0, stage 1B. Back to your table, it's got an intermediate risk stratification. Now, a pole E over here has an excellent, suppose I didn't do a pole E. Why did I do a pole E in this case? If a pole E came out, this is stage 1B, was positive, I would consider this to be a pole E mutated. And then this would become low risk and no treatment would have been given. Because a T1B is a low risk. That's why a pole E was also done. So it was an intermediate risk. Now for intermediate risk, you don't give chemo. Only a vaginal vault brachytherapy was given. So your treatment guides, your diagnosis guides treatment. So should we do MMR on all cases? Yes, because it's got a diagnostic role. Pre-screening to identify patients for having Lynch syndrome. Prognostic information because it's got an intermediate prognosis, and it's a predictive for potential utility of immunocheckpoint inhibitor therapy if the patient is in the advanced or in the recurrent stage. Should you use all 4 IHCs or 2 IHCs in a resource constraint? You can do 2 IHCs, PMS2 and MSH6, but you will have to go back and do an MLH1 and a PMS2 and an MSH6 if any of them come out abnormal. And does loss of MMR-IHC allow direct identification of patients with Lynch syndrome? Unfortunately not, because it tells you that there is MMR deficiency, but this could also be a somatic mutation or because of a hypermethylation. If you want to confirm Lynch, you'll have to do germline mutations. Now, should you do a MSI test instead of MMR? MSI test is laborious, requires non-neoplastic tissue, more expensive, and does not provide information of the gene affected. So I think an MMR test is better, okay? Now case 6 is a 61-year-old who underwent a THBSO, bilateral pelvic para-aortic, in February 22 at an outside center. Endometrioid grade 2, slides and blocks were given for review. And if you can see, it's looking endometrioid from all the pictures that I showed you. But some areas were solid, some areas started looking bizarre, some more bizarre cells, neutrophils within, tumor giant cells, you know. Feb 22, okay, looking quite bizarre, mitosis everywhere, but it had a background of endometrioid, all right? Look at this, lots of peritumoral lymphocytes, some solid areas, ER positive, P53 wild, P16 lacking block positivity, MMR all retained. So it had prominent tumor-infiltrating lymphocytes. It was looking different in every slide, intratumoral heterogeneity, a mixed type of morphology, ambiguous morphology, patchy bizarre cells, tumor giant cells. So we called it FIGO3 in Feb 22, and I'll tell you why. Tumor invades more than half of the myometrial thickness, cervical stroma was involved, no LVSI, the nodes were all negative. It was a P22N0 tumor. Now it comes under the high intermediate risk, and this was called at that time in Feb 22, high intermediate risk, MMR protein proficient, P53 wild. You're going to ask me any question here? Any question? Something not done? And POLE, yeah, where's POLE? This is Feb 22, we didn't have POLE. The rest of the tests, all I'm showing you recent cases. So at this stage, I was validating POLE, okay? So when this case came, I discussed it in the MDT and I said, you know, we don't have POLE, we are validating it. But then they said, no, on morphology, this is, on histomorphology, this is high intermediate risk. So the chemotherapy was planned. And look at the dates, March, April, May, got 3 cycles. And 31st of May, my validation was complete. And I had run this case also. This case, and I was really suspecting POLE, but you don't have POLE. Nobody in India was doing it. This was a POLE mutation positive, exon 9 to 14 by Sanger sequencing. So this showed the positive for heterozygous missense variant at exon 9, and I don't do molecular pathology, so credit to my molecular pathology colleagues, Dr. Sushant, Dr. Deepak Mishra, and team who did it in the hospital. Now look at it. From being a high intermediate risk, it's gone to a low risk. So what did after this information, the patient was happy, the clinicians were happy. It was finally called POLE ultra-mutated endometrial carcinoma. It's not a serous carcinoma. It's not a grade 3 endometrioid carcinoma. It's got a very, very favorable outcome. They stopped the 4th cycle. They didn't give it radiotherapy. So this is the importance of molecular pathology. Now, this POLE mutation should be pathogenic. It should involve the exonucleus domain, and it correlates with an ultra-mutated phenotype. So if you want to know how to interpret POLE, this is a great paper. The mutations should be in these exons, 9, 11, 13, 14. They should be functional. Sometimes you see mutations outside the exonucleus domain. They are non-functional, and they are not considered as POLE. Our case was this particular one. What are the molecular diagnostic tests available for POLE? NGS, Sanger, hotspot, nucleotide snapshot, droplet, etc. We do the hotspot Sanger sequencing, and there is no IHC surrogate for POLE. Why does POLE have a good prognosis? Because it's got a very ultra-mutational state, high tumor mutational burden, it's very immunogenic, attracts a lot of PD-L1 lymphocytes, enhanced T-cell response, and therefore an excellent prognosis. Now, I just want to tell you this important thing. As I said, 3 to 5% of endometrial carcinomas harbor more than one molecular classifying alteration. So, if you have P53 in the presence of POLE or MMR, that P53 is a second, it's a mutation. Can I take 5-7 more minutes? Okay. So it is not an important, it's not an important mutation then. The important mutation is POLE. Okay? So if you have a pole E and you have a P53, you're supposed to think of it as a pole E tumor. If you have an MMRD and you have a P53, you will classify it as an MMRD tumor, not as a P53, okay? If you have a non-pathogenic pole E and an MMR, what are you going to call it? MMR, because it's non-pathogenic, okay? So the British Association of Gynecological Pathologists, we met up at a gynae conference in February this year, which Kirishma attended, and they've given an algorithm which is freely available, and they say on biopsy, on all cases, do MMR, P53 and ER. On your surgical staging, of course, you do your typing, grading and your LVSI. In group 1, if your MMR is abnormal or your P53 is abnormal, note it. Group 2 is got low grade endometrioid 1A, no LVSI, ER positive. Group 3 is your stage 1 to non-endometrioid, grade 3 endometrioid, and endometrioid with any of the following. And group 4 is your advanced. You do poly for group 1, you do poly for group 3. Group 2 anyway is a grade tumor, they won't require therapy, poly not recommended. Group 4 is anyways advanced, don't do poly. Don't worry, you can refer to it and read it properly. I'll share my slides with you. Don't take pictures, you can do it later. So this is our pole E in our institute, and we've done more than 50 cases now. Now, quick short cases if time permits, or I can end now. Should I? Okay. You want 4 short cases?
Yeah, go ahead, please.
Okay. So, 57-year-old THBSO done at an outside center, sections from the endomyometrium. You can see a solid tumor over here, and you can see some glands over here. Solid areas, no gland formation, not looking endometrioid like my picture. This solid area is Pax8 negative, ER negative, CK dot-like. E cadherin is lost. MLH1, PMS2 is lost, MSH2, MSH6 is retained, so it's MMR deficient. So it's a dedifferentiated endometrial carcinoma. This is another variant of a high-grade endometrial carcinoma. Undifferentiated is only solid, lacking any epithelial differentiation. Dedifferentiated is an undifferentiated along with a low grade. It's a high-grade carcinoma and aggressive. So this is a monomorphic neoplasm. It's got a discohesive pattern, so you have to distinguish it from lymphoma, plasmacytoma, small cell carcinoma, or an ESS. And I will skip all this. They have mutations in the SW1, and they show loss of BRG1 and INI1. Most important thing, don't call this a grade 3 endometrioid. I showed you solid is grade 3 endometrioid. That retains CK, that retains Pax8, that retains ER. This loses all that. It's become dedifferentiated. So don't call it a grade 3 endometrioid. Don't call it a serous with solid architecture. Of course, don't call it a lymphoma. And other things are rarer. So important thing would be to differentiate it from an endometrioid carcinoma. Short case 2, THBSO, section from the endomyometrium in a 65-year-old. You can see a biphasic tumor, an epithelial tumor here, and something more rhabdoid over here, bone formation. This is looking like a serous carcinoma. This is looking like a rhabdomyosarcoma. So what happens when you get a carcinoma and a sarcoma? It's equal to a the sarcoma was desmin and myogenin positive. This is a carcinosarcoma with rhabdomyosarcoma component. This is also a high-grade endometrioid carcinoma, endometrial carcinoma. So it's a biphasic tumor. You all know about that. I will just show you this. How much sarcoma you need to call it carcinosarcoma. Even 1 millimeter is enough, okay, to call it a carcinosarcoma. It's an arbitrary figure, all right. Now, lastly, mixed endometrial carcinoma. With two distinct, this has got 2 types, either endometrioid with a serous or endometrioid with a clear cell, but you should be able to identify them clearly on morphology and on IHC. And overall, it will be a grade 3, irrespective of the percentage of serous or clear cell. So this is an endometrioid along with a high-grade serous, and you should be able to distinguish these areas on IHC. All right, short case C. 60-year-old endometrial biopsy at another hospital. Look at this gland-forming tumor, Garland necrosis, goblet cells, and the cervix was normal. PR negative, P16 negative, Vimentin negative, Napsin negative, then CK7 positive, CDX2 positive, CK20 positive. Is it a GI cancer coming to the endometrium? Could it be that? Could be, right? Okay. PAX8 was slightly there, not strongly there. This is your immuno. 7 positive, CDX2 positive, PAX8 focal. All these markers are negative. In view of the unusual morphology, please rule out GI, is what we said. Endoscopy, colonoscopy was normal. So what is it? Any idea? So anyway, we told them this is what it is. They did a full surgery. Okay? Looks exactly the same on resection. Looks like a colon cancer. Come to the endometrium. Look at this, the Garland necrosis. You look at the WHO fifth, there's something called other endometrial carcinomas. This is a gastric or a gastrointestinal type of endometrial carcinoma, which is the recent addition. It's the recent new kid on the block in WHO 2020. That's why I wanted to show you this. Endometrial gastric type adenocarcinoma. This was PT1A N0, no LVSI. You should see a gastric type morphology. No endometrioid component should be there, otherwise it becomes endometrioid with mucinous. You should not have any cervix involvement. It should have one of these markers, focal, MUC6, CK20 or CDX2, at least one. We had a CDX2 and a CK20. There should be no ER-PR. This was negative for ER. And this is the paper, please read it. And why it is important? Because you have to distinguish it from GI. You have to distinguish it from endometrioid. These are aggressive tumors, okay? Last case. This was a complicated case, a case of carcinoma endometrium. Now, I don't know which type because it was done outside. Carcinoma endometrium, I don't know it's endometrioid or it's serous. Post-EHBSO in 2017, received radiotherapy. Must have thought of it to be some low grade. That's why it received only radiotherapy. Then the patient unfortunately developed lung mets, so it wasn't so good. Then the patient received adjuvant chemotherapy. Then in 2022 comes with an anterior abdominal wall mass, okay? It's a solid cystic mass, very blue tumor, gland forming. Look at the fluid over here. Solid areas, slit-like, rete testis-like areas. Some fluid over there. Any idea what this is? Any idea? Postgraduates? Okay. Some solid areas. PAX8 was positive, so it's from the gynecological tract. ER-PR is negative. It's not endometrioid. What is it? Any marker you want to do next? Next panel? Okay. GATA3 was positive, TTF1 was positive. What is it? This is a new kid on the block. That's why I brought it up. It's mesonephric-like carcinoma of the female genital tract origin. Please read this up. So what's new in endometrial tumor pathology? Paul E, MMR, P53, NSMP. This molecular classification is new. I discussed all this with you. HER2 should be tested in serous carcinoma, and that's a new concept because you can give them trastuzumab. There are new tumors, that is the gastrointestinal type and the mesonephric. Carcinosarcoma, don't scratch your head, which sarcoma is in it, how. Just call it carcinosarcoma without doing too many markers. It can be done on morphology because they will be treated like a carcinoma and not like a sarcoma. No one's going to give it the sarcoma protocol. Don't scratch your head and say, what is the endoepithelial component? What is the sarcoma component? Just call it carcinosarcoma. And clinically, it's important, as I showed you, whatever diagnosis you made, the patient is managed as what you say. So clinically, you are very important. Tell your clinicians you're the most important person in an MDT. With that, I would like to thank you and sorry for taking extra time.
Thank you, Dr. Dipa, for excellent presentations. I would like to request the floor if you have any questions to Dr. Dipa.
Dr. Divya, I want to ask one question.
Yes, sure.
Yeah, you have mentioned about somatic MMRD deficiency.
Yes.
Yeah. But if there is a genetic component, do we do screening on the siblings or the relative?
Yes, it's a very good question. Thank you. Can I just, I didn't see your hand. Oh, it's you. Oh, so sorry. It's the chairperson asking me. So, in case of MLH1 and PMS2, if you get a loss, your first step would be, which I didn't cover because of shortage of time, there's so much to cover. You will have to do an MLH1 hypermethylation studies, which is done. It's not done in my lab, but we send it. This is one test which we don't do in our lab because it's not cost effective. Again, so you should send it to a center which does it. They do it for us. If it comes methylation positive, you stop. It's a somatic change. You don't do anything. You don't subject that patient to genetic testing. But in case it comes out non-hypermethylated, that's when you subject the patient to genetic testing. And there are guidelines for MMR interpretation in the CAP protocol. Each time you get an abnormal report, You open those guidelines on the CAP protocol, freely available on the internet. You read up the interpretation and you guide your clinicians what to do next. Okay?
Thank you.
Thank you. Any other questions?
Now I'd like to invite Dr. Lonin Prasad Disit. She is a passionate public health professional with a public health degree from King's College, London. She is National Professional Officer for Non-Communicable Disease in WHO Nepal since last 9 years.
Namaste, a very good afternoon. Thank you so much for inviting me, Dr. Runa and the organizers. It's a pleasure to be here speaking at the 10th National Conference of the Association of Clinical Pathologists of Nepal. As with my background, my presentation is going to be a bit different from what you've been hearing all these whiles, and I'm going to make it very brief as well in view of time. So with this slide, I'm showing you the burden of cancer, the incidence of cancer, and also the deaths of cancer in 2022. So this is a global picture that you can see the incidence and the deaths of cancer. You know, the deaths of cancer, around 70% of the deaths occur in LMICs, and then one of the most major risk factors for cancer is tobacco, which causes about 22% of all cancer deaths. I say this because if you look at this picture of Nepal, you will see that the leading cause of cancer in Nepal is lung, followed by cervical and breast cancer. And of course, in women, it's cervical, breast cancer is the leading cancer. And if you talk about tobacco, because as I say, I'm the technical professional officer for non-communicable disease. Tobacco, the prevalence of tobacco use in Nepal is very high. Like the recent 2019 STEP survey reported that almost 28% of the Nepalese population, which is almost 1/3, use tobacco. Smoking is highly prevalent, and the use of smokeless tobacco, both in India and in Nepal, is very, very high. So this is what I just said, and I'm going to skip this slide. And now it's like 2023, so we are in the almost half of the era of Sustainable Development Goals. We have the MDGs, which is an unfinished agenda, and then we are halfway in the SDGs, and we are still talking about, controlling, a lot of the MDG agenda. So cancer within the SDGs is very well framed under the Sustainable Development Goals under the health and well-being. So the cervical cancer burden in the Southeast Asia region, you can see it's very high, and then it's almost about 32% of the, if you see the piece of the pie, 32% of the share of the global cancer, incidence, cervical cancer incidence happens in the region, and similarly, the share of the global cancer cervix mortality, if you can see, is high. Coming to what kind of response, a public health response WHO does is, I would like to mention on this global strategy for elimination of cervical cancer as a public health problem 2020, where the vision is to have a world without cervical cancer. And there are 3 strategic pillars, much of which focuses on public health measures such as vaccination. It focuses on, screening, and then it also focuses on the later part where it's all about identification and then treatment. So going back to the SDGs, and this, if you implement this strategy and then you implement the 90-70-90 approach, then it will contribute to a 30% reduction in cervical cancer-related deaths by 2030, and therefore contributing to the SDG 3.4 goal. Now let us look at what is the cervical cancer incidence and mortality in terms of the countries in the Southeast Asia region. So if you see Nepal, if you look at the a standardized incidence rate and then also the mortality rate, you will see where Nepal is at. And I'm not using a pointer right now, but it's very clear. So we all know that cancer does require a life course approach, and then we're talking about primary prevention, secondary prevention, and tertiary prevention, as also I explained in the other slides about the 90, 70, and 90 approach. So starting from 50 years, you can start with the primary prevention and then go up to screening and then also to treatments, and you know it better. Then just recently, 2 years back, the WHO came up with another framework, which is the CR implementation framework for elimination of cervical cancer as a public health problem. And this is from 2021 to 2030. Again, the goal is to accelerate progress towards the elimination of cervical cancer as a public health problem. And it says WHO member states, which Nepal is also one of the member states, again by 2030. And the goal is well aligned with the SDG targets 3.4. Under this framework are 5 strategic actions, and let me just go very briefly through it. The strategic actions to strengthen primary prevention through HPV vaccination, screening and pre-cancer treatment, early diagnosis and treatment of invasive cancer, improved health system support for elimination of cervical cancer, and also strengthen the information systems, education, advocacy, and social mobilization to eliminate cervical cancer. Don't want to skip this. Now, if you look at this slide, what is the status of HPV vaccination in the Southeast Asia region? And we put like 11 countries in the region, and if you look at Nepal, which you must be very well aware of, that we do not have any kind of a vaccination program in Nepal. And do you all know that there was a pilot HPV vaccination done in Nepal? Where about? How many districts? So there was, through Gavi, there was a pilot, but what the government is trying to do right now is actually to prioritize HPV vaccination, and we hope that it will, the country will soon have an HPV vaccination program. Then the status of cervical cancer screening, again in Nepal, you can look at the status. So there is an initiation of cervical cancer screening, but however, it's an opportunistic type of a program. It's not national-wide. And then the target group age for the screening, according to the guideline, is between 30 to 60 years. And the coverage, as you can see, is very, very low. Sorry. So, well, these are some of the recommendations for cervical cancer, and the HPV DNA detection, which the government is now trying to pilot and also trying to make it as a national program. Right now, at the primary healthcare centers and at the referral hospitals, there are some tests that is done, and this is what the government would like to roll out. I just mentioned briefly on mentioned about the cervical cancer, I'm going to talk briefly on the breast cancer initiative, the GBCI, the objectives and the pillars of the GBCI. The objective is to reduce global breast cancer mortality by 2.5% and thereby averting 2.5 million breast cancer deaths globally between, this is still up to 2040 past SDGs. And the pillar here also focuses on health promotion for early detection, focuses on timely diagnosis, which we all know the deaths are mainly because they come to the clinics very late, and also because of the facilities that are available in Nepal, limited facilities, and also comprehensive breast cancer management. Now, in Nepal, WHO has also recently started this childhood cancer initiative, and we know that even here, much attention has not been given to childhood cancer, but now the government is also planning to kind of take this forward. And I'm just trying to show you some inequities in childhood cancer through this slide, and you know this better, so I'm not going to go through it. So what are the goals, objectives of this action on childhood cancer is, again, by 2030, achieve at least 60% global survival rate for childhood cancer and reduce suffering for all, and it's to save 1 million additional lives. And then there are country-focused implementations and other best practices, in the objectives and the technical packages. Well, coming to the end of my slides, then we need to set priorities, as I said, because I come from a public health background. My presentation, as you can see, is focused more on public health approach. There are set priorities like, tobacco control, vaccination, screening for cervical cancer, focus on early diagnosis, scale up capacity, and also, not the least, and not to forget, palliative care. So these are the risk factors which differ from behavioral to, infections to environmental to additional factors such as hereditary. And we need policies, legislations, regulations, and taxations. So fiscal measures, legislative measures in order to control some of these risk factors. So let us all join together, pathologists, public health people, to join hands together, community to policy level, in order to, control cancer in the nation, in Nepal, in the region, and also globally. Thank you.
Thank you, Dr. Lonin, for an excellent presentation. I'll open the floor for any discussions or questions.
Looks like none, so thank you.
Thank you.
Once again, I would like to thank our speakers for the illuminating presentation. To express our gratitude, I would once again like to invite our chairs, Dr. Gopi Aryal and Dr. Seema Pradhan, on the stage to present a token of appreciation to our speakers. Dr. Divya Midha, can we please have you on the stage to receive the token of appreciation, please? Thank you, ma'am. Dr. Lomin Dixit, may we please have you on the stage to receive the token of appreciation? Now, I want to take a moment to acknowledge and thank our generous sponsors for making this conference possible. Their support have been invaluable. Let's welcome on stage Mr. Guru. Sorry. To honor our chairperson, I would like to call Professor Dr. Anurag Mehta on the stage, please. May we please have Dr. Renuja on the stage, please. Runaja, sorry, ma'am. Thank you. Thank you, everyone. Now, I want to take a moment to acknowledge and thank our generous sponsors for making this conference possible. Their support has been invaluable. Let's welcome Mr. Guru Prasad, VP and Global Director at Bosch, for sponsored session on Eyesight to All Sight, Digitalization of Health Care.
मेरो एउटा स्मल रिक्वेस्ट है त्यो पछाडी बोलेको एकदमै धेरै अगाडि आवाज आइरहेको छ आई रिक्वेस्ट यु अल प्लिज त्यहाँ एक एकजनाले थोरै थोरै बोल्दाखेरि पनि इट्स क्रिएटिङ अ लाउड नोइज हियर के है सो आई रिक्वेस्ट यु प्लिज अलिकति चाहिँ प्रोटोकल अलिकति फलो गरिदिनु है थ्याङ्क यू भेरी मच
Hello now. Good. Good afternoon. My name is Guru Prasad. Okay, it has come up. How many of you are actually from engineering background here? Not a single one, because when I was welcomed in the morning, by default, the lady wrote doctor and then asked my name. Then I said, sorry, it's Mr., it's not doctor. So I come from the global company Bosch. It's a German company. It's a multinational organization. I care for the healthcare vertical of this organization. And what I'm going to talk here will be completely different than what all I have sat and learned in the day. The sheer knowledge of the clinical science and the overwhelming nature of the knowledge which is going to come by. So the whole talk is titled, it's very generic. Please don't look at me as a sponsor. I regularly speak at international events. Look at me more like a technologist in the area of healthcare. And the topic which I have chosen is called eyesight to AI sight. AI sight is artificial intelligence sight. And then since morning you've been hearing about all the challenges where you need to look at something. And what you see depends on what knowledge you have, and there is no way you can catch up with the knowledge which is getting generated parallelly in the world. Just like all other gadgets which we have got used to, let's take the example of a mobile phone. Very soon the world of healthcare will also start having cutting-edge technologies which will play a profound role in making your life easier to the extent possible. So in this, I'll go forward. This is the global challenge of clinical diagnosis. There is an enormous resource constraint. Population is ever increasing. Milestones are only getting crossed. On the clinical side, the workforce will tend to be insufficient. There is no way anywhere in this world we'll be able to produce clinical doctors at the rate at which we are producing children. There is no way. Any clinical practitioner would have spent already 40 years or 45 years of their productive life just learning about it. Education and training lead times are enormous. Infrastructure, the world is not flat, it is complex. All these things lead to inconsistent quality. None of us want to have bad health care. It applies to all the patients who will get treated from you. They also expect the same quality. And finally, accessibility. Healthcare is all about accessibility because human being the most proficient or the proliferant organism lives in crazy places on this earth, and then it becomes difficult to provide care. The future drivers will be healthcare equity. There will be harmonization globally. Then the whole thing about transparency and data-driven decision making. If it becomes overwhelming, stop me. You have the right to say, stop it. It's not just anymore acceptable to us. But I will give you an insight into the world which many of you youngsters will start looking at it more like a mobile phone in your prime productive career. Technology will play such a profound role in your professional careers, which possibly the earlier generation could not feel it, but it is now inevitably will feel it. Please see the dates. It's not even dates, it's centuries. Microscopy 1600. Photomicrograph 1900, 1980 telepathology, 2000 digital pathology, 2 centuries milestone got collapsed in 20 years in the second 2 milestones. There's an important thing I say, in the next 10 years, we will have cumulative progress, what we have not seen in the last 100 years of humankind. Not just in healthcare. Healthcare is always a laggard. Please be very clear about it. The other domains are progressing at that enormous rate. 70% of all the samples still are viewed by the human eye. That is the reason we start the story with eyesight. It's labor intensive, painful, tiring, can be subjective depending upon the knowledge level of the individual looking into that microscope, highly skill dependent, and depending upon private, professional, whatever events, there is a high error rate because we are inherently moody by nature and our decisions are always subjective depending upon what happened in the last few hours or few days. Please see on the right side, 1/3 of the diagnostic labs have no access to a trained pathologist. This is a worldwide metric, not just Nepal, please. 2/3 of the clinical diagnosis we discussed is through a microscope. No way MD experts can be produced at the rate at which the demand is coming. We discussed about it. And finally, we are very normal. We are, at least from this crowd here, we are used to giving a sample in the morning and getting a report by evening because we have the luxury, but very many of the people actually wait for weeks or even months to get their report. That's the reality of the world. Thanks to the God, whomever is the God we all believe in, we are not in that category, so we think that that is not the reality, but that's actually the reality in the world. Small insight into the clinical challenges of you. I just became the spokesperson. If it is wrong, you can always blame me. So, but I can see a lot of nods. It is true. I will now jump and wear the hat of an engineer. Computer vision. How many of you know what is computer vision? Computer vision is nothing but making computers see, analyze, act, and finally decide. We have accepted this technology in all other fields around, and healthcare is just about to be impacted. What you see on the right side are some images. What is so natural to us, you need to teach that machine to recognize it the right way. So we call this as computer vision technologies, where a very narrow portion of our cognitive ability is translated into a language which the machine can understand, and the machine after that will rarely make a mistake. It will do that job relentlessly, without sleep, without food, without getting tired. Story starts with an image data. There's some sort of pre-processing we do. Certain features are extracted, and then a particular classification is derived. It can start from recognizing our faces, to recognizing whether we are wearing masks, how many of the people here are wearing spectacles. Today there is technology available by which all these things are taken for granted in other industries. What is this AI? Artificial intelligence is making a non-humane or non-living item, which is a machine, learn to do certain things and mimic a human mind. Please note, our ability to teach somebody is dependent on what I think I know, and today we stop at the human being and say that we will only teach that element to that machine. You would have heard two normal words, machine learning and deep learning. How many of you have heard all these things? Difficult? In machine learning, which you see on this, I can't get it, it's somewhere in the middle one. What you do is, you go through the process which you go through and exactly break it down into smaller pieces and tell that machine to start identifying it. In machine learning, the teaching is sacrosanct. The machine in itself does not do anything other than what you taught it. In deep learning, you give a collective knowledge to that machine and say, you start interpreting more than what I taught you. So today in the world of healthcare, the intelligent machines stop at machine learning because we are still worried whether the other element of it learning by itself, the regulator still does not agree that can be allowed on a live human being. So in the world of machine learning, when it comes to artificial intelligence, healthcare stops at machine learning. Yeah? I'm just giving the very basic, please, because this is about 20-25 minutes, so you can see a lot of other videos from me, lot more details I get into, but because it's a large clinical fraternity, I keep it to the basic minimum. It is just a matter of fact that new things will emerge in the world, not by the earlier modes of invention. It is by two worlds coming together. The worlds which we are talking here is the world of clinical medicine and the world of an engineer, which is computational. And what does it do? It helps in bringing together this world and arriving at some outcomes which neither of their profession can do it by themselves. That is what we say technology enablement. And I don't know how many of you actually saw there are 2-3 devices from Bosch. It distinctly stands out from all others which are under display, because what we are seeing here is transgressing the boundary of physics, chemistry, and then going into computational science. So we are talking of not chemicals, we're talking of no reagents, we're talking of something beyond that, and that is the power of data and computation. Yeah? Actually, there are 3. One is hidden here, 2 live you can see there. Actually, I should be careful from Monday when I go back to Bosch. I should not start using your vocabulary, carcinoma and all of that, because the whole day I listen to it. In simplicity, this is all we are talking. On the left side is the traditional pathology. Sample is collected, sample is prepared, whatever. It is put under a microscope. Somebody looks at it, generates a report. The question is now coming, gentlemen, hello, please. I only get a very short time, please. The thing on the right side you see is where the technology layer is intervening. Where is the challenge on the left side? It is the human being. It is not the chemical, it is not the slide, it is not the microscope. It is the 2 eyes which are running short. So what we do is, we digitize the sample, get rid of the actual sample physically, and then put it through a cloud system, run it through a machine learning algorithm. It gives the result to what you want it or what you have told it to do, and the results are generated anywhere in the world. Please note that once you imagine this bad habit. Yeah, I'll tell you this bad habit. Today you go from lab to lab, hospital to hospital. I'll give you the luxury, you don't have to go anywhere. The samples will come to you in your home office. Which one would you prefer? You would prefer the home office. That is where technology inevitably to the new generation will become that much more appealing, because you did not go and travel, you saved 4 hours. Because you saved 4 hours, you can see 40 more slides, 40 more reports, that much more revenue, that much more patient outcomes. That's all is technology we are talking about. What does it lead to? Many a time there's a misunderstanding, is it a win-win or a lose-lose, or is it a win-lose? So we have divided the stakeholders who are typically part of the story. For pathologists, it's always selfish, human beings are selfish. For you, objective analysis, all the routine sample screening can be done by this machine. It is just like an app. The app will tell you a notification when it thinks that you need to know, rest it will do by itself. Reduced errors, you can sleep, the machine will run. It looks as if you work 24/7, you become big. The machine actually works behind the scenes. Better specimen views, because what tired human eyes can forget or fail to see, the machine will not fail to see. Diagnostic laboratories, there are providers here, increased throughput. Waiting for the human being, machine running it, and only few things going to the human being, increased throughput. Some of the topics we're talking is even color independent. How does it sound to you? For example, I was in Nepal for the last 48 hours. We were asked, what type of staining? We said stain agnostic. What? How can you have stain agnostic viewing? Because that guy who is looking into it has superior abilities where color is not the only distinction factor. He can do a lot more things which I and you cannot do, so I don't need the color at all. increase business outcomes. Naturally, they would want more and more patients to move around. Patients, accurate diagnosis, timely diagnosis, faster test results, and access to second opinion. Today, access to second opinion, you saw the lady who was speaking here before me. She said the patient came with the sample. The patient no longer need to come with the sample. The patient will come with a digital image of the sample wherever in the world. Yeah? Health system, population health management, standardization, affordable and accessible care. One of the device here, I think, is the most popular, cute little guy. I think half of you have got tested yourself, the hemoglobin monitor, which is not this topic. Just imagine. I sat down in 2 of your municipalities the last 2 days. We did camps. Throughput 50 patients per hour without needle, without alcohol swab, without syringes, without blood, without infection risk. What was planned for 1 day got completed in 1 hour. And actually they said, yes, we are done, wind up, move on. That is the power of technology in some of these topics. All the 50 patients, you don't have to follow up. You did not prick them at all. You did not prick them. So there is no risk even one patient will get an infection. So that is the world we are getting into. I'll pause here. I don't know whether I took more time. No, I think I'm on time. This is that revolutionary product which you have seen there. Even a lady can carry by hand. Designed, developed and manufactured in India for all our crazy requirements in the emerging market. Value engineered to such an extent that you can deliver the same test results at 1/10 the cost. It comes with its own battery pack. You don't need power supply on the field. It is completely automated. There is no person skill set involved. It is connected to the cloud when required. Data is transmitted into the cloud. It works in Nepal. I don't have to now tell you beyond that. If it can work in any one of these places, it can work anywhere. Yeah? Please note that we should all be proud because everybody, wherever I go, it's always a Western system which has been imported. Please note that this went on to win the CES Innovation Award in Las Vegas. That is the profoundness of the possibility. And we already had some people who visited and said, how can this work? But it works. And it is affordable. And we think that this is the future of healthcare. This is just the beginning. Many more things are going to come in the process. But I only have one request to all of you as clinicians. Start talking to engineers and other stream people. The world for you will be far more brighter. Yeah? And with this, I end my short presentation because I really wanted it short. A lot more information available. You have any questions, I can take it, please. And thanks to the organizers to have invited me. Yeah. Again, thanks to the organizing team. I was surprised that I got an invite to come all the way from India to talk here for 20 minutes, but I'm happy to do so. Yeah. But I want this to be remembered by you. This is the future of your world, and you will all profoundly benefit by adopting it, independent of whether it's a Bosch technology or some other technology, but technology will come into your world. Any questions? Yeah? Thank you very much. If you have no questions, you can always write to me. On the right side are my bearings. You can write to me. You can connect with me. Follow me. There are a lot of interesting things around the world I get access to. I'll post it. And I wish you all the very best in your endeavors. Thank you.
Thank you so much, sir, for sharing your remarkable expertise on this highlighting topic. Now, I would like to invite Dr. Rahul Katharia, Professor and Head of Department of Transfusion Medicine, currently working in Amrita Hospital, Faridabad, to speak on current trends in immunohematology and blood transfusion. Dr. Rahul, can we please have you on the stage?
Good evening, everybody. I should, before the earlier speaker said that he is the odd one out, but I should be saying that I am the odd one out here. In front of clinical pathologist, a transfusion medicine guy has been thrown to explain something which is not routinely practiced in your field. So I won't be taking much of your time because I think I'm not here to teach. I'll be very light. I'll just go back to the history where my existence came. In 1600, there was a gentleman who used to beat his wife. And what happened, the villagers thought he is very abusive, his nature is hot-headed, we need to change it. So what they did, they caught him and got cow's milk, as cow is very calm animal, and infused that milk to the gentleman. Somehow the gentleman survived, I don't know how. And from that day, the gentleman was calm. It was not because of the cow milk, but because of the near-death experience which the gentleman had. So it is the first incident which was called to be an unofficial transfusion-associated adverse event. After that, a pope died, 4 youngsters died, dog, blood given to a human, sheep to dog, multiple things happened. Just to avoid all those things, somebody thought, late Sir Karl Landsteiner in 1900 found those ABO antigens, and then we came into existence. So initially called to be as mad scientists, but gradually the field has grown. And just before I start, it's a small disclaimer. These slides are being begged, borrowed, and stolen. I acknowledge every source where I have taken it, and I don't endorse any of the images which I share over here. Thank you. So this is the field, how the field has grown. Right now we work on cellular therapy, we work on transplant technology, we work on clinical transplant practices. But one main thing which has really stuck for more than a century is the immunohematology. And just to apprise there, we talk about only A group, B, O, AB, but there are around 345 blood groups, 43 blood group systems, 40 unassigned antigens. There's lots of things going on here. And every day we find something new. So the talk is basically, when we find something new, where to put that box in the entire cabinet. So what about, I think everybody knows what genotype and a phenotype is. The basic purpose of showing this slide is that we help in paternity testing also. At times the father says the child is not mine because I am B and the baby is O, or the vice versa. So a genotype might be different. The phenotype is somewhat which is seen by the layman over here. So I told who we are and what we do. We are mad scientists and gradually moved for more of a clinical person. So it's a nerve center because when I was a resident, my professor used to do everything manually. Right now I have one AI hand which works everything for me, and I just put a signature and the report is ready. So from that point today, me as a professor, things have changed a lot in the past 20 odd years. This is a growth where we help in resolving ABO discrepancies to give everybody must have heard about Bombay phenotype blood groups. So this is one thing which we have been doing it, ABO discrepancies, RH characterizations, incompatible cross-match, DAT positive samples, you name anything, SDFNs, not only with red cell, but with platelets also. These are a few weapons which I have in my kitty where I use to decide and diagnose and give the best possible matched blood to the patients. My entire talk is just in one slide. This is the slide which should think, and the entire IH is based on this slide. We have moved from slides to tubes, to microplates, to column, to paper-based, to molecular. This is our journey from start and still on. Everything which has moved from slide to molecular is based on these 3 pillars. Detect an irregular blood group antibody, detect an antigen, and avoid allogenic blood antigen exposure. That's it. You remember this thing? I'll close with the same slide. in the presentation. Rest, everything is just brushing up so that I complete the 15-20 minutes short time of the presentation. These are the methods I've already talked about. I'll just touch upon each just to let you know why we have moved to a next technology. And when we talk about the sensitivity, the least sensitive, but still the gold standard, we still use it when we don't find anything compatible, is the conventional tube technique. It's a gold standard, godfather I would say. When we don't find, I go to a test tube and it will give me best possible, which can I give to the patient. Next is column agglutination, enzyme. And the most sensitive is flow cytometry, which we routinely don't practice. We just say it is something, but we routinely don't practice flow cytometry. Slide method, the only drawback which it had, it can only do ABO groupings, not more than that. And if the slide has dried out, it will give a false positive reaction. So what we did, we moved to a test tube. We added a media so that drying of blood doesn't happen. But the issue was, it was very subjective. I find it to be 2+, somebody says it is 3+. But with time, it will, the positive reaction may turn into a negative reaction. So what we did, we moved to a semi-automated system, got a microplate. Microplate is nothing, just a presentation of a test tube in a very small format. The same heme agglutination reaction, which is happening in a test tube, happened in a microplate. Fine. Then we thought it is not sufficient, it is not very sensitive. Again, we added something in it, that is solid phase red cell adherence technology. What we did, we coated the plates with the antibodies and then put the red cells. So it was more sensitive, more stable, and the only drawback which a microplate is that you require a system to read those microplates. If we do it by our human eyes, then it will be a subjective variation in the results. And another technology which came in is the magnetized RBC. Similar to microplates, the only benefit it has that it doesn't require centrifugation. The cells are attached with the paramagnetic compounds and we use a magnet to pull down the positive reactions. So it is how the microplate has happened. One thing which parallelly moved along with the microplates were the column agglutination technique, where we can use a gel or a glass bead to do a reaction. Here, if you see the columns have the AG or the required reagent already put inside, and we just need to put the red cells and the serum in the chamber, and there will be a reaction in it. Centrifugation is done. We have semi-automated systems, automated systems. The advantage what it gives is that suppose my automated system goes off, I can just see the card and read the reaction. The biggest advantage what a column gives over microplate or a test tube. Then again, why to sit ideal? We added molecular, though this is something which we routinely don't practice, but it has come handy when we are dealing with thalassemia, sickle cell disease patients, or patients who have multiple antibodies, or where we are not able to find a particular red cell unit for transfusion. In those cases, molecular blood grouping has become handy. We have multiple platforms. Right now, we have a high throughput microarrays where we use mini sequencing to find the blood groups. And I think you know better than me as clinical pathologist how a microarray works. So what's new? Right now, we are working, the field is working on soluble recombinant blood antigens, nanotechnology, precision matching. That precision matching is basically your molecular techniques, and use of database in predicting the blood group antigens. So just a brief about these 4 things in coming slides. This was a study which was published in Transfusion, where you can see a patient had 2 antibodies, KID-A and NOBS, and the columns were already containing the recombinant antigen, and when we were not able to differentiate between 2 antibodies, these soluble antigens helped us to differentiate between 2 antibodies. How these soluble antigens have been working. And the advantage what they give is, at times we label that patient has a high frequency antibody, has an antibody against a high frequency antigens, and they are labeled as like, but these soluble antigens help us in differentiating between those high frequency antibodies. Why I'm saying this? because these antibody against high frequency antigens are associated with clinical disorders. Take an example, a patient of chronic liver disease has an entity called high titer low avidity antibody, and these antibodies are particularly against Chido and Roser. So if you find a patient with liver disease has antibody which cannot be differentiated, the probability is that they might be having antibody against Chido and Roser. So how these soluble antigens and recombinant antigens help us in identifying those antibodies. Paper-based, this is the latest thing which we have been trying to implement at multiple hospitals. In our hospitals, it's just like a visiting card. You take the card, put the blood group at the patient bedside, and you get the group. You don't require anything. 3 drops of blood is required to get this paper-based blood grouping done. These are dye-assisted papers where antibodies and proteins are embedded on the paper. So I think microarray, everybody knows a single drop will give me 30 blood group antigens, or it can help me doing a TTI screening for a blood donor. I can have HIV, hepatitis B, C, syphilis, malaria in one single test. I don't have to do multiple tests, multiple reagents are not required. This is already in place in our blood bank. So this is again how it looks like. This is from Immucor. So what it does, it gave us a concept of molecular immunohematology, where a single drop will help us in deciding an RBC, HLA, and HPA antigen. And they did a testing in 28 RBC antigens, 10 HPA, and 6 HLA loci, and they found that 99.82% concurrence was there when they used this technique. And based on the results, we decided that this will help us in precision matching, that I don't need to do a cross match to give a compatible unit. I can predict which patients will be forming an antibody against anti-D, or what is the outcome of a patient in a when the patient is multiply transfused. So it will help us in accurately phenotyping RHD typing, which is more important in SDF in patients. We can extensively type our blood, means that I have all the details which are there on my shelf. I can find the compatible unit for my patients without even doing a cross match, and it reduces delay, because I'm not doing a cross match when I'm doing a molecular typing of the patient. So the same concept, what they did, they took this is published in 2016 in Blood Advances, where they did the genome of 28 antigens, and they extrapolated everything together with the ISBTI fact books, and they said that if I have the genome of all the antigens, I can predict which antigen will be from a different blood group. That is, I can predict a newer blood group which will be discovered in time. This is how they have used it's a far-fetched thought. It's just a study, we are not doing it, but it will help us because every day we are finding newer antigens. Maybe the increase in carcinomas, maybe the increase in detection capabilities, we are finding newer antigens, and we are not able to fit in this antigen which blood group system it will go. I told that 40 unassigned antigens. This will help us to define this particular antigen belongs to which category of blood groups based on the genes. Again, this is a proprietary from a firm which is being used in trauma patients, which is being used at bedside, where you require 3 drops of blood. I would say it's a modification of the 1900 slides where the TM had evolved. The reagents are embedded, you just put in the blood, seeps, gives a positive and negative reaction. So it is again going back what we started with, but in a much better reproducible way, because slides cannot be reproduced, but this can be kept in room temperature at 4 degrees Celsius for 7 days. So the results won't fade off. So one thing, because we come from our developing nations, India, Nepal, everything. Should I have molecular genetics replacing serology? No. Money is first, but second, EPO grouping takes 2 hours in molecular, and it takes 2 minutes in my serology. So when it comes to giving a blood to a patient, I still go back to serology. It's quick, easy, cheap, and accurate. So do you remember this heading I showed in the initial slides? The 3 pillars. The first pillar, the traditional methods, and newer what we are doing. What we are doing is we are culturing the cells. Suppose I have a XY antigen in me. I'm not able to find a red cell unit for transfusion. So what they'll do, they'll culture a red cell which will not have an XY. They'll culture it and give it to me for transfusion. Done. This is the newer target molecule where the field is working. Second is that we have recombinant soluble proteins which inhibits a particular antibody, that's CR1, CROMER1, which is being used for chronic liver diseases. Second is the antigen. I think everybody knows for prenatal testing, typing, RH profile access. This is the new thing which we are working on. Traditionally, we have those platforms for doing groupings and extended phenotypings. And third, which created a hue and cry, I think 6 months back, there was a news from UK where they said ki we have cultured the RBC and that RBC can be used for transfusion. Good, very good, wonderful. That is the RBC cultured in bioreactors. But can somebody tell me what is the cost of that blood? As an adult, I'll be requiring around 220 ml of blood. 5 ml will cost you 1,000 euros. So can you multiply it? So that is only it's something which is in pipeline, but to get a single unit, I think the money which I'll earn in my entire life, I'll give it in 1 unit. So it is just one thing which has been in development. And not only that, when I joined TM 20 years back, we were talking about eco RBCs and those pegylated hemoglobins and encapsulated HBs. Still there, nothing has happened. So this thing, I think third generation from me might be able to do it. I won't be alive to see if this happens or not. So conclusion, it's ever evolving. The focus is on to be precise and rapid results. Arranging a compatible transfusion is the utmost priority. Whatever we do, n number of things we do, the first thing is if I'm not able to give a transfusion to the patient, when required, everything fails. We identify, the newer techniques help us in identifying subgroups, complex antibodies. Molecular blood grouping will help us in predicting unknown blood group antigens which are already there but we are not able to see. And after all that, conventional tube technique is the gold standard. Thank you. I think I'll stick to the time. I hope no questions. Thank you.
Thank you, Dr. Rahul. Your session was full of knowledge and enthusiasm. To do an honor for granting a certificate of appreciation to 2 of our speakers, I would like to call upon Dr. Nirajan Mainali, a General Secretary of ACPN, on the stage, please. May I please call upon Guru Prasad sir to come on the stage to receive the certificate of appreciation, please. May I also call Dr. Rahul Kataria to come on stage, please? Thank you so much, sir. Now, to replenish our glucose we have lost for this whole day session, let us indulge ourselves for a refreshing tea break for about 10 minutes. It would be a great pleasure to have you back at around 4:30.
ranging from 2 to 3 liters per hour, which greatly minimize water usage. One Biosafe reagent kit includes 30 milliliters R1 and 10 milliliters R2. Smart Design reagent kit makes the benefits of loading R1 and R2 at one time. Each reagent kit has a unique barcode. Barcode recognition function is available for both sample and reagent. A simple and user-friendly software provides excellent user experience. STAT mode and automatic dilution function are supported. The needle and convection SNIPE, a leading company in chemiluminescence immunoassay field, has a full biochemistry product line as well. BioSays 240 Plus, the latest SNIPE biochemistry analyzer with compact design and high efficiency, is a reliable member worth choosing in clinical labs. BioSays 240 Plus is one of the fastest small-size analyzer with 240 tests per hour for biochemistry and 200 tests per hour for electrolyte testing. The sample and reagent area are combined in a single disc. It contains up to 90 sample and 90 reagent positions. Both polytype primary tubes and micro-container cups are compatible. The sample and reagent disc provides constant cooling at 2 to 10 degrees centigrade. Continuous loading function for sample and reagent is also available during measurement. The detachable design is convenient for sample and reagent storage. The sample and reagent needle coated with Teflon is washed automatically after each pipetting to avoid cross-contamination. Other functions, including liquid level detection, clot detection, and crush-proof are also available. 1,400 round per minute high-speed mixer coated with Teflon is used to fully mix sample and reagent and is washed with preheated water before and after mixing. Totally 80 reusable optical plastic reaction cuvettes are used for reaction and measurement. Minimum reaction volume can be lowered to 100 microliters, which is cost-effective for customers. BioSays 240 Plus adopts post-spectroscopic optical system and a long-life halogen lamp, which greatly improves the detection accuracy in reducing consumable cost. 16 wavelengths ranging from 340 nanometers to 800 nanometers meet the needs of different assay configurations. 80 reaction cuvettes can be automatically cleaned by a station with 4-step washing procedure. The maximum water consumption of BioSays 240 Plus is ranging from 2 to 3 liters per hour, which greatly minimizes water usage. One BioSays reagent kit includes 30 milliliters R1 and 10 milliliters R2. Smart Design reagent kit makes the benefits of loading R1 and R2 at one time. Each reagent kit has a unique barcode.
and past Vice President of ACPN to co-chair this session. Dr. Pradhan and Dr. Pant, the stage is yours. I would like you to be seated on the left.
So we are now heading to the last session for the day, the scientific session that is. So the next, I would like to call upon the next speaker. I will first introduce him. He is Dr. Abhimanyu Jha. He is the professor and head of Department of Pathology, Tribhuvan University, Maharajganj Medical Campus. He is the executive member of SACH, South Asian, and he is the assistant dean of IOM and the past general secretary of ACPN from 2008 to 2011. He has several publications in national as well as international journals, and his special interest is on bone and soft tissue pathology. I welcome you to the stage, Dr. Abhimanyu Jha.
Thank you, sir. So good evening. So just I was thinking, so all of us are human beings. There is no doubt. But all of us are different. We look different. We behave differently. And we are, of course, genetically different. That's why we look different. Even though some of us look similar, their behaviors are different. Same thing applies to tumors. So even though look similar, they may behave differently. They have same name, but every individual tumors are different, as we are. So with that, I will start. Change कसरी गर्ने हो? Okay. So it's many phases of osteosarcoma. So there are many phases of osteosarcoma. I cannot talk all the phases of osteosarcoma. I will be talking just some of the phases of osteosarcomas. So all of us know osteosarcoma. So I have just modified the definition a little bit. So if you see WHO definition, I am not satisfied with that definition, because WHO says it's a osteosarcoma intramedullary tumor, it's a high-grade tumor, but there are so many types of osteosarcoma. They have defined, WHO has defined different osteosarcoma differently. So it's a malignant bone tumor of variable grades. It's not always high grade. It may be low grade, it may be intermediate grade, or even high grade. That arises within medullary cavity or on the surface of the bone. That is for skeletal osteosarcoma. So they produce osteoid, predominantly affects children and adolescents. That is important. I will come to that. It arises from mesenchymal stem cells. So mesenchymal stem cell differentiates not only to bone, differentiates to bone, cartilage, muscle, fibrous tissue, fat. So morphologically and genetically, these tumors are different, as we are. So the types of mutation decides the morphology and behavior of the tumor. So none of the tumors are same. And even the same tumor, different area, they are different. So it's something like this. So it's just my imagination. So two balls, they are different. Within same ball, they are different colors. So it depends from where you have taken the sample, the morphology. So this is just to show the heterogeneity of osteosarcoma, morphological heterogeneity. They may be round cell, they may look myxoid without any osteoid, they may look typical osteoid, they may look epithelioid, they may produce lot of cartilage. So malignant cartilage doesn't always mean it's chondrosarcoma. Malignant cartilage does not always mean chondrosarcoma. I am emphasizing. And it may look quite benign. So this is just to show how mesenchymal stem cell differentiates normally to different cells. So how osteosarcoma occurs? This is just, I have copied, this is schematic. So the upper portion is the normal differentiation, how they differentiate to mature osteoblasts, osteocytes. So committed osteoprogenitor cells may have mutations. The most common mutation all of us know is RB and P53. And that produces precursors of osteosarcoma that differentiate, and they can differentiate in any line depending on the passenger mutations. So this is driver. So it's not only genetic, they are epigenetic also. Next. So this is just to show how mutation decides the microscopic morphology. So depending the types and number of mutation, the microscopically the tumor may look different. This is just, this is not all, just to show how many mutations the osteosarcoma harbors. So this is just some of the mutations. There are maybe many more. So there are several genetic and epigenetic alterations, as I told you. So the osteosarcomas are associated with various syndromes: retinoblastoma, Lee-Fermani syndrome, Rothman-Thompson syndrome, Bloom syndrome, Werner syndrome, and there are various associations with these entities. So this is the blue one is the WHO classification, the recent 2020. If I am correct, hope it has not come after that. So this is just the various microscopic variants of low grade and conventional. I just want to emphasize these difficult areas. And this the last one. So if you go to the previous edition, it is there in WHO classification as a variant of conventional. In 2020 edition, they have deleted, but that does not mean that it does not exist. So this is how we diagnose, we pathologists, we all of us know. So, so now since we are discussing osteosarcoma, you may think some type of osteosarcoma, that is obvious. But if it is not a class or a presentation of osteosarcoma, you may say just it's all benign looking, some cartilage, there is some bony trabecula, few fibrous tissue, that's all. So without any information about location, age, I don't know how many of you will be able to make the diagnosis, confident diagnosis of osteosarcoma for this. So how you make diagnosis? So microscopy. So we are not microscopists, we are pathologists, right? So I am emphasizing. So for the last few years, I am very fond of this word. So microscope just gives the image. So it is head of pathologist. So it comes to the head, the surgeons put something in the head, the radiology image puts in the head, then the pathologist thinks it is something like this. And the diagnosis is so easy, parosteal osteosarcoma. So coming to age, so all of you know, all of us know actually. So it's disease of young children and young adult. And most of the primary osteosarcoma occurs in children and young adolescent age. In world age group, it's mostly secondary osteosarcoma. Of course, it can occur, primary also can occur. So, look, osteosarcoma can occur anywhere in the body. So it's not property of bone, but most commonly it occurs in bone, of course. So 90% of them occur in metaphysis of appendicular skeleton. Then 9% occurs in diaphysis. So don't get carried away that if it is in diaphysis, it's not osteosarcoma. So don't know the case which we are dealing is under 90% or 9% or 1%. 1% even can occur epiphysis. But for secondary osteosarcoma, it depends on the disease, underlying disease where it is located. In some syndrome, it can occur multifocal, and in Werner syndrome, it can occur in unusual site, even in patella. So this is, all of us know osteoid. So we are very reluctant to diagnose osteosarcoma if there is no osteoid. So, but I told you, it is a heterogeneous tumor. So can osteoid be uniformly present in 5 centimeter tumor? So wherever you put needle, you think osteoid will be sampled? No. So while dealing with small biopsies, think of that. So in the sample, whether the needle was from the area where it was osteoid or not. So osteoid, if you see any definition in any book, it says it produces osteoid, fine. But it does not say osteoid has to be present microscopically. Osteoid is required, but it is not necessary, it has to be present microscopically. So grossly it may be present, radiologically it may be present. Okay? So may not be present uniformly, fine. May or may not be represented in a small diagnostic biopsy. There are other tumors which produce osteoid. And all of us know sometimes it's so difficult to find osteoid, what is. And osteoid may have variable appearance. Sometimes it looks like mature bony trabeculae. So we are very reluctant to say them osteoid. It looks so mature. Sometimes even you can see osteoblastic rimming. So we have concept that the neoplastic osteoid will not have osteoblastic rimming. No. Usually they don't have, but sometimes they can have. So if you read any book in parosteal osteosarcoma, you see that there may be some osteoblastic rimming. So in the telangiectatic and small cell osteosarcoma, osteoids are very less. And some tumor you will find only osteoid. Lots and lots of osteoid. I have seen people diagnosing osteoma in the small biopsies based on looking at only osteoid. So that if there is no cell in a small biopsy, that does not mean it is not osteosarcoma, it is osteoid osteoma. So you can always talk to the radiologist. How big is tumor? Where it has gone? It's outside bone. Sometimes tumor has gone metastasized and we give diagnosis of osteoid osteoma. Just because microscopically we see osteoid matrix only. So we are pathologists again, I am telling. So this is just various looks of osteoid matrix depending on the types. There may be typical, so many types of osteoid. Chondroid. So name is osteosarcoma. We all know osteosarcoma produces osteoids. So which osteosarcoma does not produce cartilage? Tell me. All osteosarcoma produce cartilage. Most osteosarcoma produce cartilage, either more or less. So for me, if I don't find osteoid, actually in a small biopsy, if age and site is compatible, I look for cartilage for the diagnosis of osteosarcoma rather than osteoid. That really helps me. So malignant cartilage in children, if in given clinical context, it's diagnostic of osteosarcoma. It's not chondrosarcoma in children if there is malignant cartilage. So amount may vary from minimal, focal to predominant. In some cases, cartilage production is dominant feature, like in periosteal osteosarcoma. It's cartilaginous tumor. Like predominant cartilage, you will see gnathic osteosarcoma of mandible and jaws, and periosteal osteosarcoma. Grades of cartilage, it may be intermediate or even high grade. So you see
In parosteal osteosarcoma, it looks like almost benign, only thing little more cellularity. So next to osteoid matrix, cartilage is most diagnostic in appropriate clinical context. So even you can see cartilage cap, as I showed you in the earlier slide. That can be seen in 25 to 30% of parosteal osteosarcoma. So a malignant cartilage in children and in jaws, most likely it is osteosarcoma, not chondrosarcoma. So again I repeat, malignant cartilage in children and in jaws, most likely it is osteosarcoma, not chondrosarcoma. So this message also goes to the radiologist who keeps on diagnosing chondrosarcoma in children. Of course, in old age, if there is osteosarcoma, there is problem. Whether it is chondrosarcoma producing cartilage or osteosarcoma producing cartilage, or it's chondrosarcoma de-differentiating to osteosarcoma in old age. Now coming to, this is various appearance of cartilage. This is all osteosarcoma, malignant cartilage. Fibrous tissue. So in addition to osteoid and cartilage, next matrix in osteosarcoma is fibrous tissue. Sometimes it will be quite sclerotic. So just seeing a sclerotic, benign fibrous loosening tissue in the small biopsy doesn't mean that this is not osteosarcoma. So fibrous tissue may strikingly dominate in some of the tumor, may sometimes resemble like desmoplastic fibroma, may look like fibrous dysplasia. So example, this is example. So this is bland looking fibrous tissue. So no atypia. So don't go to nuclear atypia. I never go to atypia because I read my Robbins very carefully. So Robbins, if you see the first chapter, first introduction of neoplasia, it says, next to metastasis, invasion is the most diagnostic of malignancies, not anaplasia. So invasion. So invasion need not be microscopic. It may be clinically invasive, may be radiologically invasive. So atypia is not diagnostic. It is invasion that is more diagnostic. So all looks benign, but all are osteosarcoma. So this is even myxoid. So now coming to cell. So there are so many types of cell in osteosarcoma. These cells can be present in same tumor, different type of cell, or different tumors can have different types of the cells. So same conventional osteosarcoma can have all types of the cell in a single tumor. So depending on from the sample from where one has taken, so this may be spindle, polyhedral, cartilaginous, osteoblastic, giant cell, clear cell, epithelioid, plasmacytoid, all sort of the cells. So lot of different cells based on the above findings, based on the matrix production, based on the type of the cells. So osteosarcoma can resemble microscopically to anything, even sometimes radiologically. So it can resemble cartilage producing lesion, fibrous lesion, giant cell lesion, small round cell tumor, metastatic tumor, myxoid tumor, synovial sarcoma. So that also produces bone. So tumor de-differentiating to osteosarcoma. There are many tumors which de-differentiate towards osteosarcoma, like carcinomas. Various sarcoma, like chondrosarcoma, can de-differentiate. MPNST can de-differentiate to osteosarcoma. So these are the list all of us know, which produces osteoids and comes probable differential diagnosis of osteosarcoma, and this is not theoretical. Practically, we face every day this problem. Every day we have to think all this when we get the case. Similarly, cartilage producing tumor, chondrosarcoma, fibrous dysplasia, chondromyxoid fibroma, osteochondroma, enchondroma, comes under the differential diagnosis of osteosarcoma. NORAs, listen, mesenchymal chondrosarcoma, a small cell tumors, clear cell chondrosarcoma, chondroblastomas, fracture callus. It is very dangerous. Fracture callus, most of the time it looks like osteosarcoma. Myositis ossificans, of course. So there are some benign mimickers. Fracture callus, periostitis, AVC, aneurysmal bone cysts, GCTs, fibrous dysplasia, non-ossifying fibroma, osteoblastoma, chondromas, chondromyxoid fibroma. Benign mimickers of osteosarcoma. So this all of us know the various giant cell containing lesion, that is differential diagnosis of osteosarcoma. So how usually we diagnose? Really we follow the protocol or we just override the protocol? First thing I would like to, like all in current situation in this world, all the cases should not be handled by everybody. So a surgeon oriented to bone tumor should handle the case. So it is difficult for the pathologist. If we try to entertain the general surgeon taking biopsy for a bone tumor, it's really very difficult. But if orthopedic surgeon oriented to orthopedic oncology, if you talk, they will tell you the diagnosis. You don't have to see the microscope. So it makes a lot of difference. So clinical finding, of course, so osteosarcoma most of the time does not present with fracture, except for telangiectatic. So LDH and LP, it's not diagnostic of osteosarcoma, but it really helps in the further assessment, post-therapy assessment. Okay, so conventional radiographs, very important. So it really gives a lot of information. So the various appearance, some of the appearance of, just sake of the completion, I have put this. So MRI is supposed to be gold standard for the diagnostic imaging of osteosarcoma. Pre-surgical assessment and response to chemotherapy. A CT scan, okay, for planning biopsies. So biopsy. So we often, as a pathologist, like surgeon blame us. They don't give diagnosis, they give this diagnosis, that diagnosis. So sitting in our room, we also blame the surgeons and radiology. They don't know how to take biopsies. Just one core of biopsies, this, that. What is there? You can put some more needle and take. But that is not the case. So they have also a lot of problems. So it's a planned way. So all of the radiologists cannot take biopsy. Even though they don't know the outcomes. So when surgeon oriented to orthopedic oncology surgery, so they plan the biopsy so that the biopsy tract can be excised in toto, because they don't want to miss the biopsy tract. So they have to plan very carefully from which side they have to take the biopsy. So ideally the surgeon which undertakes the final resection should be familiar with the path and extent of the biopsy. Should be performed in coordination with interventional radiologist and oriented in musculoskeletal oncology. This is important for the patients. Potential for limb salvage surgery. It is crucial to spare save as much local tissue as possible. So that really hampers limb salvage surgery. So core needle biopsy should traverse a single tissue plane. It's not that you put needle from anywhere. And of course, multiple cores from center, you will get necrotic tissue, periphery, reactive bone, like that. It is just an image of how they are approaching putting the needle to the ala of the sacrum. So none of the single diagnostic modality can be diagnostic in all the cases of osteosarcoma. So independent microscopic diagnosis can be hazardous. So diagnosis is a team approach. You have to use the head of radiologist, surgeon, and pathologists. Of course, if you use one head and if you use 3 brains, diagnostic yield will increase. So little bit about the therapy that is required for the pathologist. So therapy differs for different types of osteosarcoma. That is why they expect us for the typing. So if it is low-grade osteosarcoma, it's not chemotherapy, it's surgical resection. But after resection, we have to carefully examine the tissue. If we get high-grade area in low-grade tumor which has been given in the true-cut biopsy, they need chemotherapy. Intermediate grade, like periosteal osteosarcoma, chemotherapy followed by resection. This is for non-metastatic osteosarcoma. For high grade, it is chemotherapy followed by re-staging to see if the tumor is resectable. If resectable, our job as a pathologist is to evaluate the margins that decide the further treatment modality. So now some of the phases. This is low-grade osteosarcoma and variant. So you will not see any atypia, hardly find any mitosis, anaplasia. So it's a trabecular bone. You may get usual osteoid. It may look like fibrous dysplasia. If lot of osseous matrix, it may look like desmoplastic fibroma if less bone and more matrix. Less bone, more fibrous tissue. The typical of low-grade osteosarcoma and variants and parosteosarcoma, it is biologically different from other osteosarcoma. They are really, because they are named osteosarcoma, but it's different tumor. So they have typical MDM2 and CDK4 mutation. These are some of the images. So this is a 3-month-old child. Not 3 year, 3 month, small child. It's very difficult to think of osteosarcoma. So it was operated many times, osteomyelitis, this, that. But surgeon was even not thinking of osteosarcoma because of age. They are thinking maybe some fibrous dysplasia or something. They were not sure actually. So microscopic diagnosis was, so this is bland looking true-cut biopsy. This is just a bone, part of bone. So diagnosis can be osteofibrous dysplasia, and I looked into the literature. Okay, this is, can it be some epithelial cell hidden somewhere? Can we do cytokeratin to identify to whether it can be adamantinoma? But this is the MRI of the patient. So this was the true-cut biopsy. There's no atypia at all. So it was low-grade osteosarcoma in 3-month-old child. So parosteosarcoma, it's again low-grade tumor. It arises from outer periosteal surface, so it does not have periosteal reaction. So if it arises from inner periosteal surface, it will have periosteal reaction as periosteal osteosarcoma. So microscopically, there are bony trabecula well formed, and in between there is fibrous tissue, cartilage, differential fibrous dysplasia, low-grade osteosarcoma, sometimes NORA. So even imaging-wise, this is very clear. Okay, this is osteochondroma, this is parosteal osteosarcoma. It looks like just a stock-on. This is continuous with the medullary cavity. But sometimes sessile osteochondroma and NORAs can look like parosteal osteosarcoma, and surgeons are very confident, okay, this is parosteal osteosarcoma. But this is cartilage cap, same image. This is parosteal osteosarcoma. It's low-grade fibrous tissue. So microscopically, this is osteochondroma. So here you see just fat. So you have to be very careful. So this cartilage, this is part of just enchondral ossification. This remains of residual cartilage. This may, you may think of, can it be chondroblastic difference osteosarcoma? But here you see a fibrous tissue, not fat. This looks like, this is small bone, the Nora. So this, if you get a small biopsy, if it is young patient, I may think of osteosarcoma because of atypical cartilage. But it's not osteosarcoma. So periosteal osteosarcoma produces a lot of cartilage. It's intermediate grade tumor. So high grade surface osteosarcoma versus dedifferentiated parosteal osteosarcoma. How to differentiate? So surface osteosarcoma high grade is almost microscopically similar to conventional osteosarcoma. So entirely the tumor is conventional osteosarcoma, only thing is it is in the surface. But if high grade transformation occurs in parosteal osteosarcoma, if tumor is entirely high grade, how do you know? So if there is previous diagnosed parosteal osteosarcoma, then we can say it is not high grade surface osteosarcoma, it is dedifferentiated parosteal osteosarcoma. Or microscopically you can demonstrate the low grade area and high grade area in the same tumor, then we can say it is dedifferentiated parosteal osteosarcoma. So radiologically, parosteal osteosarcoma, if there is dedifferentiated, there will be lytic areas. And this is surface tumor with medullary invasion. So this drawing I have just made to show the invasion into medullary cavity. That is important while you are evaluating the resection because prognosis is really different. If it is just high-grade surface osteosarcoma involving the surface or it is invading the medullary cavity, it will behave like a conventional osteosarcoma. So this is image is just showing the high-grade transformation in parosteal osteosarcoma, dedifferentiated parosteal osteosarcoma. So telangiectated osteosarcoma, you may get little osteoid. Hemorrhagic tumor, radiologically it looks like aneurysmal bone cyst. But if it is big tumor, it can go to the soft tissue, destroy the cortex, then you can know, okay, it's not ABC, it is a destructive malignant tumor. And you may not get osteoid. So, only thing is there is fibrous septa filled with blood and highly anaplastic tumor cells. So don't go just behind the osteoid. If it is clinically and radiologically osteosarcoma, even though you don't find osteoid, you can give osteosarcoma. A small cell osteosarcoma, it's really difficult. So it arises in diaphysis where Ewing sarcoma arises. It arises in young age, Ewing sarcoma arises in young age. Mesenchymal chondrosarcoma, young age. It is a small round cell tumor. It can also arise in diaphysis. Microscopically, all of them look same. If you can find osteoid, fine. If you cannot find osteoid, it's really difficult. Here, ISC might help. And unfortunately, ISC may not help. So all the markers are positive in all these tumors. Even you do cytogenetics, same translocation. Even whatever is this EWSR1 gene is present in the small cell osteosarcoma. So now the controversy is really it's a small cell osteosarcoma or it is dedifferentiated Ewing sarcoma. So conventional, okay, all of us know conventional. So this is a 16-year male with mass in distal femur. So Trucker biopsy was just clear cell tumor malignant, maybe carcinoma metastatic. No osteoid. So, epithelioid osteosarcoma, yes. No osteoid. So this is same specimen. It was around 5 to 2.5 centimeter after chemo. This is all necrotic area. It was more than 90% necrosis. So many of you ask, how to find necrosis. So you coagulative necrosis, ischemic necrosis, you will not find that because it's already organized. So what you see is fibrous tissue and some residual osteoid, bone, that's all. So this is the residual tumor with this anaplastic feature. So in dissected specimen, we got cartilage also. So cartilage is very diagnostic of osteosarcoma. So this is a 19-year male with clavicular tumors, clinically osteomyelitis. Strongly they are thinking of osteomyelitis. They sent a small biopsy, Trucker biopsy. I gave diagnosis of osteosarcoma, but since it was young patient and there was clear cell changes. So there are some clear cells in small biopsies. So I talked to the surgeon. So I said, okay, chondrosarcoma does not occur in your this age, but clear cell chondrosarcoma can occur. So can you do please ISC? So ISC suggested, okay, this is osteosarcoma, fine. But the problem arose after resection. So they gave chemotherapy for conventional osteosarcoma, did not respond at all, 0% necrosis. And the resection was like this. So this is bone. So huge tumor, looks like a lymph node, grossly. So that I got carried away. And I got like this. So I could not diagnose at all. I thought, so I thought whether the sample, previous sample was from the same patient. Yesterday, that day there was only one OT. While doing, there is one case while doing true cut biopsy. So it looks like carcinoma. Can it be salivary gland carcinoma or something? So even there was some keratin. So I just searched a lot of literature. I couldn't find any way. So I just learned my basic things. Okay, sample. So I regrossed. So now I regrossed from this area. And I got the typical osteosarcoma. There are a lot of cartilage, of course, malignant. So this was epithelioid osteosarcoma. Patient died after, I think, after 15 days they called me, there's a lot of spinal metastasis multiple and it is bedridden patient. This is osteoblastoma like osteosarcoma. It really looks like osteoblastoma. So this is acceptable, this edition of WHO also. So it really looks like osteoblastoma. Osteoblastic rimming of bony trabecula microscopically. Atypia doesn't help, because some of the osteoblastoma can be atypical. Mitosis can be seen in osteoblastoma. So only thing is permeation to the normal bone, invasion into the bone microscopically. Other feature might not help. This is osteoblastoma. This is osteoblastoma. So here is circumscription. It is not invading into surrounding bone. But here you can see it is invading into the pre-existing host bone. So that is the only way to diagnose. It is not atypia. Another controversial term is chondroblastoma like osteosarcoma. I tried once, but I failed. So clinically, microscopically, it's exactly same as chondroblastoma. Same. So this is chondroblastoma like osteosarcoma, even though WHO does not act, has deleted in this edition, but that entity still exists. So this is 27-year male infiltrative proximal humerus mass. So I talked to the radiologist, I learned a lot of radiologists, I asked whether this is invasion. So it was going into the muscle, it was going into the joint cavity, ligament labrum, all invaded. So it cannot be benign, of course. So, okay, so my diagnosis was, okay, can it be chondroblastoma like osteosarcoma versus chondroblastoma? This is the specimen. It has almost eaten up the muscle and everything. Half of the joint is gone. So looking at this, I thought can be the osteosarcoma. So this was the true cut biopsy, typical chicken wire, but there was bone formation also. This is the microscopic image. So what was this? So I could not find any thing suggestive of osteosarcoma except for invasion, infiltration. I didn't even find a single mitosis. The previous, I suggested ISC also. ISC was almost like they didn't agree to for osteosarcoma, maybe chondroblastoma. So I gave just aggressive chondroblastoma. So I don't know what will happen to the patient. Let us follow up. So this is just osteosarcomas dedifferentiated. It can be in chondrosarcoma, some osteosarcoma can arise. In carcinomas, urinary bladder carcinoma, osteosarcoma can arise. Dedifferentiation, osteosarcoma can be in the breast, can be in the ovary. Okay. So ISC, what is the role of ISC? Just a few lines. So ISC in diagnosis of osteosarcoma is really helpful, but cannot be relied completely. Sometimes it really misguides you. ISC may not give correct diagnosis in all the cases and to be interpreted in the clinical context. However, in some of the cases, it really helps. But if you depend completely on ISC, your patient will be harmed. So, osteosarcoma is morphologically and genetically heterogeneous tumor with broad radiological and histological differential diagnosis. None of the diagnostic modality is complete if applied in isolation. So it is combined modality of diagnosis. Independent microscopic interpretation can be really hazardous. So location of tumor, imaging finding, microscopic finding in combination with age can give correct diagnosis in most cases. Communication with surgeon is the key in the diagnosis, it is really key. So don't hesitate to talk. So just forget about ego, who is big, surgeon big or pathologist big, I am senior, you junior, just forget, think of the patient. It really helps. So again, I repeat, malignant cartilage in children, it is osteosarcoma. Thank you.
Thank you very much, Dr. Abhimanyu Jha, for emphasizing the need for a multidisciplinary approach for the diagnosis of osteosarcoma. And I would just like to remind the residents that osteosarcoma cannot be diagnosed without looking at the X-ray. If you haven't looked at the X-ray, you have not diagnosed osteosarcoma. And if we are having a difficulty in diagnosing osteosarcoma, we have to look at the CT of the chest as well. Because a X-ray, simple X-ray of the local lesion may be enough, but the chest has to be subjected to CT examination to pick up metastasis if present. And we've got to remind ourselves every time we look at bone lesions that our pathology books on bone tumors contain more radiographic images than microscopic ones. So the radiographic image is the gross image in bone tumors, more so with small biopsies. So we have to look at that, otherwise we cannot diagnose. And Dr. Abhimanyu has clearly and very rightly emphasized the need to do so. Thank you very much. So,
we would like to sincerely apologize to Dr. Shailesh as his presentation has been rescheduled for tomorrow because of the time restraint. I would like to ask Dr. Rajesh and Dr. Shailesh to present the token of appreciation and certification to Dr. Abhimanyu Jha. Now, I'd like to call Professor Dr. Ramchandra Adhikari to present the token of appreciation to Dr. Rajesh and Dr. Sailesh. We have now come to the crux of today's event, the inauguration program. Now it is my honor to invite the President and Organizing Chairperson, Dr. Runa Jha, to please take her seat on the dais. Doctor. I think she'll be here soon. Now I'd like to invite the chief guest for today, Dr. Chanda Karki, Professor of Gynecology and Honorable Member of the Parliament, to come take her seat on the dais. Sorry for the delay. We have now come to the crux of today's event, the inauguration program. Now it is my honor to invite the President and Organizing Chairperson, Dr. Runa Jha, to please take her seat on the dais. Now, may I invite the chief guest for today, Dr. Chanda Karki, Professor of Gynecology and Honorable Member of the Parliament, to join Dr. Runa on the dais. With equal pleasure, I'd like to invite our special guest for today, Dr. Rajesh Sambaji Rao Pandav, WHO representative of Nepal, to kindly take his seat on the dais. The next distinguished individual I'd like to invite on the dais is the General Secretary, Dr. Nirajan Mainali. Now, ladies and gentlemen, excellencies and press members, I request you all to please take your seats and enjoy the rest of the evening we have lined up for you today. To extend our gratitude as a small token of our appreciation for the valuable contribution of your time and presence, may I call upon stage Dr. Sivaraj Gesi, Scientific Chair, on the stage to please honor our special guest with the Khada ceremony and token of love. I would like Dr. Nirajan to give away the token of love. Thank you, Dr. Sivaraj Casey. Moving forward, I would like to request every one of you to rise for our national anthem.
सार्वभौम भई फैलिएका मेची महाकाली सायो थुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली प्रकृतिका कोटि कोटि सम्पदाको आचल वीरहरूका राज गरे स्वतन्त्र अचल ज्ञान भूमि शान्ति भूमि तारै पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल बहु जाति भाषा धर्म संस्कृति छन् विशाल अग्रगामी राष्ट्र हाम्रो जय जय नेपाल।
We've almost come to the end of the ceremony for today. To mark the commencement of the 10th Conference of Association of Clinical Pathologists of Nepal and also to mark the success of today's event, we have a small Dio lighting ceremony prepared. I would like to request Dr. Runa Jha and Dr. Chanda Karki to proceed with the ceremony. I would like to ask all the special guests to join for the Dio ceremony. Hello? Thank you so much. The room surely feels a lot brighter, especially with all the luminous personalities here today. Once again, I'd like to request Dr. Runa Jha to come on stage and do the honor of delivering a brief inaugural remark.
थ्याङ्क यू पहिला त अलिकति अपोलोजी हाम्रो गेस्टहरूलाई पनि एकचोटि तल झरेर त्यसपछि फेरि माथि झर्नुपर्ने हुन्छ सो यस कार्यक्रमका प्रमुख अतिथि माननीय प्रोफेसर डाक्टर चन्दा कार्कीज्यू यस कार्यक्रमका विशेष अतिथि WHO रिप्रेजेन्टेटिभ नेपाल डाक्टर राजेश सम्भाजीराव पाण्डव हामीमाझ उपस्थित हुनुभएका हाम्रो निमन्त्रणालाई स्वीकार गरेर आउनुभएका भक्तपुर क्यान्सर हस्पिटलका निर्देशक डाक्टर विष्णु दत्त पौडेलज्यू केम्सनका अध्यक्ष भक्त हमालज्यू प्रोफेसनल सोसाइटीका प्रतिनिधिज्यूहरू पत्रकार बन्धुहरू र सबै डेलिगेट्सहरू यहाँहरूलाई एकचोटि फेरि म यो 10th नेसनल कन्फरेन्स अफ ACPN मा एकचोटि फेरि यहाँहरूलाई स्वागत गर्न चाहन्छु। अहिलेको स्पीच स्ट्रक्चर छैन त्यसैले केही तलमाथि हुन सक्छ त्यसमा तपाईहरुले नि थप गर्न सक्नुहुन्छ। एक्चुअली दिन कस्तो रह्यो भने एकदम बिजी शेड्युलका बावजुद हाम्रो निमन्त्रणा स्वीकार गरेर वहाँ यस मञ्चको शोभा बढाइदिन आइदिनु भएकोमा एकचोटि फेरि उहाँलाई पनि धन्यवाद दिन चाहन्छु। हाम्रो समस्याको कुरा गर्नु पर्दाखेरि माननीयज्यू हिजो आज र भोलि हामी क्यान्सरको ट्रिटमेन्टमा पेथोलोजीको के महत्त्व हो त्यो छलफल गर्दैछौँ। हिजो पनि कुरा गर्यौँ, आज पनि बिहानदेखि नै त्यही छलफलमा हामी छौँ कि कसरी पेथोलोजीको जुन परीक्षणहरू हुन्छ अहिले त्यो धेरै नै फर्को मारिसकेको छ। पहिला जुन 10-15 वर्षको अगाडिको पेथोलोजी थियो र जुन आजको पेथोलोजीको प्र्याक्टिस छ त्यो एउटै छैन। आज त्यसको टेस्टमा के आयो, सबै क्यान्सरको एउटै उपचार हुँदैन। त्यो एउटा पर्टिकुलर क्यान्सरमा पनि त्यसमा कुन म्युटेसन छ, कुन अरू थप परीक्षण पोजिटिभ आएको छ, त्यसको अनुसारले त्यसको औषधि डिसाइड हुन्छ। तर विडम्बना के छ भने, ठुलो विडम्बना के छ भने क्यान्सरको ट्रिटमेन्टमा परीक्षणको त्यो पाटोलाई पुरै इग्नोर गरेको देखिन्छ। आज पनि हामी बेसिक परीक्षण जसलाई कि हामी जस्ट एउटा मर्फोलोजीको बेसिसमा डायग्नोसिस दिन्छौँ र धेरै जसो उपचार त्यसकै बेसिसमा हुन्छ। त्यसको कतिवटा कारण देखाइन्छ। सबभन्दा पहिलो कारण कस्ट, परीक्षण धेरै महँगो भयो। हिजो पनि कुरा उठेको थियो, 50,000 रुपियाँ लाग्छ थप। एउटा ब्लड क्यान्सरलाई ब्लड क्यान्सर भनिसकेपछि बोन म्यारोमा थप 50,000 जति रुपियाँ उसले परीक्षणमा खर्च गर्नुपर्ने हुन्छ। त्यो 50,000 धेरै महँगो भएन, उसले कसरी तिर्छ? अग्रिड, उसले तिर्न सक्दैन। त्यसपछि उसको उपचार, त्यो त 50,000ले हुँदैन, लाखौँ लाग्छ, 5 लाख लाग्छ, 10 लाख लाग्छ, 15 लाख लाग्छ। त्यो 50,000 खर्च नगरेर जुन उसको 5 लाख 10 लाखको जुन ट्रिटमेन्ट वेस्ट हुन्छ त्यसको जिम्मेवारी कसले लिने? त्यसको लागि यो देशमा पेथोलोजीको एउटा राम्रो क्यान्सर प्रयोगशालाको विकास हुनु अत्यन्तै नै आवश्यक छ। माननीयज्यू, बहुत दुःख लाग्छ भन्दाखेरि हामी कहाँ क्यान्सर अस्पताल, क्यान्सर विशिष्टीकृत अस्पताल पनि छन्। एकजना हाम्रो डाक्टर विष्णु पौडेल डाक्टर साहब, आदरणीय डाक्टर साहब, त्यस अस्पतालको प्रतिनिधि यहाँ हुनुहुन्छ पनि। अरू पनि केही क्यान्सर स्पेसिफिक अस्पतालहरू खुलेका छन्, सरकारी स्तरमा पनि छन्, निजी स्तरमा पनि छन्। तिनीहरूको परीक्षणको अवस्था कस्तो छ त? त्यो कहिले कुरा पनि गरिँदैन। त्यो न न्युजमा आउँछ, खालि ट्रिटमेन्टसम्म पुगिन्छ। त्यो ट्रिटमेन्ट सही भयो गलत भयो त्यसको पछाडि जुन ब्याकअप गर्ने परीक्षण थियो त्यसको अवस्था के भयो? नोबडी इज बदर्ड। एकदम बहुत दुःखका साथ भन्नुपर्छ, न त्यहाँका डाइरेक्टर साहबहरू म्यानेजमेन्टहरूलाई त्यसको चिन्ता हुन्छ, न अरू कसैलाई त्यसको चिन्ता हुन्छ। फोकस अन्त कतै हुन्छ। चाहिँ नै हाल्यो भने त्यसको के त बाहिर गइहाल्छ नि, बाहिर पठाइहाल्छौँ नि। बाहिर पठाइ हामी कहिलेसम्म परीक्षण गरिरहन्छ? कहिलेसम्म हामी आत्मनिर्भर कहिले बन्ने? जमात हेर्नुहोस् माननीयज्यू, 310 जना पेथोलोजिस्ट छौँ एसिपिएनमा आबद्ध। त्यसमध्ये 260 जना आज यस मञ्चमा हुनुहुन्छ। हरेक वर्ष 25 देखि 30 जना नयाँ पेथोलोजिस्टहरू थपिन्छन् यो समूहमा। हामीसँग काबिलियत छैन र? छैन भने के भने ठाउँ नै छैन, त्यो डेभलपमेन्ट नै भएको छैन कहिलेसम्म त्यसरी। र त्यसपछि बाहिर पठाउनु त्यति मात्र, त्यति सहज छैन। बाहिर त जान्छ, पठाउनु पनि पर्छ, कस्ट इफेक्टिभ पनि हुनु पर्यो टेस्ट। सबै टेस्ट आफैले गर्न पनि नसकिएला, बाहिर पठाउनुमा मेरो त्यति आपत्ति छैन। आवश्यक परेमा बाहिर पठाउनु कुनै सरकारी प्रयोगशालाले त लिँदैन। यहाँबाट गएको परीक्षण जान्छ कहाँ? त्यहाँको कुनै निजी प्रयोगशालामा जान्छ। त्यो निजी प्रयोगशालाको कस्ट कति हुन्छ त्यो एकचोटि इमेजिन गरौँ त। त्यो कस्ट चाहिँ फेरि कसले तिरिरहेको छ त? त्यही गरिब जनताले तिरिरहेको होइन? होइन, त्यसपछि त्यहाँको पेथोलोजीसँग तपाईँ कम्युनिकेट गर्न सक्नुहुन्न, कुरा गर्न सक्नुहुन्न। उसले के देख्यो, के फिल गर्यो, यो कुनै एउटा सुगर युरिया गरे टेस्ट जस्तो त होइन। यो पेथोलोजीको परीक्षण जुन क्यान्सरको परीक्षण गर्छौँ त्यस्तो खालको परीक्षण त होइन। डक्टर र पेथोलोजिस्ट बिच कम्युनिकेसन हुनुपर्छ। बाहिर पठाउँदाखेरि त त्यो सबै ग्याप हामी फिल गर्छौँ। र त्यसपछि एउटा इन्कम्प्लिट परीक्षणको आधारमा बिरामीको टेस्ट गरिन्छ, उसको उपचार गरिन्छ। पेपरमै पढेको थिएँ एकचोटि, उसको कति वर्षसम्म चाहिँ उसलाई किमो दियो, कति साइकल, अनि त्यसपछि ठिक भएन। भरे त लङ क्यान्सर, प्राइमरी लङ क्यान्सर भनेर ट्रिट गरिरहेको, त्यो अन्त कतैबाट मेटास्टेसिस थियो, जुन कि जसको लागि जुन स्पेसल परीक्षणहरू गर्नुपर्ने हो त्यो चाहिँ नगरिएर त्यसले चाहिँ अर्कै रोगको किमो चाहिँ खाइरह्यो। त्यो वेस्टेज होइन होइन। सो त्यसैले परीक्षणमा लगानी बढाउनु अत्यन्तै जरुरी छ। सरकारले पनि एकदम न्यून सहयोग गर्नुहुन्छ, थोरै नै सहयोग छ क्यान्सर पेसेन्टलाई, त्यो सहयोग पनि परीक्षणको लागि छैन। हाम्रो माग चाहिँ के छ भने एउटा बेसलाइनबाट क्यान्सर हुन सक्छ या यो क्यान्सर छ भनेर इस्टाब्लिस भइसकेपछि त्यो क्यान्सरको थप वर्गीकरण गर्न जे चाहिन्छ, जे खर्च लाग्छ क्यान्सरको लागि पाउने सहयोगमा त्यो पनि हुनुपर्छ। रिसेन्टली एउटा न्युज सुनेका थियौँ, एकदम सुखद समाचार। कि नेपाललाई चाहिँ बच्चाको ट्रिटमेन्ट क्यान्सरको ट्रिटमेन्ट चाहिँ फ्रीमा उपलब्ध हुनेवाला छ। एकदमै राम्रो समाचार। त्यसमा चाहिँ परीक्षण फेरि कहाँबाट हुन्छ त? फेरि उसले गलत या इन्कम्प्लिट परीक्षणको आधारमा उसले औषधि मात्र खाइरह्यो भने त त्यसको फाइदा हुन्छ त? के हुन्छ? मोर्टालिटी, त्यसपछि या त्यो ट्रिटमेन्ट फेलियर, त्यो सबको रिस्क त त्यति नै रहन्छ। सो त्यसैले यो देशमा एउटा सरकारको पहलमा राम्रो प्रयोगशाला क्यान्सरको लागि स्थापना हुने, एउटा रेफरेन्स प्रयोगशाला स्थापना हुनु अत्यन्तै आवश्यक छ। कतिसम्म छ भने निजी क्षेत्रमा पनि क्यान्सर अस्पताल आइरहेका छन्। रिसेन्टली सुनेको थियौँ 1 अरब लगानीमा एउटा क्यान्सर अस्पताल इस्टाब्लिस भयो। अब नाम लिन चाहन्न, एकदम राम्रो हैन, बिरामीलाई सहुलियत हुन्छ। अब त्यो न्युज सँगसँगै के थियो भने 1 अरबमा यो मेसिन भित्रियो, यो मेसिन भित्रियो, आइएससी परीक्षण चाहिँ अहिलेलाई हुँदैन, आइएससी परीक्षण चाहिँ अहिलेलाई हामी बाहिर पठाउँछौँ। त्यो समाचार हेर्दा पनि लाज लाग्ने हो। 1 अरबको अस्पताल, 1 अरबको अस्पताल, त्यसमा 1500-2000 पर्ने आइएससी परीक्षण चाहिँ हुँदैन, त्यो चाहिँ बाहिर पठाउँछौँ भन्न पनि कसरी सकेको। र त्यस्तो क्यान्सर अस्पतालहरूलाई हामी क्यान्सर अस्पतालको मान्यता दिइरहेका छौँ। कुनै विशेषज्ञ अस्पताल इस्टाब्लिस हुन्छ भने खालि उसले सय्या राखेर, मेडिसिन राखेर विशिष्टीकृत अस्पताल हुन सक्दैन। त्यसको लागि चाहिने जे जति विशिष्टीकृत परीक्षण हुन्छ त्यो परीक्षण सेवा उसले त्यहाँ उपलब्ध गराउनु पर्दछ। त्यसपछि मात्र त्यसलाई विशिष्टीकृत क्यान्सर अस्पतालको मान्यता दिनुपर्छ। एटलिस्ट हामी पेथोलोजिस्टले चाहिँ त्यसलाई विशिष्टीकृत क्यान्सर हस्पिटल त्यति बेला मात्रै मान्छौँ। जसले परीक्षण गर्दैन, खालि उपचार गर्छ, त्यो कसरी विशिष्टीकृत अस्पताल हुन सक्छ? अर्को समस्या आउटसोर्सिङ। मैले भनि नै सकेँ माननीयज्यू, देशबाट कति सङ्ख्यामा बाहिर गइरहेको छ, त्योभन्दा बढी शिक्षामा गइरहेको होला हैन। पठाउनु पनि पर्छ बेला बेलामा, त्यसको चाहिँ पुरै विरोध होइन, तर त्यसको साइड इफेक्ट्स हेरौँ। त्यसले गर्दाखेरि देशमा राम्रो प्रयोगशालामा लगानी हुनै सक्दैन। यहाँ टेस्टै राख्नुहोस्, म आफ्नै ल्याबको पनि कुरा गर्छु, यति सस्तोमा त्यहाँ परीक्षण गर्छौँ, यति सस्तोमा गर्छौँ, स्टिल त्यहाँ परीक्षण आउँदैन। भएको परीक्षण पनि विदेशमै जानुपर्छ। र त्यसको एउटा मुख्य रिजन एक त हाम्रो क्लिनिसियन साथीहरूले भन्नुहुन्छ मलाई यहाँको ल्याबको विश्वास लाग्दैन। अनि म कतिपटक उहाँहरूलाई भनेको पनि छु, कहिले आम्ने सामने हुँदाखेरि, यहीँबाट तपाईँ पढेको तपाईँको चाहिँ विश्वास गर्नुपर्ने, यहीँबाट हामी पढेको हाम्रो विश्वास चाहिँ गर्नु नपर्ने, तपाईँले त अधिकार कसले दियो? र त्यसको अर्को भनेको यो देशमा चाहिँ राम्रो प्रयोगशालामा व्यक्तिले लगानी नै गर्न सकेनन्, किन प्रयोगशालामा लगानी धेरै खर्चिलो हुन्छ। त्यसको लागि त यहाँ कमिसन खोरी र बिचौलियापन, यो क्यान्सर नै हो। पेथोलोजीको लागि चाहिँ यो ठुलो क्यान्सर हो। यो कतिले बुझ्नु भएको छ, कतिले बुझ्नु भएको छैन। नेपाल मेडिकल काउन्सिलको प्रेसिडेन्टलाई पनि मैले यो कुरा राखेको थिएँ, यो कमिसन खोरी पेथोलोजीको लागि ठुलो क्यान्सर हो र यसको हामीले उपचार पनि गर्न सकेका छैनौँ। हुन्छ के अझै त बिगबिगी सुन्यो भने अचम्म लाग्छ। टेस्ट पठाए बापत क्लिनिसियन्सलाई किकब्याक कति? 10%, अस्पतालको छ भने 10%, अस्पतालले नै दिनुहुन्छ धेरै जसोले, होइन भने 20%, 30%, 40%, बाहिरतिर 80%। अब त्यस्तो सिचुएसनमा चाहिँ प्रयोगशाला कसरी चल्छ? त्यस्तो प्रयोगशालाबाट कसरी रिपोर्ट जान्छ? एउटा गुणस्तर रिपोर्ट त जान सक्दैन। त्यसपछि त्यसमा त्यस्तै कम पढेको, तालिम लिएको त्यस्तै व्यक्तिहरूले प्रयोगशाला चलाएर त्यो स्याम्पल हेरेर नमुना दिए भने देलान्। एउटा राम्रो पेथोलोजिस्टले त्यस्तो प्रयोगशालाबाट रिपोर्ट जारी गर्न सक्दैन। कुनै हस्पिटलमा 60-40, 60 तपाईँ 60 हामीलाई दिनुहोस्, 40 मा तपाईँ पुरै खर्च चलाउनुहोस्। अझ त्योभन्दा ठुलो समस्या त अब फार्मेसीहरूबाट निस्किरहेको छ। हाम्रो बिरामीहरूको, हाम्रो जनताको चेतना त्यति नै छ, पुग्छन् फार्मेसीमा नमुना दिनलाई। फार्मेसीले के गर्छ? नमुना लिन्छ। फर इक्जाम्पल एउटा थाइरोइडको लियो, बिरामीसँग उहाँले लिनुभयो 1200 रुपियाँ, पेसेन्टले 1200 रुपियाँ तिर्यो। त्यसपछि त्यो स्याम्पल लिएर ल्याबसँग बार्गेनिङ स्टार्ट हुन्छ। कसले कति पैसामा गर्ने हो यो टेस्ट? 200 मा, 300 मा, 400 मा, हैन? ल कसले सस्तो गरिदिन्छ त? कसले गुणस्तरीय दिन्छ? तिम्रो कति खर्च लाग्छ? आई एम नट बदर्ड। कसले कतिमा तिमीले 500 मा त फलानु ल्याबले त 400 भनिरहेको थियो 350 मा म 10 वटा स्याम्पल पठाउँछु 350 मा 300 मा गर्ने हो त्यसको फाइदा कसलाई भयो त न प्रयोगशालालाई भयो न त पेशेन्टलाई भयो मेरो ल्याब चलाउने साथीहरूलाई पनि रिक्वेस्ट छ यदि 400 मा थाइरोइड गर्न सकिन्छ भने पेशेन्टलाई नै गर्दिउँ न त अब फार्मेसीबाट स्याम्पल उठाउने बिचौलियाको बिगबिगी र यस्तो सिचुएसनमा हाम्रो प्रयोगशालाहरू कसरी सञ्चालन हुन्छन् त यो हाम्रो ठूलो समस्या छ यसलाई कानुनको दायरामा यो जुन बिचौलियापन छ मेडिकलमा अरू सेक्टरमा पनि होला रेडियोलोजीमा पनि होला सायद अरूमा पनि होला सुनेको थिएँ एउटा रिलेटिभ हुनुहुन्थ्यो क्लिनिशियन उहाँले पनि एन्डोस्कोपी रेफर गरे बापत अर्को क्लिनिशियनलाई किकब्याक दिनुपर्छ भन्दै हुनुहुन्थ्यो हैन यो छ भने यो मान्ने चाहिँ हजुर आफै पनि एउटा डाक्टर हुनुहुन्छ यो क्यान्सरलाई चाहिँ जडाबाटै उखेड्नुपर्छ यसलाई यो जुन पर्सेन्टेज पाउने हुन्छ रेफर गर्ने पर्ने हुन्छ हैन यो चाहिँ जसरी उसले डाक्टर या अस्पताल छान्छ कि म फलानाले देखाउँछु त्यस्तै नै उसले आफ्नो प्रयोगशाला आफै छान्नु पर्यो उसलाई कसैले रेफर गर्ने हैन कि तिमी फलानु प्रयोगशालामा जाऊ या तिमी चिलानु प्रयोगशालामा जाऊ त्यो बिरामीको अधिकार हो त्यो उसले आजको डेटमा चाहिँ पाइरहेको छैन उसको चेतनाको कमी छ र हेल्थ सेक्टरमा इन्फर्मेसन ग्याप छ हेल्थ केयर मार्केटमा जहिले पनि प्रोभाइडरसँग बढी इन्फर्मेसन हुन्छ कन्ज्युमरसँग कम इन्फर्मेसन हुन्छ र त्यो जुन इन्फर्मेसन ग्याप हुन्छ त्यसको चाहिँ फाइदा उठाइरहेका छन् यहाँ विभिन्न व्यक्तित्वहरूले यो कुरा चाहिँ माननीयज्यूले विचार गरिदिनु पर्यो र हाम्रो आवाज चाहिँ पुर्याइदिनु पर्यो अगाडिसम्म आजको डेटमा पेथोलोजिस्टको संख्या गर्व लाग्छ भन्नलाई 310 हामी पुगिसकेका छौं अब बेला आइसकेको छ हामीले विभिन्न ठाउँमा मेडिकल कलेजेसहरू स्याचुरेट हुँदैछन् पहिला त अझ पनि गभर्नमेन्टमा त्यसको खासै बढेको छैन आकर्षण 25-26 जना पेथोलोजिस्ट मात्र हामी गभर्नमेन्टमा छौं बेला आइपुगेको छ यो क्यान्सरको डायग्नोसिस एउटा साधारण तरिकाले जुन गर्न सकिन्छ एउटा एफएनएसी गर्न केही पैसा लाग्दैन केही ठूलो टेस्ट होइन त्यो हैन बायोप्सी पनि अरु मेसिन भन्दा अलि सस्तै नै पर्छ हैन यो हामी यो जिल्ला भन्दा तलसम्म पुर्याउन सक्नुपर्छ हेर्दै हुनुहुन्छ मानिज्यू यति ठूलो जमात छन् गइहाल्छन् नि कोही न कोही त हैन यो चाहिँ हामीले ठाउँमा सही ठाउँमा क्यान्सरको एउटा गाँठो कतै निस्किन्छ उ घुमिरहन्छ जबसम्म उसको त्यो पुरा जिउभरि फैलिदैन मर्मासन हुँदैन तबसम्म हायर सेन्टरमा आउँदैन उसको ठाउँमा डायग्नोसिस एउटा जस्ट एउटा निडल घोपेर त्यहाँको अलिकति पानी निकालेर एफएनएसी गरेर उलाई एउटा डायग्नोसिस दिन सकिन्छ हैन त्यो नपाएर लेट स्टेजमा प्रेजेन्ट गर्ने अनि त्यसपछि भन्ने के हुन्छ त यहाँका बिरामीहरू लेट प्रेजेन्ट गर्छन् कसरी लेट प्रेजेन्ट नगरोस् उलाई अर्ली प्रेजेन्ट हुने गरी हामीले फेसिलिटी के दिएका छौं त राज्यको आफ्नै दुविधाहरू होलान् हैन आफ्नै रिसोर्सेसको कमीहरू होलान् तर कमसेकम जे गर्न सक्छौं त्यो पनि त गरौँ त्यो इन्फर्मेसन नै कसैले पुर्याइरहेको छैन कि यसरी पनि गर्न सकिन्छ न सो त्यसैले अब हामीले पेथोलोजीको सर्भिस जिल्ला अस्पताल र त्यो भन्दा तलसम्म नै पुर्याउनु पर्ने हुन्छ अब आजको डेटमा हेर्ने हो भने केन्द्रीय लेभलका अस्पतालहरूमा पनि बल्ल बल्ल बायोप्सी सर्भिस सुरु हुँदैछन् त्यहाँ अपरेसन गरेका स्याम्पल कता जान्छ थाहा छैन कतिसम्म छ भने इन्ट्रेस्ट पनि दिनुहुन्न मैले आफ्नो पहलले केही अस्पताललाई दिन खोजेको बायोप्सीको इक्विपमेन्ट कतिले लिनुभयो कतिले के भन्नुभयो मसँग ठाउँ छैन ठाउँ बनाइदिने हो अब ठाउँ गएर कसरी बनाइदिने त्यहाँ सो त्यो जनचेतना छ र त्यो केन्द्रीय लेभलको अस्पतालको कुरा गरेको केन्द्रीय लेभलको अरू होइन त्यो जिल्ला या प्रादेशिक लेभलको कुरा गरेको होइन फेडरल हस्पिटल्सको त्यस्तो छ हालत भनेपछि परीक्षण नै हुँदैन भने उसको उपचार कहाँबाट हुन्छ अनि उसले लेट प्रेजेन्ट नगरेर के गरोस् त क्यान्सर दिवस मनाउँछौं क्यान्सरको फोरमहरू छ ठुल्ठुला फोरमहरू छ त्यहाँ डायग्नोसिसको त कुरै हुँदैन त्यहाँ कोही पनि पेथोलोजिस्टको रिप्रेजेन्टेसन नै हुँदैन कुनै क्यान्सरको बिरामीलाई थाहा नै छैन होला कि उलाई मेन क्यान्सर भयो भनेर उलाई उर्दिकोले जारी गर्यो त्यो त पेथोलोजिस्टकै कलमबाट निस्केको हुन्छ उसैले साइन गरेको हुन्छ कि तिमीलाई क्यान्सर भएको छ त्यो जानकारी बिरामीसँग पुगेकै हुँदैन उले त्यो कुरा बुझेको पनि हुँदैन र जसले बुझ्छ उले बुझाउन पनि खोज्दैन ठुला ठुला क्यान्सरका फोरममा हेर्नुस् डायग्नोसिस माथि त कुरा नै हुँदैन डायग्नोसिसमा के एडभान्सेस भयो त्यो माथि त कुरा नै हुँदैन कुरै नै भएन भने त बिरामीले पाउँछ कसरी त्यसको फाइदा र हामी अगाडि कसरी बढ्छौं त्यसैले एउटा एमडी नै पढाउनलाई भन्यो भने आजको डेटसम्म पनि क्यान्सर त्यो धेरै अगाडि पेथोलोजी सर्भिस डेभलप भइसके पनि एउटा मेडिकल कलेजको हालत हेऱ्यो भने त्यस्तै छ। एमडी पढाउने छ एउटा बेसिक फेसिलिटी बाहेक, एउटा एचएनई स्टेन गर्ने बाहेक उसँग केही सुविधा नै छैन। एमडीको लेभलमा हामीले देखाउँदा पनि देखाएनौँ भने इक्विपमेन्ट, खालि किताब हेरेर किताबको फोटोहरू हेरेर कसरी सिक्छ? हामीले ए क्याटेगोरीको ल्याबमा फ्लो साइटोमेट्री हुनुपर्छ भनेर राख्यौँ, त्यो अलिकति मैले नै पुस गरे हो। कस्तो छ भने पढ्दाखेरि एमडी गर्दाखेरि उसले नदेख्ने, त्यसपछि यो देशमा त कसैलाई फ्लो चलाउनै आउँदैन, चलाउने कसले, त्यसैले मेसिन नराख्ने, एउटा भिसियस सर्कल भइरहने। मान्छेले देखेकै छैन, विद्यार्थीले देखेकै छैन, त्यसैले यो काम नै हुँदैन, काम हुँदैन, त्यसैले यो टेक्नोलोजी नै यहाँ विकास हुनु हुँदैन। अब यो भिजियस सर्कलबाट हामीले बाहिर निस्किनुपर्छ। एमडी पेथोलोजीको जब करिकुलम कुनै कलेजलाई एमडी पढाउन दिइन्छ भने त्यसको चाहिँ क्राइटेरिया मापदण्ड एसिपिएनले नै ठुलो स्वरले आवाज निकालेर त्यसको चाहिँ क्राइटेरिया रिभाइज गर्नै पर्छ। एटलिस्ट विद्यार्थीले देखाउनको लागि त उसँग पिसिआर सेटअप हुनु पर्यो, उसँग आइएससी हुनु पर्यो, उसँग फ्लो साइटोमेट्री हुनु पर्यो। एमडी लेभलमा एक्सपर्ट भएरै निस्किँदैन, ठिक छ, पछि गएर ट्रेन गर्छ, तर देख्नु त पर्यो नि कमसेकम, त्यो बेला प्र्याक्टिकल त कमसेकम गर्नु पर्यो नि। जुन चिजको टेक्नोलोजी उसले देखेकै छैन, किताब पढेर कहीँ एमडी हुन्छ, प्र्याक्टिकल नगरिकन कहीँ एमडी हुन्छ, त्यसमा त घर बसेर पढ्यो भने त। एमडी पेथोलोजी कुनै पनि कलेजले सबभन्दा पहिला एमडी पेथोलोजीको माग गर्छ सिटमा, केही नहुँदाखेरि पनि, सर्जरी नै किन भएको छैन त्यही पनि चाहिँ पेथोलोजीको चाहिहाल्यो र हामी दिइ पनि हाल्छौँ ल पढा भनेर। तर त्यसपछि त्यसले के देखेर निस्किन्छ, के हेरेर निस्किन्छ, त्यसको विचार हुँदैन। त्यसपछि हामी माथि लान्छ न के आउँछ। अझ यहाँको पेथोलोजिस्टहरूलाई क्यान्सर हेर्नै आउँदैन, उसलाई हेर्न आउँदैन। 3 दिनको कन्फरेन्स हामीले क्यान्सर थिम त्यसैले राखेको। केही दिन अगाडि पनि मैले यो इस्यु फेस गरेको छु, देखाइदिनलाई कि हेरौँ यहाँको पेथोलोजिस्टलाई क्यान्सर आउँछ कि आउँदैन। म भन्छु यहाँको पेथोलोजिस्टलाई त 90% क्यान्सर मात्रै आउँछ, बरु उसलाई बेराइन चिज आउँदैन। यहाँ जुन हाम्रो करिकुलम छ 90% उसलाई क्यान्सर मात्रै आउँछ, क्यान्सर मात्रै आउँछ, हाम्रो पढाइ त्यस्तो छ हैन। सो त्यो कुराहरू चाहिँ एकदमै त्यो एमडीको कोर्सले जसलाई क्राइटेरिया पाउँछ त्यो क्राइटेरिया, त्यो मेडिकल कलेजको क्राइटेरिया चाहिँ रिभाइज हुनु एकदमै नै आवश्यक छ। र न त यही लान्छना लागिरहन्छ कि यहाँको पेथोलोजिस्टलाई त क्यान्सर हेर्नै आउँदैन भनेर। क्यान्सर हेर्न आउँदैन भने त पेथोलोजिस्टको दोष होइन, त्यो कलेजको दोष हो जसले उसलाई प्रड्युस गरेको छ, उसलाई देखाएकै छैन कसरी आउँछ। यति चाहिँ मैले भन्न चाहेँ मान्यज्यू। अब त्यसपछि आजको यो कन्फरेन्सको कुरा गर्दाखेरि 3 दिनको कन्फरेन्स हामीले सञ्चालन गऱ्यौँ। यसमा हाम्रो 93 वटा पेपर्सहरू प्रेजेन्ट भएका छन्, त्यसमा 57 वटा 56 कि 57 वटा चाहिँ पोस्टर्स छन्, बाँकी ओरल प्रेजेन्टेसन र स्पिकर्सहरूको टक छ। सो यस कार्यक्रममा आएर शोभा बढाइदिनु भएका सबै डेलिगेट्सहरू र मञ्चमा आसीन हाम्रा मान्यज्यू, हाम्रो स्पेसल गेस्टहरूलाई चाहिँ एकचोटि फेरि धन्यवाद दिँदै मेरो मन्तव्य चाहिँ यही सकाउने अनुमति चाहे। नमस्ते।
Thank you, Dr. Runa. Today is an exceptional day, a coming together of distinguished pathologists to discuss the advancements and approaches in the field that everyone here is passionate about. And it wouldn't be possible if it weren't for the groundwork laid down by our seniors. So I would like to take this opportunity to ask Dr. Runa and Dr. Chanda to formally felicitate and honor our esteemed senior, Dr. Ishwar Lal Shrestha. He is the chairman of City Poly Path Lab and City Polyclinic Health Services. He introduced full automation in hematology, clinical biochemistry. He also introduced automation in blood culture. I would please like to ask the MCs to bring out the dosala and the certificate. He also introduced automation in blood culture, automation in bacterial identification, and antimicrobial sensitivity with MIC and automation in PCR tests. He co-authored many original research papers in national and international peer-reviewed scientific journals. He also established gold medal award by the name Dr. Ariel Shrestha Gold Medal Pathology. Allow me to read out the certificate. We are honored to present you this certificate on 10th National Conference of Association of Clinical Pathologists of Nepal on 21st and 22nd April 2023 for your enduring contribution towards service of pathology for 43 years. Your outstanding efforts for quality pathology service have made us proud and motivated many pathologists to become entrepreneurs. I would like to request Dr. Shester to say a few words.
Good evening, honorable chief guest, all the dignitaries in the dais, fellow pathologists, and distinguished guests. I would like to express my sincere gratitude for the recognition and honor bestowed upon me in this gathering of experts and professionals in the field of pathology. To receive this felicitation from such an esteemed community in recognition of my contribution to the study and practice of pathology is truly humbling and inspiring. I feel privileged to be a part of this distinguished professional who are dedicated to advancing the field of pathology through research, innovation, and collaboration. As a pathologist, I firmly believe that our discipline plays a crucial role in diagnosis and treating disease, and ultimately improving patient health and well-being. As we all know, the practice of pathology has evolved dramatically in the recent years. Advances in the technology and molecular diagnosis have unlocked new avenues of research and improved our abilities to identify diseases at the molecular level. These tools are allowed us to tailor treatments and explore new therapies that were once unimaginable. Scientists are using AI, artificial intelligence, DNA sequencing, precision oncology, and other technologies to improve the treatment and diagnosis of the disease. Liquid biopsies and synthetic biopsies are another innovations that can force cells to reveal themselves during the earliest stage of the disease. CAR T-cell therapy, the treatment that makes immune cells hunt down and kill cancer cells, was recently declared a success for leukemia patients. The treatment called CAR T-cell therapy involves removing and genetically altering immune cells called T cells from cancer patients. The altered cells then produce protein called CAR, that is chimeric antigen receptors. These cells recognize and can destroy malignant cells. But amidst the advancements and the promises they had, we should never forget the fundamental principles. As pathologists, we must always adhere to the highest standards of professional conduct, ethical behavior, which Dr. Runa has said about that, and evidence-based medicine. We must continue to foster a culture of collaboration. I would like to leave you with a quote by Dr. David Sackett, widely regarded as a father of evidence-based medicine, who once said, "Good doctors use both individual clinical expertise and best available external evidence, and neither alone is enough." I believe this statement resonates deeply with the essence of pathology. Thus, that we must strive to our clinical expertise with the most up-to-date scientific evidence. Once again, I would like to thank Dr. Runa Jha, the President of ASCPN, and the organizing committee for the honor, and I look forward to continuing to work with each and every one of you to advance the field of pathology. Thank you all.
Thank you, Dr. Shastra. It is really an honor to have you here with us today. Similarly, I would also like to extend our gratitude to Dr. Rajesh Sambhaji Rao Pandav, WHO representative of Nepal, for taking time out of his busy schedule to attend today's event. May I please invite you on stage for your Shubhakamana Sandesh.
Thank you. Chief Guest and Honorable Member of Parliament, Dr. Chanda Karki, President of the Association of Clinical Pathologists of Nepal, Dr. Runa Jha, Dr. Nirajan Mainali, General Secretary, Association of Clinical Pathologists of Nepal, eminent pathologist, Director of Cancer Hospital, all the members of the Association of Clinical Pathologists in Nepal, and distinguished guests, good evening and namaskar. First of all, I would like to thank Dr. Runa Jha to invite me for this August gathering of pathologists. I know her since the last 2.5 years in her role as the Executive Director of the National Public Health Laboratory, and WHO and me have worked closely with her for the last 2.5 years. Especially on COVID-19 related issues, but also in general on strengthening the National Public Health Laboratory and the public health laboratory system in Nepal. And her passion, I very much appreciate her passion, and you saw that passion in her opening remarks on the passion about the role of pathologists, passion about the ethics. So it has been a real pleasure to work with Dr. Runa Jha together. So thank you for this opportunity to say a few words, although I'm not a pathologist. I congratulate President Dr. Runa Jha and the organizing committee for this of the National Association of Clinical Pathologists in Nepal for organizing this 10th National Conference with the rightly selected theme, Evolution in Pathology, Guiding the Way into Modern Cancer Care. As we know, cancer is a leading cause of death worldwide, accounting for nearly 10 million deaths in 2020, or nearly 1 in 6 deaths. The most common cancers are breast, lung, colon, and rectum, and prostate cancers. In Nepal, cancer was attributed to 21% of non-communicable disease premature deaths, as per a report in 2016. In Nepal, the most common cancers are lung, followed by cervical cancer. Globally, around 1/3 of deaths from cancer are due to tobacco use, high body mass index, alcohol consumption, low fruit and vegetable intake, and lack of physical activity. Cancer-causing infections such as human papillomavirus and hepatitis are responsible for approximately 30% of cancers in low and lower middle income countries. Many cancers can be cured if detected early and treated effectively. WHO promotes early diagnosis of cancer and focuses on detecting symptomatic patients as early as possible so they have the best chance of successful treatment. Early diagnosis is directly related to improved cancer outcomes. Cancer screening is a different strategy than early diagnosis. Currently, WHO recommends screening programs for only 3 types of cancer, breast, cervical, and colorectal, but not for any other type of cancer. However, early diagnosis of cancer continues to be a challenge globally and particularly in resource-poor countries. Traditionally, cancer diagnosis is a time-consuming, less sensitive, expensive, and not readily accessible. However, technological advances in recent times have changed the scenario. We are fast approaching our dream of cancer diagnosis using a drop of blood. Further, access to cancer diagnostic services remain a challenge. WHO is pleased to note that Nepal has progressed significantly in endorsing a national in vitro essential diagnostic list, which complements the universal access to health. So congratulations for that. Since the time of Marcello Malfighi, the founder of microscopic anatomy in the 17th century, pathologists have used the microscope for diagnostic purposes. Professor Juan Rosoy said in 2007, I quote, "There is no other technique that provides abundant, quick, and cost-effective information as the classical microscopy." So that is still probably true, that morphological analysis by skilled observers will be with us for many years to come. And if I understood correctly, Dr. Una Jha, you also referred to this when you talked about this. Yeah. However, because of the advent of precision medicine, along with the expanding array of advanced technologies, genomics, pathology is bound to change dramatically. And it has changed. The advances in technology, imaging, computing, and artificial intelligence, the revolution has entailed a progressive adaptation to new clinical challenges, placing pathologists at the forefront of the era of precision medicine. The entire spectrum of modern pathology nowadays ranges from preventive, diagnostic, and predictive testing to treatment decision-making and knowledge sharing. Thus, morphological reports no longer represent the finish line, but only the starting line in the management of cancer patients. Because knowledge sharing among healthcare professionals is crucial, modern pathologists are now fully embracing the use of innovative technologies and computational devices, working alongside oncologists to facilitate the whole gamut of patient management. Thus, in this complex scenario, modern pathologists play a central role in the management of cancer patients, not only in the diagnosis, but also in the treatment decision-making by playing a fundamental part in bridging a gap between oncologists and molecular scientists. Hence, I call upon all pathologists of all generations is the necessity to combine or integrate the knowledge of morphology, advanced technology, and molecular pathology, including bioinformatics and artificial intelligence. Further, today and in the future, all pathologists have an important role to play in ensuring the new generation of pathologists are trained in integrated pathology. The era is not far when pathologists will play the leading role in precision cancer therapy through their inimitable skills. WHO has been supporting the Ministry of Health in terms of cancer prevention and control strategy development, various capacity building access, also regular reviews through collaboration with IARC on the cancer situation in Nepal, and giving recommendations on strengthening cancer prevention and control in Nepal. Recently, we've also been working with Kanti Children Hospital for childhood cancers, and just recently a team from Nepal went to the St. Jude Hospital, where we have promoted collaboration with St. Jude Hospitals for cancer treatments for children. And some good news is that some medicines will be available for childhood cancers free of charge to Nepal. And also there will be support for further work on cancer prevention and control. So WHO is committed to supporting the Ministry of Health, but also working closely with pathologists on cancer issues. I wish this meeting all success and assures continued WHO support for all your efforts. Thank you and namaskar.
Thank you, sir. On behalf of everyone present here, I would like to thank you for your kind and inspiring words. Since we're approaching the end of our event, it is our pleasure to have Dr. Chanda here with us today, and it would be my pleasure to invite you to say a few words.
सबैजनालाई मेरो नमस्कार। सबभन्दा पहिला मैले भन्न सुरु कहाँबाट गर्छु भने यो महिला र पुरुषको विभेद चाहिँ पहिलो यहीँबाट देखिन्छ, जहाँ पनि भन्ने गरेको छु मैले। यो ड्यास यति अल्गो बनाउँछ कि अल्गो अल्गो केटा मान्छेलाई मात्रै ठिक हुन्छ, किनभने यो बनाउने मान्छे चाहिँ केटै मान्छे हुन्छन् के। त्यहाँबाट भन्छु, तपाईँहरू दिनभरि कन्फरेन्समा बसेर थाकेको होला भनेर पनि भनेको हो। सबभन्दा पहिला त म यहाँहरू सबै उपस्थित, मैले धेरै सम्बोधन गरेर टाइम लिन चाहिनँ। मैले मेरा अग्रज डाक्टर साहबहरू पनि धेरैजना यहाँ बसिराख्नु भएको छ, म देखिरहेको ईश्वर डाक्टर साहब त हुँदै हुनुहुन्छ, विष्णु डाक्टर साहब, मेरो साथी डाक्टर गीता हुनुहुन्छ, यहाँ गोपी डाक्टर साहब हुनुहुन्छ, सुष्पना हुनुहुन्छ, सबै धेरै मान्छेलाई देखिरहेको छु र मेरा कन्टेम्पोरेरी साथीहरूलाई पनि देखिरहेको छु र धेरै यङ मान्छेहरू, कतिलाई मैले आफै पढाएको पनि विद्यार्थीहरूलाई देख्दा मलाई एकदम खुसी लागेको छ। र सबभन्दा पहिला त म यहाँ उपस्थित सबैजनालाई ड्यासमा बस्नुभएका मानिसहरू र यो प्याथोलोजी सोसाइटीका पदाधिकारीज्यूहरू र हाम्रो उपस्थित सबै हाम्रा आदरणीय व्यक्तित्वहरू र सबै यहाँ उपस्थित सबै महानुभावहरूलाई चाहिँ म नयाँ वर्ष 2080 को शुभकामना दिन चाहन्छु। सबैको नयाँ वर्ष सफल होस्, राम्रो होस् र चाहिँ हामी सँगै मिलेर केही परिवर्तनहरू गर्न सकौँ, नयाँ आयामहरू ल्याउन सकौँ भनेर म सबैलाई भन्दछु। र डाक्टर रुनालाई, स्पेसली डाक्टर रुना झालाई चाहिँ म धन्यवाद भन्न चाहन्छु कि मलाई उहाँले चाहिँ आज यो मौका दिनुभयो, मलाई यो इज्जत दिनुभयो। हुन त एकछिन अगाडि मात्रै हाम्रो फोनमा बाइचान्स कुरा भएको हुनाले म आउने मौका पाएँ, त्यही पनि मलाई चाहिँ, म हुन त प्याथोलोजिस्ट होइन, म गाइनोकोलोजिस्ट हो, तर प्याथोलोजिस्ट नभइकन मेरो हातै बाँधिन्छ, त्यो चाहिँ हो, मैले केही गर्न सक्दिनँ होइन। त्यस कारणले चाहिँ एकदमै धन्यवाद। र यही मौका म लिन चाहन्छु सबै प्याथोलोजिस्टहरूको यहाँको अगाडि कि म चाहिँ डाक्टर रुना झालाई चाहिँ म एकचोटि सल्युट गर्न चाहन्छु तपाईँहरूको ठुलो एप्लोड का साथ। किन मैले भन्दैछु भने मैले उहाँसँग धेरै काम गरेको छैन, तर कोभिडको बेलामा म पनि काठमाडौँ मेडिकल कलेजको प्रिन्सिपल र सिइओ को नाताले कोभिडको लागि के गर्न सकिन्छ भने लडिराख्दाको बखतमा मैले डाक्टर रुना झाले चाहिँ त्यो टेकुमा बसेर चाहिँ कोभिडको लागि जसरी काम गर्नुभएको छ त्यो त ज्यादै उदाहरणीय छ। हाम्रो जुनियरहरूलाई खास गरिकन म भन्न चाहन्छु कि तपाईँहरूले उहाँबाट सिक्नुहोस्। एउटा महिला हो, त्यही पनि मधेसमा, म पनि मधेसमा जन्मेर हुर्केको मान्छे हो, जन्मेर पढेर बढेर। त डाक्टर रुना झा एउटा यस्तो मान्छे हो जो मधेसमा बसेर हुर्केर म बुझ्न सक्छु कि मधेसको आज त त्यस्तो अवस्था छ। अब हामी जन्मिँदा मेरो त 60 वर्षभन्दा नि क्रस गरिसकेँ मैले, त्यतिखेर के थियो त्यहाँ, हामी कसरी यहाँसम्म पुग्यौँ भन्ने रुना झालाई डाक्टर साहबलाई हेरेर तपाईँहरूले सिक्न सक्नुहुन्छ। र उहाँले जुन आज काम गर्दै हुनुहुन्छ, आज पनि तपाईँले जब यहाँ बोलिराख्नु भएको छ नि, मलाई चाहिँ उसलाई समातेर संसदमा लैजाऊ जस्तो लाग्छ। मैले अनेस्टली मेरो मनबाट भनेको उसलाई चाहिँ, किनभने संसदमा मैले सोचेको संसदमा आज पनि भन्दैछु नि, म त डाक्टर मान्छे, तपाईँलाई थाहा छ म गाइनोकोलोजिस्ट मान्छे, अलिअलि काम गरेकै मान्छे हो, त्यस्तो एकदमै प्र्याक्टिस नचलेर काम नपाएर बसे मान्छे पनि होइन, अलिअलि काम गरेर खाएकै मान्छे हो। र अहिले राजनीतिमा जाँदा, संसदमा जाँदा म चाहिँ त्यो डाक्टरै ठिक थिएँ कि जस्तो लाग्छ कहिले। तर म मधेसमा जन्मेर हुर्केर यहाँसम्म आएर म आज यो पोजिसनसम्म पुग्दा मेरो सङ्घर्षको कथाहरू तपाईँहरूलाई सुनाएँ भने मैले रुना पनि त्यही हो है। मैले आफूले कति आरो अब्रो खटे, कति उतार चढाव देखेर यहाँसम्म पुगेँ। म जस्तो पुग्ने मान्छे हजारौँले पाएन होलान्, मलाई कसैको ब्लेसिङ्स लाग्यो होला, कसैले मेरो मौका भयो होला, भाग्य भयो होला कि म यहाँ पुगेँ। तर मेरो ठाउँमा भएका म जस्ता मभन्दा योग्य मान्छेहरू कति छन् जो पुग्न सकेका सकेनन् होइन। त्यस कारणले चाहिँ मैले भन्छु, अनि त्यसैले अहिले आएर जुन एउटा मौका मैले पाएँ, आफ्नो ठ्याक्कै रिटायरमेन्ट हुनु र नयाँ पार्टी आफ्नै मूल्य मान्यता र आफ्नै विचारमा हिँडेको हो कि त्यो हुन त त्यो पनि टेस्टिङ गर्न बाँकी छ। म त इमान्दारीपूर्वक भन्छु, म केही लक्कन छप्पन गर्ने मान्छे होइन, म जहिले पनि ठाडै बोल्ने मान्छे हो। त्यस कारण म त्यो सोच विचारले त्यो हो भने मैले पनि केही योगदान गर्न सक्छु कि आफ्नो पेसाप्रति, आफ्नो राष्ट्रप्रति, आफ्नो समाजप्रति गर्न सक्छु कि भनेर मैले त्यो मौका चाहिँ म भाग्यमानी भएँ कि मैले त्यो डेस्टिनीले मलाई त्यहाँ पुर्यायो। न त भने पुरानो पार्टीहरू मात्रै हुन्थ्यो, त्यो हुन्थ्यो भने मैले राजनीति गर्छु भने पनि मैले गर्न सक्दैन थियो होला। आफ्नो इन्डिभिजुअल हिसाबले मैले जे सेवा गर्न पाउँथेँ त्यो गर्थेँ होला। त्यस कारणले चाहिँ मैले त संसदमा भन्ने गर्छु, महिलाहरूलाई 33% भन्छौ तिमीहरू, 33% महिलालाई मात्रै किन, एकचोटि महिलालाई 33% दिउँ, अर्कोचोटि पुरुषहरूलाई 33% दिउँ, अनि रिजल्ट कम्पेयर गरेर हेरौँ भन्छु मैले चाहिँ जहिले पनि होइन। त्यस कारण त्यो हिसाबले चाहिँ रुना डाक्टर साहबलाई देख्दा मलाई जहिले पनि रुनालाई चाहिँ लिएर, त्यसैले कहीँ न कहीँ मलाई त यो राष्ट्रिय स्वतन्त्र पार्टी नहुँदै मैले डाक्टर सुधाहरूसँग कुरा पनि गर्थेँ कि चाहिँ ल हामी डाक्टरहरू मिलेर एउटा पार्टी खोलेर गर्नु पर्यो, हामी जहिले पनि नेताहरूलाई चाहिँ कोठामा बसेर गाली गर्ने, ठाउँमा पुगेर काम गर्नु पर्यो भनिराखेकै हो। अहिले पनि मैले रुनालाई देख्दा रुनालाई बोकेर मभन्दा बोल्न सिपालु छ, होइन उसलाई चाहिँ लिएर जाउँ कि जस्तो लाग्छ मलाई। उसले कामले पनि साबित गरेको छ, बोलीले पनि साबित गरेको छ, उसले आफूलाई प्रुभ गरेको छ र चाहिँ त्यही सिलसिलामा मैले रुनालाई सम्झेर यो फोन गरेको होइन कि चाहिँ ए के छ यो केही छ हाम्रो चाहिँ हाम्रो ल्याबोरेटरीको कति कुराहरू हुन्छ जुन मैले नबुझेको होला, मैले स्वास्थ्यको बारेमा विशेष आवाजहरू उठाउँछु, त्यस कारण त्यसको लागि मैले के गर्नु छ भने तिमीसँग कुरा गर्छु है भनेर अहिले भर्खर फोन गर्दा म यहाँसम्म आइपुगेँ अहिले होइन। त्यस कारण त्यो हिसाबले हामीले कुरा गर्नुपर्छ र चाहिँ अब धेरै कुरा गऱ्यो भने त दिनभरि लाग्छ। मलाई लाग्छ म अर्गनाइजरहरूलाई चाहिँ बधाई भन्न चाहन्छु, यस्तो महत्त्वपूर्ण विषयमा 3 दिने चाहिँ तपाईँहरूले कन्फरेन्स गर्नुभयो। यसमा पक्कै पनि प्याथोलोजिस्टहरूको लागि 93वटा पेपर पब्लिस आज प्रेजेन्टेसन भयो भन्नुभयो। पक्कै पनि हामी सबै प्याथोलोजिस्टहरूको लागि र खास गरिकन यङ मान्छेहरूको लागि चाहिँ यो ज्यादै महत्त्वपूर्ण भयो होला भन्ने मलाई चाहिँ लाग्छ र यो चाहिँ कन्फरेन्स चाहिँ सफल भयो होला भन्ने लाग्छ। तर कन्फरेन्स गरेर मात्रै हुँदैन, म जहिले पनि भन्छु र नेपाल मेडिकल एसोसिएसनको नेसनल हेल्थ समिट पनि त्यही कन्सेप्टमा भएको तपाईँहरूलाई थाहा छ कि कन्फरेन्स गरेर मात्रै हुँदैन। यहाँ बस्यो 3 दिन सुन्यो, हाम्रो कतिजनाको ज्ञान बढ्छ, त्यो सही इम्प्याक्ट हुँदैन। तपाईँहरूका उठेका कुराहरूलाई चाहिँ लिस्ट आउट गरेर सरकारले गर्नुपर्ने, राज्यले गर्नुपर्ने कुरालाई चाहिँ सरकारलाई घचघच्याउन तपाईँको कन्फरेन्सको आउटकम चाहिँ दिनुपर्छ र त्यसलाई फलो पनि गर्नुपर्छ एसोसिएसनले। हामी जस्तो मान्छेलाई तपाईँले सजिलोसँग तपाईँले मलाई चन्दा यसो गरिदियो भने घचघचाउन सक्नुहुन्छ। म जस्ता अरू पनि छन् त्यहाँ संसदमा जो चाहिँ काम गर्छु भनेर आएका छन्। त्यस कारण हामीले कहीँ न कहीँ यो कुराहरू चाहिँ हामीले गर्न सक्नुपर्छ र एसोसिएसनलाई मैले त्यो पनि काम गराउँछु। अहिले तपाईँहरू यस्तो एक्टिभ भएको बेलामा यो कुरा गर्न सकिन्छ। न त कन्फरेन्स त हामी सबैलाई थाहा छ यो चाहिँ ठुलो प्लेटफर्म हो। हामीले आफ्ना अनुभवहरू, आफ्ना चाहिँ नलेजहरू, आफ्ना विचारहरू चाहिँ एउटा एकअर्कासँग सेयर गर्ने, आफ्नो ज्ञान बाँडफाँड गर्ने कुरा त मैले यहाँ भनिराख्नु पर्दैन, यो हामीले सबैले गर्छौँ। मैले पढ्दा चाहिँ प्याथोलोजी एनाटोमी अहिले धेरै चेन्ज भयो होला। प्याथोलोजी मेरो प्रोफेसर हुनुहुन्थ्यो के बज्राचार्य के अरे भट्टाचार्य भन्ने कलकत्तामा, उहाँले जब पढाउनुहुन्थ्यो हरेकचोटि उहाँले पढाउँदाखेरि चाहिँ आँखा चिम्लेर यति राम्रो पढाउने कि जहिले पनि मलाई प्याथोलोजीमा त किताबै लेखु जस्तो लाग्थ्यो त्यतिखेर पढ्दाखेरि। टिचर भन्ने त्यस्तो हुन्छ क्या। तर अहिले त हुन त म नेपालमा ओर्लेपछि, कलकत्ताबाट एयरपोर्टबाट नेपालमा ओर्लेपछि साडी लाउने मान्छे सबै गाइनोकोलोजिस्ट भइहाल्थ्यो त्यतिखेर। केही क्राइटेरिया चाहिँदैन थियो, किनभने गाइनीमा नगइकन उपाय थिएन, काम गर्ने मान्छे थिएन। त्यसरी पसेको गाइनी निस्क्यो। गीता कसरी प्याथोलोजिस्ट भयो मलाई थाहा छैन। त्यस कारणले चाहिँ यो कुरा हामीले पढ्दा त एनाटोमिकल प्याथोलोजी, साइटोप्याथोलोजी, फरेन्सिक प्याथोलोजी यसरी हामीले पढिरहेको हो होइन। हामीले चाहिँ मोलिकुलर प्याथोलोजी यस्तो यस्तो भनेर पढेको हो। तर प्याथोलोजीले चाहिँ ठुलो, अघि नै डाक्टर राजेशले भन्नुभएको जस्तै प्याथोलोजीले ठुलो फड्को मारिसक्यो। धेरै इनोभेसन्सहरू, धेरै टेक्नोलोजीहरू, अहिले त अब आर्टिफिसियल इन्टेलिजेन्सका कुराहरू हामी सबैलाई थाहा छ कि अब त्यसको चाहिँ विकृति पनि आउला भन्ने मलाई डर लाग्छ। मेरो विद्यार्थीहरूले थिसिस सबै च्याट जिपिटीबाट निकाल्ने भने के गर्ने होला? आफ्नो त दिमागै युज नहुने भयो नि त। त्यस कारण कहीँ न कहीँ हामी जस्तो बुद्धि भएको डाक्टरहरूलाई बुद्धि भएको मान्छे भन्छ नि, हो कि होइन? बुद्धि भएको छ कि छैन? हाम्रो बुद्धि जति सबै एआईले लानु भएन नि त। त्यस कारण हामीले चाहिँ इमान्दारीपूर्वक आफूलाई दिएको काम, आफ्नो ब्रेनको युटिलाइज पनि गरौँ भन्छु मैले। टेक्नोलोजीमाथि फुल्ली डिपेन्ड, टेक्नोलोजी नभए आजको जमानामा बाँच्न सकिँदैन। तर टेक्नोलोजीलाई चाहिँ ब्यालेन्स गरेर युज गरौँ भन्छु। आफू मर्ने गरेर, आफू सखाप हुने गरेर टेक्नोलोजी युज नगर्नु भन्छु। तपाईँहरूलाई थाहा छ प्याथोलोजीको फादर को थियो भनेर? हु इज द फादर अफ प्याथोलोजी? खै एकजनाले भनिदिनु पऱ्यो मलाई। कसैलाई थाहा छ भने हात उठाऊँ त। कहिले ठुलो स्वरले भन्ने यार, सुनेन मैले। मोर्ग्याग्नी, जी मोर्ग्याग्नी भन्ने हुनुहुन्थ्यो, इटलीको हो। मैले यो किन उठाएको भने एउटा त हाम्रो अध्ययन गर्ने बानी, हिस्ट्री पनि पढ्ने बानी गरौँ। अर्को कुरा म फेरि एसोसिएसनलाई भन्छु, किन इटलीको मोर्ग्याग्नीलाई मैले फादर अफ प्याथोलोजी भन्नुपर्ने? मेरो नेपालको एउटा फादर निकाल न, मदर निकाल न भनेको मैले। प्याथोलोजीमा यत्रो मैले काम गर्दा, मेरो अग्रजहरू यहीँ बसिराख्नु भएको छ। मैले काम गर्दा मेरो भोजपुरमा पोस्टिङ हुँदा कोही प्याथोलोजी थिएन, म आफै सबै ब्लड टेस्टहरू सबै गर्थेँ। कलकत्तामा पढेको कि जानेर गरेको कि नजानेर गरेको, प्याथोलोजीदेखि पोस्टमर्टमसम्म सबै आफै गर्नु पर्थ्यो होइन। त्यो अवस्था थियो भने आज जब प्याथोलोजीले हामीले विकास गरेको छैन नभन्नु, प्याथोलोजीमा धेरै विकास भएको छ। मैले हेरिकन पनि विकास भएको छ। राम्रो अझ जानुपर्छ, त्यो म मान्दछु, समयअनुसारले हामी जानुपर्छ, त्यो सबै कुरा छ। तर हामी कहाँ, म एसोसिएसनलाई एकचोटि रिक्वेस्ट गर्छु, हामी कहाँ प्याथोलोजीको विकास गर्न महत्त्वपूर्ण भूमिका खेल्ने, मोस्ट इम्पोर्टेन्ट भूमिका खेल्ने मान्छेहरूलाई हामी फादर मदर बनाऊ। हाम्रो नेपालको फादर मदर प्याथोलोजीमा यही हो भनेर हुन्छ कि हुँदैन? खै जोडले भन न हुन्छ भने, आफै हुने कुरामा पनि त्यो चाहिँ मैले रिक्वेस्ट गरेँ। र अर्को कुरा चाहिँ मैले के भन्छु भने, चिफ गेस्ट बनाउँदाखेरि मलाई भित्र मनबाट लाग्ने कुरा चाहिँ के छ भने, चिफ गेस्ट बनाउँदाखेरि त्यही विषयमा धेरै ज्ञान प्राप्त भएको हाम्रो सिनियर मोस्ट मान्छेहरूलाई चाहिँ, अपडेटेड हुने मान्छेलाई चाहिँ चिफ गेस्ट बनाऊ। र म जस्तो सांसदलाई ल्याएर त्यो अगाडिको मेचमा राखेर बेसरी गाली गरौँ, हुन्न? त्यसपछि काम हुन्छ। किनभने प्याथोलोजी मैले धेरै बोल्न सक्दिनँ नि, बिकज मैले त कि च्याट जिपिटी हेरेर आउनु पर्यो होइन, नत्र भने मैले आफ्नो म एउटा क्लिनिसियनको हिसाबले बोल्न सक्ने कुरा मात्रै बोल्छु नि मैले। तर के भने यहीँ डाक्टर आइएल हुनुहुन्छ यहाँ हाम्रो अगाडि, हामीले मान्ने सबै गर्ने मान्छे, उहाँलाई यहाँ ल्याएर चेयर गरायो भने त्यसको सान अर्कै हुन्छ। त्यस कारण म त्यो तपाईँलाई त्यो पनि एउटा कल्चर डेभलप गरौँ होइन। किन राजनीति गर्ने मान्छे भन्दा चिकित्सक धेरै ठुलो हो, हाम्रो समाजले नचिने मात्रै हो है, हाम्रो समाजले नचिने मात्रै हो। हाम्रो चिकित्सकहरूले, हाम्रो नर्सहरूले, स्वास्थ्य कर्मीहरूले जुन काम गर्छन्, सांसदहरूले त्यस्तो काम गर्दै भए यो देश कहाँ पुगिसक्थ्यो। म त्यो चाहिँ इमान्दारीपूर्वक भन्छु, म नलुकाइकन भन्छु। त्यो चाहिँ मैले देखिरहेको छु। र चाहिँ अब प्याथोलोजीको भूमिका त मैले भन्नै पर्दैन। एउटा डायग्नोसिसमा, प्रपर ट्रिटमेन्टमा, डिजिजको मोनिटरिङमा यसको त ठुलो योगदान हुन्छ, त्यो मैले भनिराख्न पर्दैन यो मासलाई। तर के भने त्यसमा इमान्दारिता हुनु पर्यो। रिपोर्ट दिनुभन्दा पहिला दुईचोटि सोचेर दिनु पर्यो। अलिकति त्यसमा जस्तो यही हप्ता मात्रै संसदमा तपाईँले सुनेको भए एउटा आवाज उठेको थियो। एकजना सांसदले भन्नुभयो उसको आमाको चाहिँ यहाँ चाहिँ यो चाहिँ प्याथोलोजीले चाहिँ थ्रोटको क्यान्सर भनेर भन्यो, दिल्ली जानुभयो, त्यहाँ चाहिँ क्यान्सर छैन भने त्यहाँ ठुलो आवाज उठाउनु भयो। हुन त मैले बाहिर निस्केर उहाँलाई के भने उताको करेक्ट हो कि यताको करेक्ट हो कसरी थाहा पायो भन्ने मैले भन्न त। तर इमान्दारीपूर्वक भन्नुपर्दा हामीले आफ्नो पेसाप्रति इमान्दारिता, अलिकति संयम, सोचेर सल्लाह गरेर, पऱ्यो भने सिनियरसँग कन्सल्ट गरेर, कलिगसँग कन्सल्ट गरेर करेक्ट रिपोर्टिङ चाहिँ गरौँ। मेरो सल्लाह त्यति मात्रै हो, मैले त्यो भनिराख्नु पर्दैन। तर कहीँ न कहीँ आजकलको जमाना पहिला जस्तो सजिलो छैन काम गर्नलाई। अलिकति तलमाथि पऱ्यो भने हामीलाई गाला पिट्छन्, झ्याल फुटाउँछन्, 10वटा कुरा गर्छन्, मान्छे सचेत भइसकेका छन्। त्यस कारण त्यसको लागि चाहिँ हामीले एउटा गर्नुपर्ने हुन्छ। र अर्को अब टेक्नोलोजीहरू, इनोभेसनहरू, रिसर्चमा चाहिँ अलि बढी फोकस हुनु पर्यो। मैले मेडिकल कलेज चलाइराख्दाखेरि यहीँ पनि हुनुहुन्छ कतिजना, हाम्रो फ्याकल्टीहरूलाई एउटा पेपर लेखन, आफ्नो तिम्रो क्यारियरमाथि जान्छ, पेपर लेख भन्दा लेख्न नसक्ने हामी छौँ। मैले एकदम इमान्दारीपूर्वक भन्दैछु, हाम्रो रिसर्चको संस्कार हामीले बसाउन सकेनौँ। म लट्ठी लिलिकन सबैलाई ल पेपर लेख भन्न जान्ने मान्छे मै हो। त्यो कति बेर लाग्छ त्यो रिसर्च गर्नलाई, आफूले गरिरहेको कामको रिसर्च गर्नलाई। त आफ्नो क्यारियर बढ्छ भन्दा त नगर्नेहरूले अरू रिसर्च, जनताको हेल्थको लागि कसले रिसर्च गर्ला यहाँ, हो कि होइन भन्नु त? रिसर्चको पानी बसाल्ने कि नबसाल्ने? खै हाम्रो यङ प्याथोलोजिस्टहरू हात उठाउनु पर्यो। एउटा हात उठ्यो जम्मा, हेर्नु एउटा हात उठ्यो, त्यो भएन। एकदमै रिसर्चमा तपाईँहरू फोकस्ड हुनैपर्छ। रिसर्चले तपाईँलाई चिनाउँछ, इनोभेसनले तपाईँलाई चिनाउँछ होइन। त्यस कारणले यो कुरामा चाहिँ अलिकति धेरै पनि ध्यान दिनु पर्दैन। अलिकति ध्यान दिएर त्यसबारे सोच्नुभयो भने हुन्छ। त्यो कुनै गाह्रो काम होइन। म जस्तो त्यो मधेसको गाउँमा हुर्केर आएको मान्छेहरूले त अहिले 80वटा भन्दा बढ्ता पेपर लेखिसके, तपाईँहरू लेख्न सक्दैन? मलाई त अङ्ग्रेजी पनि आउँदैन होइन। तपाईँहरू त यहाँ राम्रो स्कुलमा पढेको, राम्रो ठाउँमा पढेको, यत्रो एक्सपोजर भएको, यत्रो ट्रेनिङ पाएको मान्छेहरूले पेपरहरू लेख्न नसक्ने पनि कोही हुन्छ त? हुन्छ? कोही बोलेन। तपाईँहरूले बोल्नुपर्छ जस्तो मलाई थाहा छैन यो चाहिँ है। त्यस कारणले चाहिँ कन्फरेन्सको बारेमा मैले धेरै केही नबोलौँ, हाम्रो चाहिँ अब छ। तर के भने अब देशको बारेमा भन्यो भने अहिले राज्यले चाहिँ स्वास्थ्यलाई निःशुल्क स्वास्थ्य दिनुपर्छ भने राज्य जनताको चाहिँ मौलिक हक अधिकार हो नि, निःशुल्क स्वास्थ्य शिक्षा पाउनुपर्छ भन्ने। तर छैन नि, यथार्थमा त कहीँ छैन नि। अघि नै डाक्टर रुनाले भनिसक्नुभयो कति 5 लाख, 10 लाख, 15 लाख भनिसक्नुभयो। तर साधारण अब यहाँ प्रब्लम कस्तो छ भने तपाईँले एकातिर बेसिक चिज नपुगेको ठाउँ पनि छ, एउटा चाहिँ सिटामलको ट्याब्लेट नपाउने, एउटा बेसिक गएर जाँच्न नपाउने हाम्रै गाउँ पनि छ अहिले हैन। तपाईँ कर्णाली प्रदेशको कुरा गर्नुहोस्, सुदूरपश्चिमको कुरा गर्नुहोस्, मध्य प्रदेशकै कुरा गर्नुहोस्, मेरै महोत्तरीको कुरा गर्नुहोस् हैन। तर त्यहाँ अहिले पनि म त्यसैको लागि लडिरहेको छु। एकातिर त्यो छ भने अर्कोतिर हामीले चाहिँ दुनियाँसँग कम्पिटिसन पनि गर्नुपर्ने छ नि। दुनियाँसँग हामीले कम्पिटिसन गर्नु पर्यो नि। हाम्रो सबै टेस्ट इन्डिया गयो भने हामी कसरी हुन्छ हैन। त्यसैले यसलाई चाहिँ हामीले ब्यालेन्सको हिसाबले हामीले लिएर जानुपर्छ। धेरै ठुलो चुनौती छ, हामी सबै मिलेर गर्नुपर्छ। कस्टको कुरा त त्यसैले नै जान्छ। हामीले कहीँ न कहीँ हामीले सरकारमा अब परिवर्तन चाहियो भनेर घन्टी बजाउन आएको हो। त्यसकारणले हामीले चाहिँ के भने म चाहिँ अब डाक्टरबाट नेता भएको छु। अहिले स्कुलमा भर्ना भए जस्तै भएछ मलाई अहिले चाहिँ। नयाँ स्कुलमा भर्ना भयो जस्तो लागेको छ र मैले भनेको छु म 6 महिना म धेरै बोल्दिनँ भन्दा नि बोलेर पार्टीबाटै झिक्देला नि जस्तो भइसक्यो। किनभने मैले अध्ययन गर्नुपर्छ जस्तो लाग्छ। मैले संविधान पढेँ, अब प्रतिनिधि सभाको नियमावली भयो, हरेक मन्त्रालयहरूका रिलेटेड ऐन कानुनहरू छन्, त्यो पढ्नु पर्यो, त्यो भाषा मैले जान्नु पर्यो, त्यहाँका नियम जान्नु पर्यो। त्यसकारण म 6 महिना चाहिँ म अध्ययन गर्छु र बिस्तारै म खुट्टा राख्छु भन्ने छु। त्यही पनि नबोली नहुने भएर 3-4 पटक मैले संसदमा स्वास्थ्यको लागि हल्ला पिटिसकेको छु। अनि धेरै बोल्यो भने फेरि गडबड होला नपढिकन भनेर त्यसकारण नयाँ स्कुलमा भर्ना भए जतिको भएको छ। तर मैले के भन्छु भने कुनै पनि नेताले मात्रै चाहेर हुँदैन, जनताले पनि चाहनुपर्छ। जस्तो जनता उस्तै नेता हुन्छ, हो कि होइन। त्यहाँ चाहिँ कस्तो हुन्छ भने नेताले बोलायो भने सारा संसार दौडेर जान्छ त्यहाँ हैन। एउटा घुस खुवायो भने घुस खुवाउने नेताको वरिपरि टन्नै हुन्छ मान्छे, त्यसको नेटवर्किङ एकदम बलियो हुन्छ। म इमान्दार नेता, म भाषण एकदम आदर्शवासी कुरा गरेर म राम्रो काममा गयो भने मेरो अघिपछि को पनि हुँदैन। त्यो चाहिँ यो समाजको नेकेड ट्रुथ हो। त्यसलाई बदल्ने तपाईँ हामी नै हो कि होइन? हो कि होइन? सबैलाई थाहा छ, तर हामी कसैले गर्दैन। मैले पैसा घुस खुवाउँ, म आफू पनि घुस खाँदिनँ। मलाई सबैले सोध्छन् तिमी अझ पनि प्र्याक्टिस गर्दैछ भनेर। प्र्याक्टिस नगरी के खाने त नि भन्छु मैले। सबै राजनीति गर्ने मान्छेले एउटा काम चाहिँ गर्नुपर्छ, एउटा पेसा लिनुपर्छ, ताकि उसले त्यो के भन्छ इल्लिगल कमाइ गर्न खोज्दैन, हो कि होइन? त्यसैले काम त गर्नु पर्यो। बरु हामीले त बरु चाहिँ सदनको काम, मन्त्रालयको काम टाइम स्केड्युल बनाएर, टाइम क्यालेन्डर बनाएर गरौँ, ताकि हामी आफूलाई अर्गनाइज गर्न सक्छौँ। टाइम क्यालेन्डरको कुरा गएको हाम्रो पार्टीको मान्छेले भनेको कुरा सबैले नाइ भनिदिए। आखिर त्यो क्यालेन्डर राखेर सबैलाई फाइदा हुन्थ्यो। तर हाम्रो राजनीतिक संस्कार यस्तो छ कि एउटाले राम्रो कुरा भन्यो भने त्यो अर्को पार्टीको भने अर्कोले नाइ भन्नै पर्छ। त्यो पार्टीभन्दा माथि हामी देशको लागि उठ्नै सकेन हैन। त्यसकारण यस्तो कुराहरू एक रातमा परिवर्तन नहोला। तर घुस खाने मान्छे एकजना भए पनि कम भयो नि त म हैन। त्यसमा एकजना पनि कम भए राष्ट्र हैन। मैले त घुस खाँदैन नि, मरेको ठाउँमा अर्को भए खान्थ्यो कि हैन। एउटा मुख त कम भयो नि। त्यसकारण बिस्तारै चेन्ज होला। त्यो चेन्जको लागि मैले धेरै बोलिराख्नु पर्दैन। र चाहिँ मैले डाक्टर रुनाजले भनेको कुरा धेरै कुरामा म पनि मलाई चाहिँ कहीँ न कहीँ हाम्रो स्क्रिनिङ यो क्यान्सरको कुरा गर्दा चाहिँ यो स्क्रिनिङ प्रोग्रामलाई एकदमै इफेक्टिभ र मस्ट गर्नुपर्छ। राज्यले त्यो बेहोर्नुपर्छ। जस्तो सुर्तीजन्य अघि नै भन्नु सुर्तीजन्य पदार्थमा ट्याक्स बढाउनलाई किन सरकार चाहिँ कुइँ गरिरहेको, उठाएकै ट्याक्सको खर्च गर्न सकेन भन्छ कुरा गर्दाखेरि चाहिँ हाम्रो विष्णुदत्त डाक्टर साहब यहीँ हुनुहुन्छ। तर बढाइदिने नि त्यो पैसाले गरिब जनतालाई निःशुल्क उपचार गरे भइहाल्यो नि। त्यो चुरोट खानलाई चाहिँ माया गर्ने, रक्सी खानलाई माया गर्ने, अनि त्यो गाउँमा मर्न आँटेको मान्छेलाई माया नगर्ने हुन्छ त? त्यो हुनु भएन नि त। त्यसकारण त्यस्ता आवाजहरू मैले पहिले पनि बेसरी पनि उठाउँछु मैले। त्यसकारणले उहाँले भनेको कुराहरू प्याथोलोजिस्ट मात्रै होइन, हाम्रा चिकित्सकहरू, म अहिले भर्खर प्रसुति गृह अघि पुगेर आएको थिएँ बिहान। प्रसुति गृहमा मैले काम गर्दा पनि त्यत्तिकै लोड थियो। हेर्नु न हाम्रो काम गर्ने स्टाइल। वर्षको 26,000 देखि 28,000 त डेलिभरी मात्रै हुन्छ हैन। अरू गाइनीको कुरा छोडिदिउँ, सर्जरीको कुरा छोडिदिउँ, ओपिडीको लोडको कुरा छोडिदिउँ। अब त्यो अनि त्यही दरबन्दीमा त्यहाँ डाक्टरले काम गर्नुपर्छ हैन। 40 वर्ष अगाडिको दरबन्दी अहिले पनि छ। त्यसरी भएन नि त। चिकित्सकले आफ्नो पेट भर्नलाई 5तिर दौड्नुपर्छ। र दौड्छ त दौड्छ, त्यसपछि गाली पनि सबै उसैले खान्छ, पिटाइ पनि उसैले खान्छ। त्यो सिलसिलाको अन्त हुनुपर्छ भनेर हामीले भनेको। उसको काम मोनिटरिङ गर, उसको इमान्दारितालाई मोनिटरिङ गर। तर के भने उसले पाउनु पर्ने चिज त पाउनु पर्यो नि। चिकित्सक भन्नाले मैले सबै स्वास्थ्यकर्मीको कुरा गर्दैछु मैले। त्यो कुराहरू गर्नु पर्यो। अरू अब हाम्रो चाहिँ ड्रग्सको कुराहरूमा हामी चाहिँ औषधिमा हामी चाहिँ आत्मनिर्भर कहिले हुने हो, त्यसको गुणस्तरलाई कहिले गर्ने हो भने त हाम्रो केम्सनको हाम्रो अध्यक्ष हमाल सर हुनुहुन्छ यहाँ, उहाँहरू जस्तो यङ मान्छेहरूले काम गरिराख्नु भएको छ। तर कहीँ न कहीँ हाम्रो कोअर्डिनेटेड अप्रोच हुनुपर्छ। मैले अघि नै भने नि, हामीले उठाएको राम्रो फटाहरूले उठाएको कुराहरू चाहिँ सबले त्यो सोसल मिडियामा सेयर गरेर भाइरल बनाइदिन्छ। हामी इमान्दार मान्छेले राम्रो कुरा उठाएको छ, तर कसै हाम्रो डाक्टरहरूले सेयर गर्दैन। डाक्टरहरूको बारेमा म बोलिरहेको छु, एउटा डाक्टरले त्यो सेयर गर्दैन। भन्दैछु मैले तपाईँहरूलाई, तपाईँको प्रेसर नभइकन सर राज्यले सुन्दैन क्या, त्यो हाम्रो बानी लागिसकेको छ। त कमसेकम राम्रो बोलेको मान्छेहरूको त तपाईँलाई त्यो ठिक लाग्छ भने सेयर गर्नुहोस् न। त्यसले राज्यलाई प्रेसर क्रिएट, मेरो आवाजले मात्र हुँदैन, म तपाईँलाई भनिरहेको छु। त्यसैले न त त्यही भ्रष्टाचार रहन्छ, भ्रष्टाचारलाई फालु भनेर भ्रष्टाचार विरुद्धको घन्टी बजाउन आएको नि, कुशासन विरुद्धलाई घन्टी बजाउन आएको नि म जस्तो मान्छे, न त किन महँगाईको विरुद्धमा आएको नि, हो कि होइन, गुणस्तरीय शिक्षाको लागि आएको, गुणस्तरीय स्वास्थ्यको लागि आएको भनेदेखि त्यो कुराहरू त तपाईँहरूले पनि साथ दिनुपर्छ। मैले देखेको राम्रो कुरालाई तपाईँहरूले पनि साथ दिनु पर्यो। त्यस कारणले डाक्टर रुनाले भन्नुभएको सारा कुराहरू मैले नोट गरेको छु। रुना डाक्टर साहबसँग र हजुरहरू कसैले पनि सम्झिनु, म जतिखेर पनि आउँछु। मैले जब आफ्नो पेसा छोडेर म राजनीतिमा जान्छु भनिसकेको छु नि, म जतिखेर पनि म हिजो पनि त्यही चन्दा थिएँ, आज पनि त्यही चन्दा हो, भोलि पनि त्यही चन्दा हुन्छु र तपाईँहरूसँग मिलेर काम गर्छु। तपाईँहरूको आवाज म बन्न चाहन्छु, जसले 5 वटा जनतालाई भए पनि सुख होस् होइन। मैले गरेर 5 वटा जनतालाई सुख भयो भने नि मैले म राजनीतिमा गएको चाहिँ सफल भयो भनेर सोध्छु। म धेरै यहाँहरूको समय नलिकन फेरि पनि नयाँ वर्षको शुभकामना दिँदै आउँदा वर्षहरूमा हामी सँगै काम गरेर यो देशमा का जनताहरूलाई सुखी बनाऊ भनेर म चाहिँ फेरि यो कन्फरेन्स गर्नेहरूलाई बधाई र धन्यवाद दिँदै तपाईँहरूसँग बिदा लिन्छु। थ्याङ्क यू।
Thank you, ma'am, for your thought-provoking yet delightful words. It was truly a deserving speech to round up today's event, and thank you for agreeing to be with us on such short notice. Next, I would like to ask the Treasurer of ACPN, Dr. Richa Pandey, to welcome our new life members. Before that, I would like to ask our guests to take their seats on the front row.
Good evening, everyone. Namaskar. I'm Dr. Richa Pandey, Executive Committee member. Would like to give an update on life members of ACPN. We would like to congratulate all the new pathologists on the floor and our dear members. Thank you for being the life members. You can all enjoy the privileges of ACPN. We have total of 101 new members till now, as listed here. Please feel free to obtain your certificates from me. Thank you. You can.
Ladies and gentlemen, we are now almost at the end of today, and what better way to wrap up a day like this than with music and dancing and an enchanting performance. The first performance is a religious Bhairav Kali dance. For those who are unfamiliar with it, Bhairav is a form of God Shiva and Kali, his consort, the goddess Durga. So please, put your hands together for a holy, no pun intended, electrifying experience by Nepal Dance Academy. What an experience. Please, ladies and gentlemen, once again, a huge round of applause for our performers. Now, carrying on with the same energy, let's welcome our next group of performers dancing to Jhauri Magar beats originating from Magar communities of Nepal. Ladies and gentlemen, be prepared to be thoroughly entertained. And once again, put your hands together for Nepal Dance Academy.
खुशी भाँचो सोल्टी जिउ
Now that is what I call a show. What an absolutely vibrant performance. Hats off. Once again, ladies and gentlemen, please let's show our appreciation with another round of applause. Now, as our performers are preparing for the next stage, I want to take a moment to extend my thanks to the event organizers and all those involved in making this program a success. Their hard work and dedication has made this event possible, and it has been an honor to work alongside them. I would also like to thank our guests and participants for their outstanding contributions. It has been a pleasure to hear from each of you and to witness your expertise on display. Lastly, I would like to thank you, the audience, for tuning in and being a part of this event. Your support and engagement has made this program even more special. As we wrap up, I hope you have enjoyed today as much as I have. Now, moving on towards the final performance on a high note, we have once again performers from Nepal Dance Academy dancing Dhime Dance, the dance of Japu Newar communities. One last time, ladies and gentlemen, let's welcome the absolutely scintillating team from Nepal Dance Academy with a big round of applause. Since it is taking a little while for our dancers to prepare, I would like to apologize for the delay. But again, they say that good things come to those who wait. So thank you for your patience.
सबैजनालाई फेरि नमस्कार। कल्चरल सांस्कृतिक कार्यक्रम गरेको हुनाले र चाहिँ डाक्टर रुनालाई मैले अघि नै भनिसकेँ, डाक्टर रुनालाई हामी सबैले सेल्युट गर्नुपर्छ। डाक्टर रुनाले एउटा गीत गाउने मान्छे को छ भने बाथरुम सिङ्गर त सबैजना भइहाल्छ नि। हामी तारा देवी हुन सक्दैन हैन, अब तर चन्दा कार्की भएर बाथरुममा गाइरहेको यहाँ गाइदिन्छु मैले चाहिँ है। र चाहिँ तपाईँ म मात्रै गाउँदिनँ, तपाईँहरू सबै मसँग गाउनुपर्छ। यो चाहिँ लाइफको फिलोसफी के हुनुपर्छ भन्ने गीत हो। र अब नेपाली गीतहरू धेरै छन्, माया प्रीतिको गीत लाएर यहाँ सबैलाई बिगार्न भएन। त्यस कारण तपाईँहरू सबै मसँग गाउनुपर्छ। सानो 2 लाइन गाउँछु, डाक्टर रुनाको इज्जतमा हो यो चाहिँ है। तर चाहिँ के भने हामी सबैले चाहिँ लाइफलाई कसरी कम्प्लिकेटेड बनाएको छ नि आज हैन। हामी के सोच्छ के सोच्छ कि आई डोन्ट नो वाइ वी थिङ्क अल दोज थिङ्स। तपाईँ सिम्पल लाइफ गरेर काम म त एउटै फर्मुला छ मेरो जिन्दगीको, काम यस्तो गरौँ राति मस्त सुत्ने गरेर क्या। रातिको निन्द्रा डिस्टर्ब भयो भने गडबड हुन्छ क्या सबै। तपाईँ टाउको ठाडो पारेर बोल्न पनि सक्दैन गलत काम गऱ्यो भने, अनि अर्कालाई गाली गर्न पनि पाइँदैन। आफूले ठिक काम गऱ्यो भने सबैलाई गाली गर्न, सबैलाई ठटाउन पाइन्छ क्या। त्यो चाहिँ हो। त्यसैले लाइफ चाहिँ सिम्पल हुनुपर्छ। ल मसँग सबैले गाउनु है। मेरो नराम्रो स्वरको लागि माफ पाऊँ, मैले आँट गरेर मात्रै हो। जीवन हाम्रो सङ्लो पानी हो, जीवन हाम्रो सङ्लो पानी हो, सलला राजै खोला झै बगाउँ सलला, सलला राजै खोला झै बगाउँ सलला। जीवन हाम्रो सङ्लो पानी हो, जीवन हाम्रो सङ्लो पानी हो, सलला राजै खोला झै बगाउँ सलला। माया रोपौँ माया गोडौँ, माया नै उमारौँ, माया रोपौँ माया गोडौँ, माया नै उमारौँ। सबको ओठमा चोखो मुस्कान चारैतिर बाँडौँ, सबको ओठमा चोखो मुस्कान चारैतिर बाँडौँ, चारैतिर बाँडौँ। जीवन हाम्रो सङ्लो पानी हो, जीवन हाम्रो सङ्लो पानी हो, सलला राजै खोला झै बगाउँ सलला, सलला राजै खोला झै बगाउँ सलला। थ्याङ्क यू। तिमीहरूले मैले गाएसँग मसँग गाएन, त्यसैले भनेको। म त यो मेडिकल फ्रेटर्निटीको मान्छे, स्वास्थ्यकर्मीहरू र देशको लागि सच्चा भक्तहरूको साँच्चीकै माया गर्छु। तिनीहरूको लागि म जे पनि गर्न सक्छु, तर तिमीहरूले पनि मैले गरेको काममा जे पनि गर्न सक्नुपर्छ। त्यस कारणले चाहिँ फेरि मैले यो 2 लाइन गीत गाउँछु। मैले जस्तै तिमीले पनि माया लगाई हेर, नमेटिने चिनो मेरो मुटुभित्र कोरा। मैले जस्तै तिमीले पनि माया लगाई हेर, नमेटिने चिनो मेरो मुटुभित्र कोरा। थ्याङ्क यू।
Thank you so much, ma'am. That was truly wonderful. I am very sorry for the delay, but now, as promised, please, ladies and gentlemen, let's welcome Nepal Dance Academy. That was truly amazing and a very fitting end to a day like today. Now I'm sure all of us have worked up an appetite, and it would be a crime to keep you all from your dinner anymore. Please proceed towards the garden for the dinner. And not just dinner, we have a surprise performance from popular names in the performing fields. Lasata Joshi, Bikram Thapa and team from LJ Entertainment singing a medley of beloved songs for yours truly. We'll see you tomorrow. And a last minute reminder, please do not forget to bring your lunch coupons tomorrow. Thank you.